Yeah. No.
Good morning, everyone.
Morning, sir.
Morning.
Morning, sir.
Morning. Thank you, everyone, for joining. Sanjeev, sir, you have the copy of program.
Hi, Vikram.
Good morning, sir.
Morning. Good morning to you. I know, unfortunate circumstances, I would have loved to be Trivandrum.
Okay.
So we start at 10. Do we start at 10?
Yes, sir. We start at 10. Gurmeet, can you get Dr. Pankaj Chaturvedi in? He is not
Sir,
able to.
I requested him to be panelist.
Yes,
He will
yes.
have to
Thank you
accept.
so much.
Okay, okay.
Yes, sir. Good morning, sir.
Good morning, everyone.
Morning, Pankaj.
Hi, Sanjeev. How are you?
I'm good. How are you?
I'm fine. Thank you. Vikram bhai, सब बढ़िया?
You?
Sir, बस चल रहा है.
बढ़िया.
Good that you could join.
Yeah.
Good morning, sir.
Hi, Abhishek. किधर है? घर पे है कि इधर? अस्पताल?
Hospital.
Oh,
Morning, Pankaj, sir.
hi, Vijay. How are you?
I'm fine, sir. How are you, sir?
I'm fine. Good to see friends at least virtually.
Yes, sir.
Vijay, all well?
Yes, sir. How are you, sir?
I'm good. You're yet to keep your appointment with me.
Yes, sir. Yes, sir. I know. I'll do come, sir.
It's like easier for Pankaj to come and come to Bangalore than for you to come to.
Acha, Vikram, while all of us are here, what I was
Yes.
thinking that American Head Neck Society has, and also MSKCC have been trying to do some joint program. So I was just thinking the AOMSI, FHNO, and either MSKCC or AHNS, whoever desires, we can have some postgraduate teaching programs.
Yes, sir. I think we can develop a series, sir. In that way, there will be continuity. Is that you have in mind?
Yes, so sometimes MSKCC, tomorrow it can be say Hisham Mehana group, say any other group is willing to, say British maxillofacial group. So we are not saying that we will only have one particular partner, but postgraduates, they love to listen to newer ideas, newer thoughts, some outside view. So that exposure will be very good. So we restrict to oral cancer in AOMSI joint symposia, but for FHNO, AHNS or FHNO, MSKCC, we can have institutes. Say once we can have like last time AIMS was there. Next time site care can be there. Then you can have any other hospital who is willing to lead as in do the local organization, case presentation, case collection, broadcasting, all that kind of thing.
Yes, sir. I think good idea. we can discuss offline and
Yes.
get it going.
So that AHNS thing I had forwarded you, maybe you can reply to that.
Sure, sir.
Yeah.
Sure.
Okay.
Thanks, sir.
Neeti, is it? Good morning.
Yes, sir. Hi, good morning.
Morning.
Hi, Niti, how are you?
I'm good, sir.
Oh, nice.
I'm a little intimidated to talk on oral cancers in front of you, but
Sanjeev, she's talking about you.
good morning, Dr. Nair.
You have the entire panelists are totally accomplished and the best that I can see, and I'm sure that you contribute a lot. So it's wonderful.
So Niti, our career is almost coming to fag end now. The future belongs to all of you. So
Yeah,
we are all proud
exactly,
of you.
Pankaj. I was going to say that. We are all
Yes.
fading away.
So
Like
one
the-
of very senior Fhno faculty member circulated one paper saying that you are most productive in 60s to 70s as surgeons. So I don't think, Pankaj sir, you are very, very young.
No, sir. See what I'm telling you, Vikram, that yesterday I went to the theater, and what I realized, the youngsters are more knowledgeable. They know newer things much more than any of us, and that knowledge is the energy. See, for us, our times are frozen. Surgically, we are good. Networking wise, we are good. Technically, philosophically, spiritually, whatever you may call it, we are good. But knowledge wise, these guys are, abreast with whatever is yesterday. And for us, I have to listen to their symposium or this journal talk. So we are not able to keep pace with the knowledge.
Very true. So 10, should we start?
Yes.
So welcome everyone to Fhno conference, virtual again this year. And we are very happy that we could host this Fhno AMSI symposium again this year. Really want to thank the AMSI leadership for supporting this symposium at the Fhno conference. So we have both mix of AMSI and Fhno faculty leading this symposium. I'm sure it's going to be a great symposium. So with this, let me invite our chairperson, Dr. Sanjeev Nair. Dr. Sanjeev Nair needs no introduction to this audience. A leading figure in maxillofacial and oral oncology field from Bangalore. He has an international presence in both AMSI as well as the international body, and has been a dear friend to me personally and to Fhno. So over to you, sir.
Thanks, Vikram. I'm really, unfortunate that I couldn't be in the place where I trained, Trivandrum, which is now known as Thiruvananthapuram, which was the place where I trained my entire UG and postgraduate education. So it's really unfortunate about that. But yeah, I'm looking forward to seeing how best to see how we can circumvent these times and we can go through these times. And I would look forward to a good session at the moment. I think Vijay starts with the session. Vijay.
Yes, sir.
I think we'll just kickstart the session. So Vijay is also very well known to me, and Vijay is one of the, one of our stars in the specialty in oral cancer, and Vijay has done a lot for the specialty. Vijay works in the Majumdar Cancer, Majumdar Shah Medical Center in Narayana Health City, and I know Vijay very personally, and Vijay is a person who has done a lot of work in head and neck cancer, and it would be very interesting for us to listen to what he has to tell us about the diagnostic tools for detection, because that's been a very controversial topic, and it's really going to be something that we need to really decide on how to take it forward, how to uh, detect cancer, because we all see it day in and day out, but we have never been able to do it. Vijay, on to you, please.
Thank you, sir. And it's indeed an honor, and I'm humbled extremely by the magnanimous words that you used. And I would like to thank the FHNO Governing Council, Vikram sir, Pankaj sir, for again hosting this joint symposium with the AMSI and the FHNO. It's truly
Vijay, just a minute. Let me just welcome the other chairperson, Dr. Rajshekhar also is there.
Sure.
So welcome, sir. Please go ahead.
So it's indeed an honor that the two specialties are meeting together at the national meeting and having a joint symposium. So I'll share my screen and start off with the presentation. So the topic that was allocated to me and I was asked to discuss today was about the newer diagnostic tools that are in vogue currently for the detection of pre-malignant diseases and early oral cancer. So my discussion today would basically be about two parts. The first one would be just looking at what are the current modalities, and the second part would be most of the work that we do at NH in terms of pre-malignant diseases and oral cancer. And actually, this is one of the focused areas of interest of Moni sir. So his lab has done a lot of work. So I thought I'll just give a brief overview of the work that we have been doing. I don't have any disclosures and of course no conflicts of interest, except that we happen to be co-investigators on most of the studies which I'll be talking about today. So the background of pre-malignant diseases and early oral cancer comes from the fact that we have a global prevalence of almost around 1 to 5%. And the tools are quite vast. The armamentarium is quite extensive in terms of the adjuncts. So it's important that we have good tools basically to classify these as benign or pre-malignant diseases, which would need appropriate treatment based on established guidelines, or whether we can categorize them as into ones which are at a very low risk and could basically be on close surveillance. So essentially adjuncts fall into two categories. It can be either diagnostic or it can be screening. The screening ones would be the ones which would be applied to large populations, and the diagnostic ones would be the ones which would determine whether the patient needs to go in for a biopsy and then subsequently need line of management based upon the biopsy. So the whole problem that comes in with these diagnostic aids is that patients come from very remote settings. So our diagnostic adjuncts need to be sort of customized to resource settings, which can be low resource versus the high resource settings. Can we get a tool which would be a point of care rather than having it to go to the lab before eventually we come to a diagnosis? Would it be patient or clinician driven? Cost is a significant factor because we talk about settings which would be the primary care, the secondary and the tertiary care settings. In addition to that stratification, whether we can have a high and a low risk stratification, predict which are the ones which would have a malignant transformation. And these tools should be such that they give us a robust sort of a pattern by which we could refer them to other centers for definitive management. And of course, they need to be based on evidence to show that they could be a point of diagnosis. Now, broadly, the current ones which are in vogue are the visualization aids, the vital staining, cytopathological, and salivary. The most commonly used ones are the visualization and the vital staining, which I'll just briefly talk about before going on to the other aspects of this presentation. Now, essentially here, when we look at the various visualization adjuncts, we have what's called as optical biopsy. So it's basically something like a real-time point of care, and it depends upon the tissue characteristics. Essentially, the pre-malignant diseases would have some bit of tissue characteristics in terms of absorption, in terms of reflectance, refraction, scattering, fluorescence. Many of them would be low cost and portable. So they basically utilize either some form of staining, like in case with chemiluminescence with acetic acid and then tissue reflectance, or basically the vascular changes that would have got incorporated like in narrowband imaging, or with fluorophores where they have the FAD and the NADH molecules and autofluorescence. Now, these can be narrow field or they can be wide field, depending upon the target area of interest. So the wide field ones are the ones which I had mentioned, and a combination of two can actually then localize which would be the appropriate area from which a biopsy would need to be done. So essentially, when we look at it here, the narrow field, the wide field ones are the fluorophores, the vascular changes, the chemiluminescence, and the narrow field ones are the ones which have got high spatial resolution, like in vivo microscopy. So basically, that's confocal and high resolution microendoscopy. Spectral ones, which basically give a variation or a graph of spectral plots, and of course, computed tomography. Now, the essential thing here is that the narrow field ones tend to be more specific when compared to the wide field ones. They in vivo microscopy actually shows you subcellular features, and spectroscopy shows spectral plots. Now, the importance of all this is that we are comparing these with the gold standard, which would be histopathology and which would be the diagnosis that is given by the pathologist. So looking at these tools, can they be employed in low resource settings where you would not have healthcare facilities remotely, whether we could? Diagnosis is going to be the challenge. Among the wide field ones, we have got tissue reflectance, basically extrapolated from cervical cancer, wherein there is going to be staining with acetic acid and then chemiluminescence. But across meta-analysis, it's got a very low sensitivity and specificity. It's almost in the range of 72 and 31%. So it's not recommended to be a diagnostic tool. So ideally, it should be combined with toluidine blue, and thereby increasing the specificity to around 81% and bringing it up to the sensitivity to 69%. But currently, it's not recommended. Autofluorescence has got a lot of work done, and even at our center, we have been working on autofluorescence. So a combination of blue and white light, 400 to 450 nanometers, excite the fluorophores which are naturally present within the tissue, and then basically categorize them as those which have got retained fluorescence and those which have got loss of fluorescence. It needs to be quite techniques specific and sensitive again here, and the operator needs to be quite trained, because the problem comes in with the confounders, the false positives, which could be as common as lichen planus. It could be like erythematous candidiasis. And also in the Indian population, when there's a significant amount of use of tobacco, betel nut, the debris there could also be a confounder here. Non-inflammatory vascular changes can also give quite a significant amount of false positive results. But when you compare it with vital staining, the sensitivity and specificity is much more higher, almost in the range of 90 and 72%. Having said that briefly, going on to vital staining, the ones which are currently in vogue are basically toluidine blue and lugol's iodine, which have a fairly high sensitivity and specificity. And rapid, low cost. The advantages, most of them are going to be quite cheap modalities. But again, here the problem that comes about is that there's not much data in terms of the widespread use. And of course, there's limited literature and the efficacy could be doubtful. So having said that, there are a lot of FDA approved agents, which come under these four broad categories of the visualization adjuncts, the ones which are going to be using some form of chemiluminescence, the ones which are going to be vital staining, cytopathology, and salivary testing. But there is a lot of ongoing work and research in this field to make most of them become a point of care tool, basically commercialize them, and then, of course, convert it into something which can be used by the masses. Now, the second part of my presentation basically would be a lot of the work that is done by our research team, and I would like to acknowledge the work and the contributions that they have made. So if we look at the current available diagnostic and imaging techniques, we have vital staining. It can be with toluidine blue, lugol's iodine, then fluorescence and OCT. So the basic tenets remain the same, that early surveillance and detection when you compare it with the gold standard of biopsy. If you can get a high-grade lesion identified, it basically downstages the disease and make sure that the outcomes are much better. Whereas a low-grade lesion could, of course, be definitely kept on follow-up. So having said this, if we look at the whole spectrum of society as at the availability of healthcare, it would be at a primary, a secondary, and as a tertiary setting. So the requirements of each would be different. So the primary would be where we want to screen large populations. It needs to be something which can be low cost and simple. it could be one which has got a good sensitivity, and it should be a point of care tool. For a tertiary, we would be one which is looking at something which is more specific, and again a point of care, and it's got a reasonably high sensitivity and specificity. So it all started out, I think, in 2015 with the work which was done by Dr. Praveen Birur, wherein they thought that why not use the smartphone as a very good diagnostic tool. And it's basically something which is easily available, accessible to all. So just click the images and then see how the images, whether it could be translated into something which was being captured accurately. Could that form a referral base or a triage to divide between the early ones and the highly suspicious ones? So this was basically done, and the data was also published subsequently. We had two cohorts here, a targeted cohort and the opportunistic cohort. So the opportunistic was basically the dental surgeons, and the targeted cohort were the frontline health workers. And basically, this was just a pilot study which was being done. And then when they did this, they found that the diagnostic accuracy in terms of identifying the premalignant lesions, it was almost 100% when it came to the dentist. So with the clinicians, when they were using the mobile phone as a smart tool, as a tool, as identification or as a screening, it was almost 100%. In a frontline health worker, it was 45%. So basically, the study came out with some points, essentially that the health workers required definite training. It was difficult to take intraoral images with the phone. And of course, you would probably need specialists who would need to be present more remotely. So automatically, the next tenet that came in could be, how could we improve on this? So could we get in other imaging modalities, and could we get in automation? So the next work which was undertaken by the team was whether we could design something like an intraoral probe and look at whether artificial intelligence could also be incorporated into this. So combined with the University of Arizona, they used a dual modality imaging technique, both images captured with white light and with the fluorescent one. So basically incorporating the existing principles which are already present, and get in a neural network. The neural network algorithms would then look at the scanned images and then decide and sort of recategorize them into those which would need further referral or biopsy, or whether it could be kept on a close follow-up. So the on-site specialist diagnosis was considered to be the gold standard. Now, they found that again here, when you had the images which were captured, so the dual imaging system definitely showed much improvement here with both the white and with the green components here, the blue and the red and the green components. The blue was not significant, again with autofluorescence coming in. And of course, the neural network was trained, and then of course with suspicious and non-suspicious lesions could be categorized. So basically it improved upon the sensitivity and the specificity, almost coming to about 89%. Subsequent thing would have been to validate this in the field study. Now, the field validation was the next step of combining a dual modality imaging with artificial intelligence based point of care detection for early oral cancer and pre-cancer. Again, this was funded by the NIH, University of Arizona, and also from the Biocon Foundation. And the goals were similar to what I just mentioned, whether we could use a dual model device, which was quite a compact one. It just had a probe, which used both the white light and the autofluorescent one, and also the algorithm incorporated, which would be, of course, once the images were uploaded onto a cloud-based platform, and to delineate the accuracy. So this is basically how the probe looks, which has got the mobile phone also incorporated into it and the light source. And the real-time images were captured, both from the white light and of course the showing here where the loss of fluorescence in the case of squamous carcinoma. So essentially here, when this was done, the frontline health workers were sort of educated on the use of this probe and to capture the images, uploaded onto the cloud platform, and then seen by a remote specialist. And also it was the other arm was wherein an artificial intelligence based diagnosis was done. So what I would like to draw your attention to is this chart here, which showed that when you had artificial intelligence present, it almost raised the diagnostic accuracy to brought it to about 88%. So from the initial one, which was just 81%, where the images were being captured, with AI incorporated 88%, and almost comparable with that would have been seen by a remote specialist 92%. Of course, just a frontline health worker would be 70%. So this brought in just the basic thing that yes, images combined with artificial intelligence done remotely could be a point of care tool. And of course, that would definitely improve upon the sensitivity and the specificity. This basically gives the outline of how the whole study was done. The next point which was important was to look at whether we could get something at secondary health centers, get in a chairside point of care. And this is where we thought we could get in the principle of the abnormal glycosylation that happens in normal cells, and lectin being one of the markers here. So when lectin got tagged on, it was again improving upon the fluorescence. This was done with the University of Minnesota. And they found that the uptake in the tumor cells was almost about 6 times higher when compared to normal. So it was, of course, initially an ex vivo imaging. And this almost showed 100% sensitivity in cancer when it was validation that was done in chairside. So this is something which could become a point of care at the secondary center, wherein lectin staining correlates with the transforming of the disease. Again, in case of pre-malignancy, we have it almost around 81% sensitivity and specificity around 82%. For tertiary health centers, of course, what would be ideally a tool or a point of care would be something like an optical biopsy. So the whole concept of using OCT was brought in here. Of course, OCT is not something which could be interpreted without having a diagnostic algorithm, because it's always going to be upon the interpretation of how the images come with regard to the basement membrane, the interface within the epithelium and the connective tissue. So the probe, of course, is quite, it's a bulky instrument. So it's not something which could be used in a primary or a secondary center, needed more like a tertiary one. And of course, here also the algorithm was developed based on the pilot study with image analysis and the scoring developed. Now, the basic thing that was shown was that there was a loss of stratification that could be seen as it progressed from normal to squamous carcinoma. So the optical characteristics were very good at delineating the presence of disease, and it was based on the depth result intensity plots. So the region of interest, the flattening was definitely seen as it was moving dysplasia and from normal, and there was a deviation of basement membrane. So again, this required that AI needs to be incorporated into it. And with AI, of course, it could correlate with a definite transition from normal to pre-malignant diseases. So when you compare it with oral squamous carcinoma versus dysplasia, almost it was a sensitivity of around 100% and specificity around 95. And in differentiating high grade versus low grade dysplasia, it was almost around 80 to 79.8%. The last part of this was whether cytology could be a good tool for oral cancer diagnosis. And again, just by doing a brush biopsy, the cells were collected, conventional cytology was done, images were captured, and then with the Indian Institute of Science, the cell scope, and with Siemens, this instrument was used, wherein the scanned images were actually reviewed by two pathologists remotely. And the basic thing here was that cytology would not have any specific diagnostic criteria, and there could be inter-observer variation. Artificial intelligence again brought about much more sensitivity here, made it almost come to the range of 93%. And in high-grade lesions, almost a specificity which was around 100%. So coupled with molecular markers, this could again improve the diagnostic accuracy. So the cell scope, which was used basically for telemicroscopy, used the same parameter which I just mentioned. And currently the basic molecular markers that are in vogue, which have been initially identified from the cluster, were SNA1, then CD44 and cyclin D1. So whether molecular cytology, so combining these markers and validating it by immunocytology to detect high-grade dysplasia and squamous carcinoma could be used as a point of care tool is the current ongoing research. So this was, of course, validated in 3 phases, with first a review of literature and selecting the markers, and then 4 markers which were validated in a much larger cohort, and then eventually into using cytology, because that would be a point of care tool. So the current stage of development is, as we have moved from conventional cytology, we have moved on to oral cytology with AI, and of course improvising it with getting in molecular markers. The Last thing which I would just want to mention is about the work that's being done by our center in terms of using PARP, which is polyadenosine diphosphate ribose enzyme. And this has been also identified, this along with the unit at MSKCC, as a molecular imaging tool with the fluorescent imaging. And we have found that there's a 3-fold increase in dysplasia and a 5-fold in tumor. So whether a PARP based cytometry can be used to develop a platform is the current focused area of interest. So this is something which eventually should hopefully translate into something that can be used for screening of high-risk patients. I would just like to mention the work because most of this comes in from the research team at NH, from Professor Moni's lab, Dr. Amrita Suresh, Dr. Praveen Birur, Dr. Samsam, Dr. Boni, and all the other research faculty at DSRG5 and the fellows and faculty of our head and neck service. Thank you very much.
Thank you, Vijay. Very, very profound and very interesting uh, advance in terms of what we always have been flummoxed with in terms of diagnosing and in terms of finding out if it's possible to arrive at a conclusion about it, especially with field cancerization. I think we will stick to the total discussion at the end of the all the lectures. Is that okay with you, Vikram? If he...
Yes, sir. Rajshekhar, sir, if he has any comment, we can take his comment. Otherwise, questions we will take with the panel.
Yeah, so I think Rajshekhar can introduce the next speaker. If I would invite Rajshekhar to introduce the next speaker. Is Dr. Rajshekhar there?
Yes, sir, you are muted, sir. Rajshekhar, sir, you are muted.
राजशेखर आवाज नहीं आ रहा है.
It's okay.
Hello.
Yes, sir.
अभी बराबर आ रहा है.
Yeah. I request Dr. Abhishek Mahajan to come out speak on imaging of oral cancers, focusing beyond the obvious. Welcome, Dr. Abhishek Mahajan.
Thank you, sir. Share my screen. At the outset, I would like to thank the Fhno and Dr. Vikram and Pankaj sir and Sanjeev sir and Rajesh sir. I'm going to speak on, am I audible?
Yes, sir. Audible.
My screen is visible. So the topic given to me is imaging in oral cancers, focusing beyond the obvious. And I think we have certain newer research outcomes which we will discuss in this particular talk. I would be focusing on neurovascular bundle involvement grading system, which we've come at Tata Memorial Hospital, and its impact on outcomes in tongue cancers. The different kinds of bone involvement in buccal CA and in its impact on outcomes in gingival-buccal CAs. Prediction of radiological extranodal spread and its impact on outcomes in patients treated with radical CTRT. Pulmonary metastatic workup, when to do and how to do, and to do it in a cost-effective manner. And the introduction of NIRATES, that is the post-operative imaging, and its impact on outcomes in post-therapy follow-up of oral cancers. Over the past 1 decade, I think we've seen this common key imaging parameters and their impact on the management. And I would not go into the details, but important ones to highlight is the depth of invasion, which is the current predictor of T-stage in oral cancers. And at the same time, extrinsic muscles were taken off. However, masticator space and ITF involvement, which also predicts T4B disease. So we came up with the 3 years back, and now tomorrow we will be releasing the this synoptic reporting, which is a mobile-based app, and this helps into the NNM stage on radiology automatically using the mobile and the web-based app. So what happens in early tongue cancer is you have a very small tumor, and actually per se it does not need imaging, because most of these patients undergo elective neck resection and tumor is palpable. However, if the assessment is done and the T-staging has to be done, the depth of invasion, which is the current concept, should not be confused with the tumor thickness, which most of the radiologists would otherwise give, the tumor thickness. It's very challenging to measure on imaging, especially in early tumors. And there are no clear-cut guidelines as to which plane and which imaging should be used for it. So mostly in buccal CA, as we described in our paper, that the depth of invasion should be measured on a coronal section with puff cheek technique. And in oral cancers, that is the tongue cancer, you should do it again on a coronal plane in the post-contrast images. So what is a tumor thickness, which is the mediolateral extent, should not be confused with the depth of invasion, which is actually the deeper part of the tumor, which is invading the below this submucosa. So radiological depth of invasion is usually it upstages. It is close to 1 to 3 millimeter larger than the pathological depth of invasion. And we saw in our data that the concordance rate of histological depth of invasion in early tumors was mostly upstaged on the T1 weighted MRI, and on the T2 even it was even more. So we always recommend using a contrast enhanced T1 weighted sequence for assessing the depth of invasion. The upstaging is more common in tumors less than 5 millimeter, that is the early T1 cancers, where there might be a role of intraoperative ultrasound, which can help into better prediction and planning the management of these patients. In the higher volume tumors, which are the larger than 10 millimeter, the concordance is close to 95%, which is better than the T2 weighted sequence. And it is again recommended that T1 weighted contrast enhanced MR should be used for assessing the depth of invasion. When the tumor is larger, it's not only that the larger tumors will undergo a conventional resection. There is a chance that these tumors are having something which might lead to positive margins in the deeper side. So the concept of conventional versus compartment resection was explored. And here what we tried to look was that when the tumors are larger, is there any factor which is leading to recurrences, or there is any extra finding on imaging which can predict the management of these patients. And what we found was that the neurovascular bundle involvement was one of the significant factor in differentiating assessing outcomes in T3s and T4s. Not all T3s and T4s behaved identical. Some T3s were behaving like T4s and some T4s were behaving like T3s. And what we found was that this classification of neurovascular bundle, where tumor more than 5 millimeter away from the neurovascular bundle, you could safely call it as not involved. Within 5 millimeter of the neurovascular bundle, again, it showed outcomes similar to the category 1. However, the category 3 and the category 4 neurovascular bundle pattern of involvement showed poorer outcomes in T3 and T4 groups. They were the ones who had a shorter DFS, and they even showed close correlation to LVI and TNI in these cases. The nodal they had higher chances incidence of nodal metastasis. So we recommended that the neurovascular bundle should be assessed on imaging, and this became a part of our routine synoptic reporting format. And we've now started reporting neurovascular bundle grades in each case. In advanced tongue cancers, patients might require prior to surgery an NACT. And what are the predictors of giving NACT? Apart from the neurovascular bundle involvement, large volume diseases crossing midline, reaching up to the vallicula, involving the hyoid, are certain factors apart from the age which can help into selecting patients for neoadjuvant chemotherapy in tongue cancers. So again, we are coming up with the classification where we are assessing multi-compartment involvement, such as sublingual, submandibular space, and distance from hyoid, which would be soon in publication. And this would guide whether these patients should be given NACT or not. And the preliminary result shows that the patients who have these cancers who are close to within 5 millimeter of the hyoid bone have poorer outcomes even after NACT, and the other patients should not be selected for neoadjuvant chemotherapy if the tumor is within 5 millimeter close to the hyoid bone. Coming to the buccal cancers, again, these are the common factors which every surgeon wants to know: involvement of the infratemporal fossa, type of bone involvement for planning the mandibulectomy and resection, and perineural invasion, whether infranotch or supranotch, whether to consider patient deemed for radical surgery or not. Again, we have a synoptic reporting format for these patients, and this is available on the app, which we will be sharing tomorrow. But apart from this, what extra we can do beyond this routine parameters which we look for on imaging? I'm showing here early buccal CA, and the patient has paramandibular disease, no obvious bone involvement. Patient would require, on the imaging, we would document the height of residual mandible, and patient might undergo a marginal mandibulectomy, and the mandible can be preserved. However, in larger tumors where there's a deep cortical involvement, usually segmental mandibulectomy is done. And if there's a larger extent of mandibular involvement, then even hemimandibulectomy may be performed in these cases. But this is not the routine. We studied the patterns of bone involvement, correlating whether the superficial versus deep versus marrow involvement has any impact on the management, and are they similar, or do they behave similar or differ in terms of outcomes. So what we found was the deep cortical involvement was behaving similar to superficial cortical involvement versus no cortical involvement. So hence, like, having even deep cortical involvement would be having similar outcomes, which was at OS and PFS, as compared to the superficial. So currently, deep cortical involvement is considered as T4A, and we found that it was not behaving something similar. They were behaving something similar to T3 cases. When we compared deep cortical involvement versus marrow, we saw a significant difference in the outcomes, and the ones which had marrow involvement were showing poorer outcomes. And when we compared mandibular marrow versus the mandibular canal, the inferior angular canal, there was no significant difference in the outcomes. So hence we have this again this paper under publication, and where we are proposing that the deep cortical involvement should be removed from the T staging, and proposing this, and we are proposing that only marrow and mandibular canal should be considered as T4A, and these are based on our results from the outcomes. In the advanced GBS cancers, where there is extensive involvement, every surgeon or every clinicians want to know whether the infratemporal fossa is involved, and whether this patient should be considered for any neoadjuvant or should be deemed as palliative if there is extensive infratemporal fossa. But not all, in fact, this was based on Liao et al.'s paper, the high infratemporal, the supraNotch disease leading to poorer outcomes. And all the infratemporal fossas are considered, any kind of high infratemporal fossa, that is the supraNotch disease, is considered as poor outcome. So this has multiple compartments. There are 3 different compartments which we saw in when we did this again this particular research. We found that there are 3 compartments: the retroenteral compartment, the muscular compartment, and the neural compartment. So the 3 compartments were divided. That is the infratemporal fossa was divided into category 1, which was low infratemporal fossa, that's the medial pterygoid. The compartment 2, which was the retroenteral compartment. The compartment 3 was further divided into 3 compartments: the muscular, the perineural, and the paramandibular compartment. And what we found is that the retroenteral compartment patients behaved similar to no infratemporal fossa involvement. So if you're documenting high infratemporal fossa disease and it is in the retroenteral space, you can safely call them as low infratemporal fossa disease, and they should not be considered as inop, or they should not be subjected to neoadjuvant chemotherapy. However, the muscular compartment showed better outcomes in comparison to the perineural compartment, the pterygopalatine fossa compartment, and they had the p-value was also significant. So we subgrouped that the patients who had pterygopalatine fossa and perineural disease were the ones who would have disease progression even after giving neoadjuvant chemotherapy. We can see over here that the patients who were in compartment number C, that is the perineural compartment, either had a significant number of patients had disease progression, and the p-value was significant. In the compartment 2, who were subjected to neoadjuvant chemotherapy, predominantly 90% of the patients responded to or remained stable and were having good biology. So compartment selection can also guide biology of the tumor and even response to neoadjuvant chemotherapy. And hence we have proposed this classification. Again, we are in process of publishing this work. Last work in the area of this particular oral cancer, we thought we would go beyond again the N0 versus N1 and marking the angle of the contact and planning the surgery beyond that. So we looked at the radiological E&E, and we thought to explore this whether when the patients are treated with radical chemoradiotherapy, whether we can add any benefit of assessing the radiological E&E when the path E&E is not possible in these patients, as they do not have neck node dissection. And what we found was the patients, this was subset analysis from the nimetuzumab study published by Kumar Sir's group. And what we found was the patients who had were negative on imaging for E&E showed better outcomes as compared to the patients who had positive RE&E. And they showed this trend both on OS, DFS, and LRFS. Then coming on to the pulmonary metastatic workup. We did this analysis of over 836 patients who were subjected to CT thorax as their pulmonary metastatic workup, and we found that T stage had no impact on predicting the incidence of pulmonary metastasis. However, patients who had higher end stage and had lower jugular nodes were ones who had higher incidence of pulmonary metastasis. So the lower jugular node involvement and the end stage, which is N1 versus N2, or N1 plus N2 plus N3 versus N4, were the ones who had higher incidence of pulmonary metastasis. This was even showing a significant p-value on multivariate analysis. Apart from this, we found that even an NCCT, that is a non-contrast CT, is an adequate cost-effective tool for assessing the pulmonary status, and only less than 0.2% of these patients had extrapulmonary metastasis without pulmonary disease. So PET can be avoided if judiciously used in these cases. Apart from this, postoperative imaging, NIRADS is coming up in a big way, and NIRADS is a postoperative neck reporting database system where you document the category of the category on the basis of the imaging findings, and you give recommendations, link recommendations. So our group assessed NIRADS in Indian population, and when we applied NIRADS, and we found that 100% accuracy of NIRADS category 1 was seen with patients who were negative for disease, and a very good correlation was seen in NIRADS category 4, and even all the classes, the accuracy was more than 70%. And the performance was even better for our NIRADS in neck node cohort, where the accuracy was close to 90% in category 3 and 95% in category 2. With that, I would say that the imaging plays an important role in staging and beyond, and depicting infiltration of the hidden areas, deeper extension, which has indispensable role in planning the management. And introduction of synoptic reporting can be the first step in standardizing reporting lexicon, allowing effective communication between radiologists and the MDT. I thank my team at Tata Memorial Hospital, especially Kumar sir, Pankaj sir, Anil Dikrus sir, and my team, Dr. Shreya, Dr. Ujjwal, and Dr. Navnath, and Dr. Himangi for this work. Thank you very much for the patient hearing. Any questions, I'll be happy to take.
Thanks, Abhishek. That was a very comprehensive and excellent presentation about what we are always flummoxed with, as a surgeon, on what to do and when to do kind of situation. So I would move on to the next presenter. We would take questions at least at the end of the entire presentation. So Dr. Neeti Kapre Gupta is a consultant head and neck surgeon from Nagpur. She has done her MS and DNB in ENT. She's a fellow in the head and neck oncology in Tata Memorial Hospital. And it also says that she's accomplished speaker and person who would be telling us about the management of trismus with and without cancer, which is one of the biggest problems that we face in Asia today. About that, Neeti, on to you.
Ma'am, unmute yourself, ma'am.
I'm so sorry. I bring you greetings from the Tiger capital and ashamedly also the OSMF capital of the country, Nagpur. Oral submucous fibrosis related trismus or trismus without cancer is graded according to the interincisor distance and the appearance of the mucosa. So grade 4 is worst with less than 1.5 centimeter mouth opening. And 4B is when there are potentially malignant or carcinoma in situ changes. Tried methods of treatment include medical management, physical therapy, and surgery. Although a myriad of medicinal agents have been experimented, the Cochrane analysis has found none to give appreciable or consistent results. Physical therapy, on the other hand, is an excellent modality to treat grade 1 and 2 trismus, and irrespective of the instrument used, perseverance pays rich dividends. Surgical candidature is restricted to grade 3 and 4 trismus with a strict prerequisite of abstinence from habit for at least 3 to 6 months to allow the mucosa and the soft tissue to settle down, and to ensure a motivated patient who is willing to give up on the habit and do rigorous physiotherapy in the post-op period. This is a short surgical video.
Can we have the volume up, please? The volume is quite low, the video.
Okay, sir. So we saw the anterior and the posterior mucosal cuts being made. The posterior was the sleeping T. The T of it was along the anterior process of the mandibular ramus, and the horizontal component was across the RMT and sometimes even onto the soft palate if the trismus is severe. This is the endoscopic picture where we are now exposing the tip of the coronoid by releasing all the muscles, especially the temporalis and the masseter and the medial pterygoid. Unless we do so, we are using an angle tip cautery for a better usage, but unless we do so, the pull of these muscles is so grave that the coronoid kind of flies up into the ITF, and then to retrieve it is a real hassle. So care should be taken to do adequate myotomies and release the coronoid from all sides, and then to initiate an osteotomy at the beginning with a fissured burr, like is seen in the video. And then completed with a chisel and a hammer. You can use an Allis or a Cocker's forceps to hold the tip of the coronoid and take it out. This is the picture at the end. The rough edges of the bone are being now drilled out by a diamond or a round burr. And these are the extractions. So last molar extractions and tips of coronoid. This alone will ensure an adequate increase in the interincisor distance. Always one should check for the mobility of the jaw and to rule out or immediately correct any dislocation of the TMJ. We do our reconstructions in non-cancer trismus with the platysma flap. This is an excellent flap which is based between the midline medially and the external jugular vein laterally. The size of the flap, of course, will depend on the size of the defect, but roughly a 6 by 3 centimeter flap suffices. The flap is now being raised in the subplatysmal plane and then is being delivered intraorally through a paramandibular tunnel. One should always avoid any torsion or twisting of the flap, and therefore these stitches are an excellent guide to ensure just that. After the intraoral delivery, the flap is then set into place, and this is how the picture looks at the end. This is a bilateral trismus being reconstructed by bilateral platysmal flaps. So our institute has been doing trismus surgery for almost 2 decades now, and the routine surgical procedure adopted is mucosal release, coronoidectomy, and reconstruction with the palatal or platysma like we saw in the video. Because in our analysis, we found that performance of coronoidectomy, good reconstruction, and jaw stretching physiotherapy compliance were the most important predictors for successful surgical outcomes. Coming now to trismus with cancer. Now, this can happen in 3 settings. So it could be with the background of OSMF. So sudden worsening of a pre-existing trismus and new onset symptoms are red flags. And with this wonderful research by Dr. Chaturvedi et al., we now know that it's actually a clinico-pathologically distinct entity. So stage match oral cancers, the one with OSMF actually fares better than the one without. Without background OSMF, it could be due to direct masticator space or ITF involvement, or it could be a result of treatment itself. So roughly the etiopathogenesis is tumor infiltration directly, surgical resection, radiation-induced trismus, disuse atrophy, or reflectory trismus. So afferent pain sensations and an efferent increase in the masticator muscle tone. Although there are validated questionnaires and trismus does form a very important quality of life evaluation in hereditary cancer, until very recently, it has been a fairly underreported entity. If we look at prevalence itself, it could range anywhere between 20 to 80% depending upon what population is being studied and what are the methods used to measure trismus. So in this Dutch study, the prevalence was 23.6%. But look at GB cancers, they were only 10% of their total patient data. Whereas in the TMH study, the overall prevalence was as high as 72.8%. This could be in part because of increased prevalence of OSMF in oral cancers in the Indian population at large. Be as it may be, we know that once trismus sets in, there is precious little one can do for it. And therefore, radiation oncologists and surgeons alike just want to shrug their shoulders and shy away from that question from the patient. What do I do about this now? More than anywhere else, prevention seems to be far superior to the cure. And one can prevent it if one knows what factors will predict presence of trismus after multimodal treatment. So adjuvant radiotherapy and submucous fibrosis are significant predictors. Type of reconstruction surprisingly was not statistically significant, although a word of caution remains because split thickness skin grafting still had the worst median IID. So it's maybe not just whether you do a free flap or not, but good case selection and good reconstruction for the appropriate defect, which is the most important. Anything above surgery, we know will significantly worsen outcomes of trismus. Radiation-induced trismus lies on the premise that a deliverance of certain critical dosage to the medial pterygoid and masseter will induce fibrosis and trismus, and any increase in dosage will cause an exponential rise in the trismus. But crossing this threshold is often inevitable in majority of cancers. So how can we circumvent this? Is by better radiation delivery techniques. IMRT and IGRT does have a significant impact in lowering the incidence of post-RT trismus. Yet patients at risk remain those who had higher dosages to masticator muscles and had a pre-RT mouth opening which was poor. bringing us again to the same thing, that before the patient actually goes for adjuvant, there is maybe something that we can do to prevent post-treatment trismus. Preoperatively, good assessment, extensive counseling to motivate the patient. Intraoperatively, leaving no devitalized muscle or soft tissue, doing good reconstruction. Ipsilateral coronoidectomies when a marginal mandibulectomy is planned, or contralateral OSMF trismus releases. And physiotherapy needs to be carried out throughout. Although a small paper, there were two groups in this study where they did an ipsilateral coronoidectomy in addition to a marginal and found that there was significantly lesser post-op trismus. We at our center have been doing contralateral OSMF trismus release at the same sitting for many years now. We do this, of course, after resection of the primary and adequate sterilization of the field. There was some debate as to the oncological safety, but we've seen that unless there is frank field cancerization, this fear is fairly unfounded. So as you can see, the left side is a bite resection with a free ALT. The right side was an OSMF trismus release and a palatal flap being put in. We've done over 90 patients so far, practically equal numbers free and pedicle reconstruction, almost everyone requiring a multimodal treatment. We believe in early oral hygiene, early oral feeding, and most importantly, very good pain control through tablets and mandibular nerve blocks in the early post-op period to encourage them to start physiotherapy. Of 83 evaluable patients, we found nearly 70% had consistent improved mouth opening with this contralateral adjunct procedure of OSMF trismus release. The significant factors, of course, were site, stage, reconstruction, adjuvant therapy, and jaw stretching compliance. Now, jaw stretching, like we said, should begin early post-op and continue throughout radiation. The 5-5-30 protocol can be followed. So 5 sessions, 5 openings and closings, and a 30-second stretch for each opening. There have been few RCTs, many of them company-driven, to evaluate which modality is better. But whether you use a terabyte or a wooden spatula, they've seen that no method is superior or inferior as long as you're doing it consistently and throughout the course of treatment. Because really, this is the make or break factor. If after a head and neck cancer treatment, you want a good disease-free survival, good quality of life outcomes, and a mouth opening something like this for your patient. This is the only surgical atlas for trismus surgery available, and I encourage you all to go through this. It's available on Amazon as a Kindle or a hardcover. Thank you.
Thank you. Thank you, Dr. Neeti. It was really something which, we all wonder how to handle all the time. So, like I said, we have time now, but then we would take all the questions at the end of the session. So we will go on to the next speaker. I would request Dr. Rajshekar to invite the next speaker. Yeah, so I think Dr. Rajshekar is not to waste time.
Hello.
Yeah.
Yeah, Dr. Girish. Yeah. You are invited to speak on mandibular invasion in oral cancer, its impact on treatment. Welcome, Dr. Girish.
Good morning, all. Thank you, sir. Thank you, Rajshekar sir, and thank you, Sanjeev sir and Vikram sir and everybody else, Pankaj sir. I'm trying to share my screen. One second. I'm trying to share my screen, but it shows a previous participant is okay. One second. Yeah. Okay. So thank you again. So I'm going to talk about the mandibular invasion in oral cancer and its impact on treatment. So we would look at this outline where the routes of tumor entry, the spread of cancer in the mandible, and the patterns of invasion that we see in the mandible. And look at assessing mandibular invasion mainly through different imaging modalities, and look at various types of mandibulectomies, the indications and contraindications of marginal mandibulectomy, and whether it's oncologically safe procedure, and the impact of mandibular invasion on oncological outcome and quality of life after mandibular resection. So this is something probably we would see more frequently over the last few decades, especially in the many decades of the previous century, that there was this classical commando surgery where it was thought that the lymphatics draining from the floor of the mouth and trunk would drain through the lingual periosteum and then to the neck lymph nodes. So it was thought to remove the neck lymphatic neck and do a neck dissection, do a mandibulectomy, and along with the primary tumor as all as one, and that would result in this sort of a defect. And especially for the surgeons of that era, primary closure would have become easier if they had to do it this way. But as you see on the right side, the standard of care now would be doing a microvascular reconstruction whenever feasible. So that's something we should look at. So what are the routes of tumor entry? In the literature, you would see that they've been mentioned about the tumor spreading to the upper surface of the mandible or the occlusal root, or through the different foraminas, or through the mandible, through the involvement of mandible, from lower border of mandible from a neck lymph node in the submandibular region, or also there are some cortical bone defects of the edentulous ridge, or through the periodontal membrane or the attached gingiva. Is there a preferential tumor spread? Is it along the bone marrow space, or along the occlusal surface, or the periodontal ligament, or the inferior nerve? Or if there is a previous radiotherapy, does that alter route of tumor entry and the pattern of invasion? So McGregor and McDonald in late 1980s had proposed this, that the tumor in a edentulous mandible would migrate from the floor of the mouth to the occlusal surface and would get into the mandible through the periodontal ligament. That they had put up this hypothesis. And in the edentulous mandible, it would migrate to the occlusal surface of the edentulous mandible, and through some micropores or dental pits that it would get into the mandible. So that was a theory which was thought about as the mode of tumor entry into the route of tumor entry into the mandible. But the Liverpool group, Mr. James Brown and his team have put together that the way of tumor entry into the mandible would be at the point of contact, or the tumor abutment. The point of abutment is what we say. So as you see in the edentulous mandible here, it is essentially through the junction of the attached gingiva and the reflected mucosa that it gets into the mandible. And in an edentulous mandible, the entry is more through the attached mucosa. So when you have a large paramandibular lesion like this, then there could be a possibility of multiple routes of entry into the mandible. So they had put this, that which is the point of abutment or the point of contact of the tumor to the mandible is where the route of entry of the tumor would be. So the TMH group at Mumbai also had looked at the invasion of mandible in GB complex cancers and the routes of tumor entry, and they had looked at the three possible entries. One is the occlusal way of entry, other one is the point of abutment, and multiple points of entries. And in their group, they had seen mainly majority of the tumors, more than 50% getting in through the occlusal route, and about 20-22% through the point of abutment, and few others with the multiple routes of entry. So they had put forward saying that oncological safety can be achieved by positioning the bone cuts corresponding to adjacent soft tissue margins in a segment mandibulectomy. So your segment mandibular cut can correlate with your soft tissue extension of the lesion, and more often than not, you are okay with the margins there. So what are the different types of tumor invasion? There are two main types, invasive pattern and erosive pattern, and there's a mixed pattern, which you would see both the components in its invasion. The invasive pattern is something which is known to be a very aggressive type here, where increasing size of the primary and the depth of invasion in soft tissues should indicate a possibility of infiltrative pattern of bone involvement, and also an increasing pathologic nodal status and presence of ECS, where significantly associated with presence of infiltrative pattern in bone. And Wong et al. Have actually looked at the survival in relation to the pattern of infiltration and shown that the infiltrated pattern was 30%. The disease-free, 3-year disease-free survival was 30% compared to the 70% in the erosive group. So does previous radiation have an impact on the way tumor would get into the mandible? Yes, the pattern of invasion is significantly impacted by radiotherapy. When there is an impaired bone formation, irritated mandible, that leads to an increased risk of direct extension of tumor into the bone. And that's where that's where no more often than not you would do a segment mandibulectomy in a radiated mandible. So this is just a picture. It's more mainly as a pre-prosthetic, evaluation of the residual mandible, which would post-extraction that you would see the amount of resorption, the absorption of the mandibular bone happens, and the change in the attached gingiva and the unreflected mucosa there. Similarly, on the right side here, this is the buccal aspect and the lingual aspect. You see the difference in the muscle attachment as the bone resorbs post-extraction of teeth. So how do we assess mandibular invasion? Where there are different methods that have been described in the literature, right from doing a good clinical examination or OPG X-ray, which is still used quite frequently in smaller centers where there is no facility of cross-sectional imaging. CT-MR remain the, I would say, the important tools of investigation for not only staging, but also assessing the mandibular invasion and mandibular invasion. And the newer techniques like this functional imaging like SPECT or the dental scans or the cone beam CTs also have a role, and periostal stripping, which has been described by the Liverpool group by Dr. James Braun, that also you will see. So the disadvantage with OPG is that there has to be at least 30 to 50% of demineralization required in the cortical bone for it to be visible on a radiograph. So that's the disadvantage. And also anteriorly placed lesion along the midline, there is superimposition of spine, because of which there is one would not be able to evaluate. But when combined with proper clinical examination and doing a OPG imaging would contribute to a good assessment, but the specificity was only less than 60% then. So as you see in this case, there's a gross, there's a large lesion there sitting on the mandible, and also a soft tissue component there you can appreciate. And the same thing can be appreciated in the OPG here. So this is this was a systematic review that was done recently, about a few years ago in 2013, where they have shown the different sensitivity and specificities of various imaging modalities that are used to assess mandibular invasion. So the CT MRI, CT has a low sensitivity, but has a very good specificity. It is easily available investigative modality in most centers that where there is cancer treatment happens would have these facility. And doing one imaging is something that most of us would look at practice, rather than doing a complementary imaging, whether it's an MR or a PET CT or a cone beam CT. So one has to look at what is the best imaging modality, considering certain patient factors and also the disease that is that question. So this is a systematic review comparing the CT that was done, that was looked at over a period of almost 27 years, and they looked at the CT had showed acceptable diagnostic value in detecting mandibular invasion. But this is something where whether it's to confirm, you also have to have proper clinical examination and assessment, and intraoperative assessment is what is imperative there. So MR, this was a systematic review and meta-analysis of using MR imaging for assessing mandibular involvement in oral and head and neck cancers. So it had excellent sensitivity when done, and but was left less efficacious in exclude patients without the mandibular invasion. So that had a lower specificity as compared to a CT scan. So this is again a systematic review that was done with both comparing the MR and CT modalities for mandibular invasion, and there was no superiority that was observed in diagnostic methods regarding mandibular invasion detection. So this is a periosteal stripping that has been described by the, as I told you, the Liverpool group, where at the time of surgery or just after resection, looking at the specimen and exploring the stripping the periosteum from the mandible and looking for any obvious erosion of mandible was also a good modality to assess. So it's again the review. Another, this is a systematic review which talks about CBCT having a good diagnosis as compared to for bone invasion, but it has a weak soft tissue contrast assessment. So that is something we'll have to look at, although there are not that many studies still for CBCT. So we'll look at the different types of mandibulectomy, segment and marginal mandibulectomy. Marginal mandibulectomy can either be a rim mandibulectomy or a reverse marginal or a sagittal or an oblique marginectomy. So this, as you see, a large lesion here on the buccal aspect of the mandible with a significant paramandibular disease. So this is the segment mandibulectomy that is done. And this is a case where, again, I'm not sure why the picture is not okay. So this is a marginal mandibulectomy that you see. What you have to ensure is that you leave behind the buccal periosteum, as for the, especially in edentulous mandible, that is a predominant blood supply for the residual mandible. And also the edges have to be curved, and you should avoid acute angles on your bone cuts to avoid the pathological fracture of the mandible when it takes the masticatory load. So as you see, the same thing being shown in the picture here. This is a reverse marginal mandibulectomy when there is a large nodal disease sitting in the submandibular region and abutting the mandible, or probably involving the buccal cortex. So you could do the reverse marginal mandibulectomy, and you can use a local flap to cover that effect. This is an oblique marginal mandibulectomy that you can appreciate here. So there is a lesion, there is a lesion that you can see here on the ventral surface of the tongue and the floor of the mouth and abutting the mandible. So you would place your bone cutting saws in an oblique fashion so that you get the entire lingual plate in your specimen. So what are the contraindications for marginal mandibulectomy, which actually would be the indications for a segment mandibulectomy? When there's gross destruction of cortical and cancellous part of the mandible, invasion of mandibular canal by cancer, massive soft tissue or a paramandibular disease on either side of the mandible, presence of tumor on the alveolar process of nervated edentulous jaw, you invariably do a segment mandibulectomy. And when there is a reduced vertical height of bone, especially in edentulous mandibles, you generally do a segment mandibulectomy. And what you look for when you do a marginal mandibulectomy is that the vertical bone height of the remaining mandible has to be at least 1 centimeter for it to take the masticatory forces, masticatory load without there being a pathological fracture. So this is just to show the same thing. So as I was telling you, to take this is the paper which suggests that at least 1 centimeter of vertical height has to be left behind when you do and whether is doing a marginal mandibulectomy, is it oncologically safe? Various papers have looked at into when you have when you're oncologically clear margins, doing a marginal mandibulectomy with just a cortical erosion, superficial cortical bone erosion, it is generally a safe procedure. And in cases where there is a requirement for, depending on the stage, there's a need for an adjuvant treatment, then adding adjuvant treatment will have good oncological outcome. So it's not just the tumor stage and resection margins that is what would amount to the oncological outcome, and not the mandibular invasion. And also there's a lot of soft tissue factors which have to be looked into for oncological outcome in relation to oral cancer. So just come to this one. So this is one important paper that has just come in this month's JCO, where they have looked at the possibility of sparing the mandible by giving neoadjuvant chemotherapy, and in about 47% patients that they could preserve the do a mandibular preservation surgery and avoid a segment mandibulectomy. So this is something that's to be looked at in future trials. If they can, that would amount to a significant functional and cosmetic outcome for the patients. So the quality of life after mandibulectomy, when there is an anterior arch mandibulectomy, that would have significant adverse outcomes on chewing and also on the swallowing aspects when it comes to the quality of life of the patient. So to summarize, the infiltrative pattern of invasion is a very aggressive variant that you should be aware of when you deal with mandibular invasion. And there is no preferred pathway of tumor entry. Tumor enters the mandible at the point of abutment, which is usually at the junction of the attached and the unattached mucosa. Then there's no preferential tumor spread along the named nerves in that location. And there is no one investigation which provides sufficient accurate data to predict safe invasion of mandible with tumor. And marginal mandibulectomy is oncologically safe, and the local recurrence is commonly a result of positive soft tissue margins and do not correlate with the method of mandibular resection. So that's something we should consider. So as much our effort should be that proper clinical examination, doing a good imaging modality, and doing a good ablative surgery, getting clear margins, and doing a proper reconstruction can avoid some of the post-treatment morbidity for our patients and improve their functional and aesthetic outcome, and thereby overall quality of life in their patients. Thank you.
Thank you, Dr. Girish. It was quite good, nice of you talking. And I request Rajneesh Kumar to speak on radiotherapy for the early oral cancer. Welcome, Rajneesh, for lip and buccal mucosa.
Good morning, colleagues. Give me a couple of minutes where I can share my screen. Good morning, everybody. I've been given a very specific area.
Sir, your presentation is not visible. Your email is visible. Can you please check again, share again? So, share again, unshare it and then share again.
Are you seeing it now?
No, sir, only the email is Yahoo mail is visible. Visible, sir, visible.
Is it okay?
Yes, sir.
Okay, thank you. I'm sorry for that. I'll be talking on a very specific area, focusing on the oral cavity, the lip and the buccal mucosa in this. It's not.
So just click on the PowerPoint just below tab next to Firefox. PPT. Yeah.
Going back to those. Okay. When you talk about oral cavity, early stage oral cavity cancers, you are talking about T1 and T2, that is stage 1 and stage 2 oral cancers. And to keep in mind, it should be a single modality treatment, either radiation or surgery, and not these together for early stage diseases. And the aim is cure, and we try to reduce the morbidity of the treatment as much as possible with our whichever treatment modality we have been choosing. The different factors which determine the treatment are the site of the disease, the functional outcome, the cosmosis, the morbidity because of treatment, of course, the expertise that is available, and not with the patient preference, which is of the most important decision which comes in. The definitive radiation in early stage oral cancer is either with brachytherapy or with external beam radiation. That is, but previously there used to be a lot of work being done with external beam radiotherapy with brachytherapy as a boost procedure. But nowadays, either it is brachytherapy or external beam radiation, which is mainly done given for early stage oral cavity diseases. On the left, you see an early stage small papillary lesion on the tongue, and on the right, you see the a lip lesion, which is like a T1 bar T2 disease. And it's a well-differentiated squamous cell carcinoma with a radiologic and an ultrasound proven negative nodal disease. The stage would be a T1 in the tongue lesion and a T2 in the lip lesion. And the management, both of these can be treated either with surgery or with radiation, with brachytherapy as a treatment of choice. Whenever you take any patient for brachytherapy, usually the histology would be a well-differentiated, most of these malignancies would be a well-differentiated histology tumor, squamous cell carcinoma, with a clinically and ultrasonologically proven node negative disease, a T1 or early T2 diseases. Usually we should be having a superficial disease. And the most important thing is that the patient should be willing for regular follow-up. A very close follow-up, at least monthly for the first 6 months, is what we consider as a very safe follow-up. The dose of brachytherapy that we use is either a 65 to 70 gray in low dose rate brachytherapy or an equivalent high dose rate brachytherapy. What we generally follow here is a 48 gray in 12 fractions, a 400 centigrade per fractions, 2 fractions a day for over 6 days continuously. After this, we put the patients on very close follow-up. Brachytherapy can be considered as a radium era, and then the HDR high dose rate era with iridium needles. Till around 6 to 7 years back, we also used to have radium needles, and I think we were probably one of the last sites where the radium needles were taken away. Radium needles were particularly used in for early buccal mucosal lesions and early tongue lesions. And very simply, we used to, under local anesthesia, we used to have a 2 milligram needle at the 2 ends with a crossing at 2 milligram here. So, and in between, we used to have 1.5 milligram needles. And the dose of radiation which was given was around 65 gray, prescribed at 0.5 centimeter from the surface over 5 days. The patients need to be in the ward for 5 days with the radium needles on. Now coming to the present day situation where brachytherapy we use now is with the iridium needles, and here we take it's an early disease of the lip, T1 disease. It's usually we do it under local anesthesia. We mark the tumor, Then we draw on the patient's lip where the route through which the needle has to go through, the tube has to go through, and then we give the local anesthesia. And usually we measure the tumor size, the area which has to be treated, and immediately post implantation there is a lot of edema. So before the CT scan or the imaging modality we use for doing the calculations, we give a 6 to 8 hour gap and then do that so that the edema reduces, and then the calculation is done, either CT based calculation or just an orthogonal X-ray based calculation. And once the radiation is delivered over 6 days, we see that there is a very little minimal mucositis that happens in the first 1 or 2 weeks, just around the tumor proper. And mind you, if it is a very pedunculated or a sessile growth which is seen on the lip, you need only to implant the base of the lesion rather than trying to cover the whole disease as such. The clinical outcomes of lip cancer treated with brachytherapy, all these shows excellent results with over 5-year local control rates of over 90 to 98% in all the series which have been published. And even 5-year overall survival is anywhere between 60 to 8, almost 90%. For a hard pellet lesion, I would definitely say that early without bone invasion, that is a T1 disease in the hard pellet, where especially in centrally located tumors like this, the HDR mold brachytherapy plays an excellent role, and it is one of the most satisfying results that we get with brachytherapy. What you use is a dental wax that we use as a bite block. We tell the patient to sit in a comfortable position. We put this dental wax as a bite block inside the mouth. We take a impression on this. Either we can keep a small amount of thick barium in this area, or even a permanent marker around. With a permanent marker, you can draw around that lesion, and then you take an impression. Then you place the tubes. The iridium tubes are placed inside the bite block at around 0.5 centimeter below the surface. And if it's very thin lesion or a very superficial lesion, we usually prescribe the dose to a surface dose. And if it is a little deeper lesion, then we prescribe it, depending upon the thickness of the lesion, we prescribe it to a cup 2 millimeter or 3 millimeter above the surface. That it depends upon where the thickness of the tumor. That is for brachytherapy in hard palate and the lip region. For buccal mucosa lesions, we have to be very careful in treating and selecting these patients for radical radiation. Those patients, centrally located lesions like this, verrucous lesions, they respond very well to radiation, and these lesions are amenable to radical radiation as much as they're amenable to surgery. These lesions, ulceroproliferative lesions, are also very susceptible for radiation treatment. But once they reach the gingivobuccal sulcus and the bone is involved, definitely we should reconsider them for surgery. These cases, I would go for a biopsy, routine X-ray chest, and ultrasound neck is what we would do in a clinically negative neck node. A CT scan only if there is any bone invasion that is suspected. There is no role for MRI or PET in these patients, where most of them go by a clinical decision. In a T2 buccal mucosa, the options again are single modality. Either it is external beam radiation of 66 to 70 gray, or an equivalent of hyperfractionated accelerated radiation, which I'll come to in a couple of minutes, or wide excision plus a supraomohyoid neck dissection plus or minus reconstruction. I'll show you a couple of photographs where early stage diseases which can be taken up for radiation, because these are ulceroproliferative growths, well circumscribed lesions without bone invasion or skin infiltration. These patients are also susceptible for either for surgery, or we can even give radical radiation in these patients with very minimal morbidity. All these patients can be taken up for surgery or for radiation. In this particular case, I put this because the lesion was extending from the commissure, and it was extending to the lower lip, and so it was extending to the lower lip, and so we had to cover the level 1A node also to be in the radiation field, and there was a little bit of extra mucositis in the lower lip covering this 1A region. So lip reactions during radiation are a little bit distressing, definitely, but post-treatment, the same patient had an excellent response with, of course, there will be a little bit of xerostomia, but all these patients are treated with ipsilateral wedge pair technique. So the opposite parotids are good enough to compensate for the xerostomia. And there will be a little bit of post-radiation skin changes, and dental prophylaxis usually is done for every patient before starting treatment. These are the post-radiation photographs showing a little bit of fibrosis and epilation. All these, the previous, the same photograph of the previous patients where the lesions were shown. And in our own unpublished data, which is undergoing review for publication, from patients treated from 2011 to 2016, hyperfractionated accelerated radiotherapy, this is a retrospective analysis in which 517 patients were treated using 2D planning using ipsilateral wedge pair. And a dose of 5250 centigrade in 15 fractions was used in all the patients, and we took patients in which the field size wouldn't exceed a 10 centimeter by 10 centimeter field size. At a median follow-up of 77.4 months, 473 patients had attained clinical remission in this in our observation. And you can see that the excellent overall survival of more than 80% in stage 1 disease. Even a few patients with minimal skin infiltration were taken up for radical radiation, and they also had a 5-year overall survival at 73.7%. Comparing our results with the previous papers where radical radiation was given, we have comparable results, especially in early stage diseases. We also did a pilot study comparing 2 external beam radiation therapy techniques, comparing 70 grain 35 fractions and 5250 centigrade in 15 fractions. In the initial pilot study, we had 30 patients in each arm, and the trend was definitely towards a better disease-free survival in the accelerated arm at 81.5% versus 50.6%. And even though it was a non-significant improvement, the complete response rate was 82.8% in the accelerated arm compared to 66.7% in the 70 gray arm. Same way, in the next study, we had included 38 patients each, in the same fractionation schedule, and this was published in the presented at the Asian Oncology Summit in Shanghai, in which 38 patients in each arm were taken up for radical radiation either in the 70 gray arm or the 5250 arm, and definitely in the complete response was much higher in the accelerated hyperfractionated arm with a significant p-value, and the recurrence or residual disease was also better in the hyperfractionated arm. At a median follow-up of 10.2 months, the 1-year survival we saw was 70 grain 35 fractions was only 54.7, and in the hyperfractionated arm we had a 76.9% with a significant p-value also. When we are talking of buccal mucosa tumors, even the role of IMRT in buccal mucosa tumors, where bilateral, in this case, it was a case of bilateral buccal mucosa tumor. And definitely, if the patient had to undergo surgery, it would have been a little morbid. So we discussed in the MDT and we took him up for radiation, and bilateral, both the buccal mucosa were, the lesions were contoured, and the region in between this oral cavity was given a dose of 40 gray, and a radical dose of 60 gray was given to both the lesions in the buccal mucosa. And the patient had very minimal morbidity, definitely with a certain amount of xerostomia, but the patient has complete response. And in CA tongue, unless the diseases are implantable, we would definitely say that surgery is the treatment of choice for all cases of carcinoma tongue, if not implantable. So to the role of definitive radiation in oral cancer, oral tongue in a T1 or T2 diseases, early T2 diseases, brachytherapy or definitely surgery, and exophytic growth, T1, T2 diseases, either you can do brachytherapy or external beam radiation and surgery. In heart palate, early disease in the heart palate, I would definitely say a T1 disease, or even an early T2 disease, the treatment of choice would be brachytherapy with minimal functional and very good cosmetic and outcome. And lip, even a T1, T2 lesion in the lip with node negative diseases, brachytherapy would be definitely the treatment of choice. And the TNM oral cancer, the 8th edition shows the overall survival, how it decreases with the stage of the disease. Thank you.
Thank you, Dr. Rajneesh. It was very comprehensive, and hello.
We are audible, sir. You are audible.
So it was very kind of comprehensive. So looking at the different aspects of what we have gone through from the beginning to the end, I think the way Vikram has put together the entire meeting, I think we need to have a white paper on how to actually tackle with the lesions that come to us. Now we have seen the disease from the surgical point of view, from the pre-malignant diseases, from the radiological aspect, and from uh, uh, every single aspect. And I think, Pankaj, what would be your opinion about this?
Yeah, I completely agree that certainly whatever we have discussed today, if we can encapsulate it and come up with a short perspective article, and I'm sure one of the journals can accept it.
It's a very good presentations, and Vikram, you have really managed to get the best speakers and the best things. So, do we go on to the panel discussion, or do we take
Yes, sir.
questions?
No, I
Because
think Pankaj sir can take relevant question during panel.
yeah,
So,
because I can't see any questions that come up on
yeah.
the chat panel. So, if any questions come up, we should be able to really, some of the most flummoxing decisions that we have are, which was presented by the second panelist about the second speaker about the mouth opening. Mouth opening is a really big problem, and whether you actually, how do you address it? I mean, you don't have a situation where you can actually surveil. Do you, what kind of investigations do you do? Do you, these are questions that I would have imagined would have come up in the panel, but I can't see any questions on the panel. So I'm asking the questions to myself at this moment.
So we have the panel to answer that, sir. Over to Pankaj sir, I think. Pankaj sir can start.
So maybe Neeti, you are there?
Yes, sir.
Yeah. So for the benefit of the audience who may be first time cancer surgeons for oral cavity, what precautions do we take following surgery to avoid trismus, which at some times can be more disabling than cancer itself?
True, sir. So, the slide that I put up, it's actually something that begins pre-operatively with counseling and motivating your patient to follow up on the post-op advice. Intraoperatively, it is about appropriate reconstruction. You may do an ipsilateral coronoidectomy with a marginal for a buccal cancer. And you may do something that we practice and have found very useful is a contralateral trismus release in the background of a OSM. So if there are tight bands and strictures on the opposite side, you may consider doing that adjunct procedure. And of course, physiotherapy early post-op and continues through the adjuvant treatment, extremely important.
So thank you, Nidhi. So Vikram and Sanjeev and Rajshekhar, I want to check how many of our panelists are here. Is Pranay Gaikwad here? Pranay? I don't see Pranay. Arvind?
Yes, I'm here.
So let me welcome Arvind Krishnamurthy, Shilpa Chatney, I can see. Bharat Rangarajan, I can see. Amit Dhawan is here. Nebu George is also here. Nishant Upadhyay.
He's not there, sir. There was a family emergency, so he's not making it. Yes, yes.
And let me start with my PowerPoint presentation.
And Sandeep Jain also, sir. He is the radiation oncologist.
Yes, Sandeep. I don't
He's
see.
there.
Hi, Sandeep. Sorry. So Sandeep is also there. And Abhishek, we will take your questions during this. So let me share my screen. Can everyone see this?
Yes, yeah.
Okay. So let me start by what Vijay Pillai very nicely presented about the early detection methods. So let me first go to Arvind. Arvind, having listened to Vijay, a very lucid presentation, this is a very common lesion that we see in our clinic. Now, how do you counsel the patient, and how do you treat the patient if you feel that treatment is needed?
Right. Thank you for having me. I think you've put up some data here about medical and surgical management. I just wanted to add that although in clinical practice, we may use some sort of medical management, especially a lot of data on vitamin A and beta carotene. If you see purely from the evidence perspective, and there was a very recent Cochrane meta-analysis to show that these doesn't work. These only work temporarily. Once you stop the medical management, these lesions tend to come back. But the more important thing is possibly to triage your lesions into low risk and high risk, and also based on the pathology perspective. But I would tend more to give more credence to the clinical aspect of the lesions. The location of the lesion, for example, high risk could be the tongue and floor of mouth, the size of the lesions, that is at least more than 2 centimeters, lesions that are there in women, lesions that are there in non-smokers, that is idiopathic lesions. And also, if at all there is a biopsy, the presence of dysplasia, of course, there is some degree of subjectivity with regards to the interpretation, but that is something that I would take into credence. And also the presence of, if there is any amount of redness, that is erythroplakia component of it. That is, so all those lesions are the ones that we would take up for surgery, and either of the modalities should be good enough.
Okay. Thank you so much, Arvind. In such a short span, you almost covered a book's content about management of the cancerous lesion. Now I move to Shilpa. Shilpa, I leave it where Arvind left. And Arvind left at a point that, yes, there are patients who are suitable for surgery. And the triage is done by clinical tools and done by the pathological examination. Now, once you are certain that this patient needs surgery, say, for example, this patient of a large white pad, do you do an excisional biopsy or would you do an incisional biopsy? Shilpa?
Yes, sir. Am I audible?
Yes, you are audible.
Yeah, I still think it is a homogeneous leukoplakia, but the size wise, it is close, coming close to 2 centimeters. So I still would go for an incisional biopsy from the most suspicious or a little thickish area. That is what would be my first step.
Perfect. So Bharat, Shilpa has done the biopsy, and the biopsy report is mild to moderate dysplasia. And the patient has come to you. He is not symptomatic. He doesn't have any problem. He incidentally detected while brushing his tooth. And this mild to moderate dysplasia is bothering him. How do you treat him?
I would just send back to the surgeon, sir. I would say exercise it completely, keep under follow-up with you. I would not offer any therapy for him from my side.
So
if there is mild to moderate dysplasia, I would send it back to the surgeon.
So now the patient goes back to Arvind, and Arvind has read the book and an article where any lesion more than 2 centimeter or nearly 2 centimeter, regardless of dysplasia, it is a Scandinavian study, Holmström 2008. It says dysplasia doesn't matter because of inter-observer variability, and therefore this patient may have malignant transformation. So I move to Arvind, this patient, if it is mild to moderate, in your practice, what would you do? Observe, medical, surgical?
As I said, in this particular lesion, it's more than 2 centimeters. It looks a little thickish in places. I agree where, as to what Shilpa had said, we take a biopsy, mild to moderate. If it is moderate, and as I said, the other factors also we take into consideration. So my feeling is it would sort of come into a slightly higher risk, considering the thickness and considering the size. Of course, the etiology is something that you would, there are all other soft indications, but more important is the thickness and the size. Of course, buccal mucosa being sort of a less low risk area. But I would talk to the patient and would be more inclined towards considering a surgical option. And this looks to be easily amenable to one of the surgical resections, be it laser or with or with any other modality, with the hot knife or the cold knife.
Amit,
can I just
please go ahead.
One of the things that we see is these kind of lesions are usually innocuous, and like Arvind very rightly said, the erythroplakic lesions are the ones that we need to be more careful of. So these are kind of hyperplastic lesions that appear on the mucosa. You can, like Arvind said, excise it. No, no harm done there. But then, what we need to really look out for are the ones which are erythroplakic.
Okay, I completely agree. Whenever there's an component, you have really worrisome trend that may follow. So, Amit.
Sir, I also, can I?
Yes, go ahead, Shilpa.
I also put him more on observation and advise abstinence and more of a regular follow-up than go for surgery.
Okay. So, Amit, this patient is now getting confused. Like doctors, some say surgery, some say medical, some they are not saying. Is there any way we can improve the triage where those who truly need surgery versus those who do not need surgery? So dysplasia is one. What about these vital dyes like toluidine blue or lugol iodine? Do you really use it, and what will be the indication?
Sir, as Dr. Vijay has clearly depicted, that there are multiple methods with which we can triage these kind of patients, but they have specificity and sensitivities at different settings. So none of the diagnostic methods is pathognomic of the disease. So as Dr. Arvind has also mentioned, it clearly is clearly dependent upon in our setting, it is clearly depending upon the clinical judgment and the index of suspicion, whether it is going towards the erythroplakic thing. And in most of these kind of lesions, it is field cancerization as well, because these lesions may be unifocal, or most of the times it is a diffuse process in the mucosa. And it is very important thing to understand here, because the diffuse process is most of the times it is there in the pre-malignant lesions. So mapping biopsies is also one of the things which we should consider, that taking multiple biopsies, and as you said, there may be a sampling error if there is mild dysplasia or moderate dysplasia. It is dependent upon the handling of the tissue as well, and there can be a lot of errors and biases in these kind of lesions. So mapping biopsy, I should say, should be considered. And if we have to, and the biopsy should be taken from the most suspicious area. And as far as if it is unifocal, then surgery has to be considered, and it has to be superficial excision. It has to be superficial excision, and as far as possible, cautery should be avoided because it can char the tissue. And even with laser therapy as well, because we need tissue for further investigation as well. So I would go for a knife in this cases, or maybe coupled with the cautery to for the hemostasis purpose. And this is my opinion on that.
So Amit, if I was as young as you and as patient as you, I would perhaps use knife. But given that we have good cautery and good current setting we can do and minimize the charring, I think cautery can be used. But you are absolutely right. It has to be a superficial excision. And if you ask me also how much margin we should take, I do not know, but 3 to 5, anything between 3 to 5. The reason is that there is a still small chance that it may turn out to be a carcinoma in situ or an invasive carcinoma. And then going in again, if you have just hugged the margins and not taken a good rim of tissue around it, can be a troublesome thing. So Nebu, we have just talked about excision. Let me complicate it further, because some of the students may be distinction holders and they need something more. There are studies which show that excision does not prevent malignant transformation, and that is based on the field cancerization that happen in these patients. That means the entire upper aerodigestive tract mucosa is condemned. That means what you are seeing as a leukoplakia is just tip of the iceberg. There are multiple molecular changes in happening at adjoining area. So Nebu, my question is that what should be the surveillance protocol for these patients, even if they have undergone excision?
I think these patients should be having a counseling regarding stopping all the habits.
Nebu,
And
you
then
can't
they
see
should
your face.
They should be, hello?
Nebu, you can't see your face. Yes.
Okay. I think they should be counseled first regarding stopping all habits. And if there are any dental issues that is causing a trauma, that should be taken care of. And then they should be kept on a regular follow-up, maybe 3 monthly for a couple of years, and then see if there is any worsening of the lesion that is happening.
So that is very important, that excision does not mean, or mild dysplasia does not mean that these patients should be sent scot-free. We have to follow them up, because there is a likelihood of malignant transformation despite whatever we do. So now, quick last comment by maybe I can ask Rajneesh. Rajneesh, while we are discussing about pre-cancer, can you just give us an idea whether photodynamic therapy still has a role to play, or it's just experimental? Rajneesh or Sandeep, anyone? Sandeep? Okay, so we can't hear them. So photodynamic therapy truly is experimental at this point. There is no proven benefit of using it. So we move on to the next case, and perhaps this is for Neeti. She's often sees them in the Vidarbha area where the submucous fibrosis is very common. So Neeti, you very nicely said that if there is a submucous fibrosis, then there are options of surgery, which include microvascular reconstruction and all those. In this patient, you can nicely see this band formation, and now this patient is highly symptomatic, and she has come to you. At what stage of submucous fibrosis, you intervene with some intervention, treatment, whether it is medical or surgical. So quickly, can you tell us the algorithm?
So, sir, medical management has really not found to be very useful. So I will try and refrain from that. But grade 1 and 2 trismus, I will start physical therapy and regular inspections for checking the mucosal status, SOS inspections if the patient develops new onset symptoms such as worsening of trismus and red flag signs. For grade 3 and 4 trismus, there will be a protocol to first refrain from habit at least for 3 to 6 months, ensuring that there is no potentially malignant or carcinoma in situ changes in the oral cavity. And once that is established, then we may offer trismus release surgery to such patients, a mucosal release, coronoidectomy, and a good soft tissue reconstruction.
Sanjeev, I just want to pick your brain, or Sanjeev, you are there? Sanjeev?
Sorry, I just muted myself. Yeah.
Okay. So Sanjeev, what's the role of intralesional, these triamcinolone acetate or hyaluronidase? Sanjeev, switch on your camera.
Yeah. So, basically, most of these things are placebos. I mean, some of them work, some of them don't work. We have had studies done by Dr. Andrade in I think 70s, who she really figured out that they do a little bit of improvement, but the most important thing that I find is, the classification that she gave was very significant. And from the classification, we can actually evaluate how to approach this particular problem. So, if it's a mild blanching of the mucosa that you see in the palate and in the that's where you see it. Uh, you can actually operate on it.
Okay. Rajshekhar, would you like to say something?
So, yeah. So, if you see a mild blanching, I think I'm losing the connectivity.
Yeah, we lost you in between, Sanjeev.
Yeah. So, if there's mild blanching, yes, you can try all these kind of medications that we use, like hyaluronidase or triamcinolone, which gives some amount of benefit with physiotherapy. But when it comes to a stage 3 or stage 4, then I think one of the things is losing evaluation or surveillance in these patients. And if we don't have surveillance in these patients, it's very important that we need to deal with that. And the way I do it in our team, we do it as bipaddle radial forearm flap.
Yeah.
So
Niti, you nicely summarized. Stage 1 and stage 2 is more conservative. Stage 3 and stage 4, depending on where the patient is and what capacity the surgeons have, we may plan surgery, but certainly grade 4, when it affects the nutrition of the patient, dental hygiene, oral hygiene of the patient, then certainly it is warranted. And there is no shortcut to doing this. You should achieve at least 2 to 2.5 centimeter mouth opening on table. And if you are not able to achieve that, then you have failed. And then microvascular reconstruction or nasolabial flap, or as Sanjeev said, that those are the ways. Now we quickly move to another complex case. So this patient is a 36-year-old smoker. So the star that I have put is the actual lesion from where the biopsy was done and it came positive. And in this patient, if you see that there is whitish patch all around. In fact, you can see blackening, whitening. So this is a very complex kind of lesion that sometimes we see. So let me start with Bharat Rangarajan. Bharat, if you see this patient where there is a lesion and then there is a surrounding dysplasia, or you may call it leukoplakia, how do you address this?
Let me be very frank. I rarely, address it on a personal level. I would definitely refer it to the surgeon, of course, for a biopsy of the, your starred area. In general, we don't get the biopsy of the dysplastic area as well. But the first thing would be to get a biopsy. I didn't see the biopsy report. I'm assuming it is
Biopsy is squamous carcinoma from the main lesion where the star is there.
Yes. Once that we have a biopsy of squamous cell carcinoma, usually if I am seeing, I would get a MRI of the involved organ, that is MRI of the face, covering the neck also, to see what the extent of the lesion is, and then discuss with the surgeon, on a possibility of surgery, because it's in the lateral border of the tongue.
Okay. So Arvind, how do you deal with this?
Yeah, I think it's a very difficult situation, but it is something that we often see in our clinics as well. Thing is that, as was mentioned, I think there is the concept of field cancerization that has already happened in a way. Like, you have a lesion, you have surrounding area, so you would sort of search for the entire aerodigestive tract for any other mucosal lesions or any other synchronous second primary. So that would be the part of the evaluation. And as Bharat said, yes, MRI to sort of, because you although you mentioned 3 into 3, it doesn't seem like, but I'm assuming that there is a component of the deeper component also. So I actually do an MRI also to exactly map the lesion. And also very closely, I think I would give a lot of credence to my examination under anesthesia when I'm doing it in the table. Like, of course, as was said, any adjunct say measures to see may not actually help. So you may consider to do something of that sort in case you want to actually see whether there is any other, say, skip sort of a lesion there, so that you'll have to be very clear on the margins of that particular region. Because if it is very thin, if it's just a homogeneous leukoplakia, I think you can be a little conservative on that margin. But supposing if you do have an invasive component elsewhere surrounding that area, you'll have to be really, really careful. So I would sort of give a lot of credence to my examination under anesthesia on table, and actually decide the final margins for this patient.
So Shilpa, when you are surgically excising this histopathologically proven cancer surrounded by dysplasia, do you go around the tumor with margin, or you include dysplasia area also in your surgical excision? Shilpa?
This is a very common situation in our field. So I would take adequate margins around the main tuber. And in this case, we can, it's just adjacent, and maybe a centimeter of more of the dysplastic thing is adjacent to the main tumor. So that part I would excise with lesser depth. I would excise it because it is not too wide that we cannot excise it. So I would definitely excise that, but with lesser margins, but take 1 centimeter margins around the main tumor.
So you are right that you have to be more liberal when you are dealing with dysplasia surrounding the tumor, but the extent, that means the deeper extent and the mucosal margin will be less aggressive compared to what you do with the tumor. And do you use frozen section intraoperatively? Because see, when we do the biopsy in the OPD, we go to the most suspicious area. Intraoperatively, suddenly you are faced with a larger area of resection. So do you think frozen section might help you?
So actually, in relation to the dysplasia, I don't think it will help much, because invariably we will find some amount of dysplasia in the margins. And I am not sure if we can really get in such a field cancerization. Apart from this one, at least it is little more localized, that whether we would get a margin which is negative of dysplasia.
Correct. So you are right that if you are having a good pathologist, he can only tell you whether there is a severe dysplasia or carcinoma in situ or carcinoma in your resection margin intraoperatively, which will save you from embarrassment when you are sitting in front of patient and then you have a margin positive. But again, let me go to Amit. Amit, for a moment, imagine Shilpa had done a wonderful surgery and she did the negative margins and everything. But one of the margin, the pathologist says that is having dysplasia. Now, once the patient comes with a report and there is something abnormal, then there is a worry. So how do you deal with positive dysplasia in histopathology, but Rest, everything is fine.
Sir, so at that point of time, I would like to counsel the patient and would tell him that dysplasia, if it is a mild dysplasia, moderate dysplasia, as and when we talk about the positivity of the margin, we talk about positivity and negativity of the margin, we talk about histological margins like with benchmark of about 5 millimeters. So if anything less than 5 millimeters, we take it as a close margins, like if it is 4 millimeters or 3 millimeters. In a recent study, it has come up to be something about 2.3 mm is the cutoff margin now, which we call it as a close margin. But if all other margins around the squamous cell carcinoma are free, I would like to leave it to the radiation oncologist and the tumor board discussion. We would like to either observe this patient, or if we are thinking about any adjuvant radiotherapy post-operatively, depending upon the main histopathology of the squamous cell carcinoma specimen, we will take the decisions like that.
Yeah. So Amit, before I move to the radiation oncologist, was one clarification about the 2 millimeter or 2.3 millimeter margin that everybody quotes about the MSKCC paper. Please understand that this is a retrospective study where they went ahead and took the 1 centimeter margin, but later there was a cohort of the patients where the margin was in tongue cancer around less than 3 millimeter, and then they found that these patients, they didn't do badly. The issue is that people went ahead with 1 centimeter margin, and it was a histological surprise to get 2 millimeter margin. So they didn't go with the 2 margin intention, because if people start going with 2 millimeter margin intention, some of them will become, half of them become positive in the histopathology. So when we have to be very careful that our margin has to be intraoperatively a centimeter. So Rajshekhar, we are discussing about these patients who develop dysplasia, who come with a report of dysplasia in the margins. How do you deal with this?
No, the given case is like, it's like, without trismus, where we are talking in length. If it trismus is added in such a case, how we are going to go about it is a big dilemma which we face often. This is one, because it's a clinically can be evaluated, can be biopsied, can be like, histopathologically evaluated. But as far as margins are concerned, I think we go according to the visualization of of the lesion, and we give that amount of margin. It may be centimeter or less than that.
Okay, okay. So we move to the next case quickly, not this one. We will go to this one because Abhishek, you are there? Abhishek Mahajan?
Yes, sir. Yes, sir.
So Abhishek, this is the kind of lesion that is very often a fleshy lesion sitting on the mandible. And many a times there is a debate whether to do CT scan or MRI. Can you quickly tell us when to use CT scan, when to do you use MRI?
So, sir, CT would remain a routine standard modality for assessing the cortical invasions when you are suspecting only deep. When it goes to marrow or when there's adentulous socket and the disease is creeping along the gingival surface and the socket is actually not having tooth in situ, then MR would be better than doing a CT scan, because you might not see a direct invasion. You may have a route of pattern which is along the gingival surface into the marrow, and their CT is suboptimal. So patients who are young, who have a dentulous mandible, CT is ideal modality. But if you have an elderly patient, mandible is eroded because of atresion and adentulous, their MR would be a better choice into assessing marrow invasion.
So Abhishek, the biggest concern that we have, once there is a marrow involvement, then there is a chances of horizontal spread, especially the perineural, or then there is a hollow cavity. How can you assist us in getting appropriate margin? Because I can't do frozen section on bone, and there is neither I can do palpation of the bone for margin. How can you assist in telling us what margin should be done?
So, sir, if you have done CT as a primary modality, then we would like to, as a radiologist, one should document the inferior alveolar canal involvement, whether the canal shows any erosion. and that would guide your perineural invasion. And second checkpoint, we'll look at the mandibular foramen, whether the fat at the mandibular foramen is maintained if you're not doing an MR. So these two checkpoints should be kept in mind: inferior alveolar canal and mandibular foramen. But to have an accurate assessment of marrow involvement, one should do a MR with contrast to see how much is the extent of marrow involvement. And I think once the deep cortical has not much significance. So if marrow invasion only becomes T4A, then MR would become the modality of choice for all GBS cancers, because then it will give you infratemporal fossa assessment better than the CT.
So Sandeep, if this patient comes with a biopsy proven CT shows bone involvement, what's the role of radiotherapy?
I think radiotherapy can be offered because of the chances of osteoradionecrosis if we do a radical doses over there. So it will be a case for surgery.
Bharat?
Sir, both the previous case and this case, none of the surgeons are saying that this is technically inoperable, because if it was technically inoperable, we'll definitely take it up for the neoadjuvant. But all these cases, irrespective of the lesion size, dysplasia, all the surgeons here are at least enthusiastic about, getting an MRI and going ahead with surgery, which is fine. But I would again not do a upfront chemotherapy or chemoradiation for this patient unless the surgery is contraindicated on medical grounds or surgery is impossible. It doesn't look so.
Perfect. So Arvind, when do you decide to do a segmental and when do you do marginal?
Right. In case we tend to do segmental when there is a gross destruction or erosion of the mandible as seen in this particular case, or involvement of the marrow, or there is an extensive soft tissue, that is a paramandibular spread. I'm very conscious that the Tatas, there is a paper from Devendra also, but till we have phase 3 data, we would possibly consider that aspect of that thing also to come under the ambit of segmental. And more importantly, as was said, I think the vertical height of the mandible has to be more than a centimeter. And post radiation setting, and in elderly patients, edentulous, you often tend to sort of go for a segmental mandibulectomy. In all other indications, when the tumor is actually very close to the mandible but not just abutting but not infiltrating, then there may be a case for marginal, provided that you're able to do this in a very proper manner, and the vertical height should be more than a centimeter or so.
Thank you. And last question I want from Vikram, and that will be the closing remark. Vikram, if we have done say marginal mandibulectomy, do you prefer a primary osteointegrated implant, or would you like secondary? And if you have done fibula, will the choice differ again?
So for a marginal, putting an implant and then radiating is just overkill, I would say. So we have to be really respect the remaining mandible. I would not do primary implant in a marginal case. But as far as segmental and fibula is concerned, then no problem. I think we should consider putting primary implant because it's a very good vascular bone. And even if we radiate such a reconstructed fibula with implant, there is usually no problem as long as the vascularity of fibula is ensured. So to answer it simply, marginal, I would be very, very cautious in putting the implants, but fibula, no issues.
Perfect. Thank you. So thank you, everyone. We have already exceeded by 1 minute. So I would like to thank Fhno, AOMSI, and all the participants who have really made it an interactive discussion. And over to Sanjeev and Rajesh and Subbu. I can see name of Subbu here. Subbu, are you there?
Next
Hi,
session.
Subbu.
Next session.
Thank you. So Rajesh.
Yeah. Okay. Yeah, I thank all the organizers and also my co-chairman, Pankaj.
It's been a wonderful session.
Arvind.
And thanks a lot.
Thank you, sir.
Thanks to Vikram and
Thank you,
his
sir.
team.
Thank you all the panelists also.
Thank you so much, sir.
Thank
you,
you.
Pankaj, sir. Thank
Good
you,
day.
Dr. Vikram.
Thank you.
So thank you everyone, particularly the AOMSI leadership for joining us for this session. Dr. Sanjeev, Dr. Rajshekhar, Pankaj sir, it was brilliant. You brought about all the points and definitely all the speakers. And your suggestion that we should get a synopsis of this session written and possibly published is welcome. And I think we should
sorry
take
to
it up.
interrupt, Vikram. Have a white paper,
Yes.
with Pankaj and all of y'all on the way we should go forward with the way we should deal with this kind of cancers.
So with your permission, can I request all the speakers to give their entire 1,000 word summary of their lecture, 1,000 word. So we will compile it into a perspective and take the editorial comments from Subramaniam Iyer.
I will see here.
Yeah, perfect. Thank you so much.
Thank you. Thank you.
Thank you. Thank you so much.
Thank you.
Welcome, Iyer sir, for your talk next session.
Yeah.
I will just see if the chairpersons are here.
Vikram, I am okay. Audio, video wise.
Yes, sir. Absolutely.
I'm sitting in Rameshwaram.
Dr. Elizabeth, you are the next chair. So, we can get started. We are just on time, 12:15.
Yeah.
So let me invite the chairpersons for this session. We have Dr. Elizabeth, professor from RCC Trivandrum, and Dr. Barua to chair this session. Over to you, Dr. Elizabeth. Dr. Elizabeth, you're there? I can see her, she's muted.
Yeah.
Okay, as she logs in, I will have this unique honor and pleasure of inviting Iyer sir. I mean, that's indeed an honor. Dr. Iyer does not need any introduction to this audience, but as a formality, he is mentor to many of the head and neck surgeons, reconstructive surgeons in the country, heads the Department of Head and Neck and Plastic Surgery at Amrita Institute. He is the founding member of Fhno, Governing Council Chair, and he wears leadership positions in various associations. So really a dynamic personality, and we have a very, very interesting talk on a unique subject this morning. Over to you, sir.
Thank you very much, Vikram. I'll just start off sharing my screen. Thank you very much. And then let me share my screen. Just tell if it has come. It has come, no?
Yes, yeah.
So let's start off. So my topic given to me was surgical perspective of management of carcinoma. First of all, I got confused because it has to be surgical perspective only mostly in a lip cancer, except in very few scenarios which I'll come to. So, but then the real meaning of the topic was, how do you go about the surgery? How do you reconstruct the lip with a less mutilating way? That is the way So my talk would be based on general principles in the management and method of reconstruction in general. See, lip is something which, if you look at the plastic surgery trainees exam and all, and you look at the books and journals and all those things, lip is something fascinating, fascinated everybody for ages. And if you look at the founding fathers of plastic surgery, there the whole gamut literature with the different names and all were in lip reconstruction. So we have been always been confused about how to approach these lip cancers. I've tried to make it simple and then thought process in a much better way so that we can apply clinically. So types of cancers in lip, there are only, I would say, mainly squamous cell carcinoma and basal cell carcinoma. Occasionally, you see minor salivary gland tumors like adenocystic adeno or mucoplasma, but generally squamous cell carcinoma, which is usually seen in the lower lip, whereas basal cell cancers are more in the upper lip. So 90% of squamous cell carcinomas appear in the lower lip and 10% in the upper lip. And usually it occurs in the red lip, I mean the red mucosal margin rather than the skin. And it is exophytic more commonly than ulcerative. That is the way you would see the lip, whereas the cheek lesions can be ulcerative than exophytic many times, where the lip is mostly exophytic. Basal cell cancers, as I told you, we see less in India, but they generally seem to be more in the cutaneous part of the upper lip. So when you see a black thing like this, you immediately think of a basal cell cancer. Now, how do you stage lip cancers? This is fairly common, and then you can say carcinoma in situ, 2 centimeters is T1, 2 to 4 is T2. This is a general classification. Where I don't think it is too much important between T1, T2, T3, T4. I would say T4 is different because there is a lot of associated involvement like bone and other things. Otherwise, the size is important because of the more than size alone, the position of the tumor is also important for us. So this must be good for basically for data collection and assessment and then oncological type of data analysis, whereas for real-time management and the reconstruction, the T1 stage doesn't help much in this lip cancers. Now, what are the investigations in there are two scenarios. One is this a small lesion like this. How do you go about, what do you investigate? I would say just do an ultrasound of the neck to see if there is a neck node. Highly unlikely, but you should do that just to rule out if there is anything. And then, of course, the pre-anesthetic evaluation. Many of them can be done at local. So even if their patient is hugely morbid, you would be able to treat under local anesthesia. In this big one, this is a big lesion involving the entire lip and different type of tumor, where you have to image for mandibular invasion, provided it is going into the sulcus, buccal sulcus. You do either a CT scan or MRI. That is up to you to decide. Most probably it will end up in a MRI scan for early erosion. And then also these scans allow you to help to find any nodal metastasis in these cases. Now, nodal metastasis to that matter is rare in lip cancers, 10% mainly in the submental area. Upper lip is very rare. It can be in the preauricular or periparotid area. And in the commissure, you have to expect that it's a level 1B sort of node in 20% of cases. So it is rare, so you can have an ultrasound or other imaging accordingly. And then addressing the lip also depends upon those the imaging modality. Treatment, I would say, that is why I told you the first statement. Surgical removal with 0.5 centimeter margin is the choice in most of the cases. Radiation therapy is okay in those cases where there's a high surgical risk. This was one of our cases where used a brachytherapy for a lip lesion. because of the morbidity, so-called morbidity of the total lip resection and reconstruction. And it was an exophytic lesion, inviting lesion for a radiation oncologist to treat. It can be external beam or brachytherapy. This was a brachytherapy catheter in place for our patient. So, but generally speaking, it is used very seldom. Now, what are the issues with lip resection? It can lead to oral incompetence. It can lead to the communication, deglutition can be a problem, communication motion, speech can be a problem. Labial sounds like b, ba, ma, those labial sounds and by labiodental sounds can be affected. So oral competence is the main issue. Speech is a problem, and then deglutition is problem because of the issue of the lip seal that is allowing to push the bolus down. So preservation of the function is very, very important, either by selective resection, I mean limited resection, whatever is needed, or restoration of the sphincteric action by your surgeon. And the most important thing is the reconstitution of this circular muscle fiber, which is the orbicularis oris, which is very, very important. And to me, this logarithm is not given much. I made it a very simple one: lip defect, small upper lip less than 25%, lower lip less than 30%, direct closure. This is very important. People just write direct closure in all the books and journals when you see the algorithm. I have added this sentence: direct closure with aesthetic approach and sphincter muscle reapproximation. I'll come to that. Intermediate one up to 50 to 60%. You can borrow tissue from locally from the opposite cheek, opposite lip, cheek or nasolabial area. Large is subtotal total, local tissue from cheeks, nasolabial area, regional flaps or free flaps. So this will simplify your thought process of lip reconstruction. And what are the things that are available for you is a remaining lip, opposite lip, adjacent cheek, combination of flaps, regional sides and distant donor sides. Now coming to, these are the different types of lower lip lesions which you see ranging from very small to total lip. And then less than 30%, wedge excision and closure. What is to be important? You can do a wedge just like that or a W type, whichever way you want. See, most important thing is this: align the, I told you about the two words, aesthetic restoration, align the white roads. That is one most important thing. Second one is this functional restoration of the orbicularis sphincter. So suture the muscle, take those, that circle is the orbicularis muscle on one side. Take a good bite of a good suture material. It can be Vicryl also, or you can use a PDS. Some people use a Proline and approximate it nicely with the opposite side. This will give you the sphincteric action. So this will allow you to get a very good sphincteric action and very good aesthesis in direct closure. Now, this is in the upper lip. How do you do it? Again, exactly same. You can do a wedge excision. Now, you can see the suture line that has gone into the nasal sill to some extent to get that contour right. So there also you look at the aesthesis, you look at the white roll, you can look at the alar rim, or the nasal sill, all those things. Now, sharing of the opposite lip. See, I have put my slides in a very, very descending or organized way so that you think of direct closure, then you go for local sharing of the lip and sharing of other tissues like that. So here, sharing of opposite lip. In the lateral part, it is the Eslander flap. Abbey Eslander principles are same. It is from the opposite lip, where the blood flow comes from the marginal vessel. Like there is an artery going all around the lip, and then you cut off one side, but the other side gives the blood supply. That's the principle. So this is a central part of the thing, which is an Abbey flap. The other one is an Eslander flap. So this is the way you put it. And now, how do you design it? How much size for Abbey? That's a common question and common practical issue. half the size of the defect is enough. The principle is that you don't need to reconstruct the entire lip. You can reduce that into half and then you can reconstruct. So center the pedicle in the middle of the defect so that it comes automatically into the ease of coming is much better, and divide the pedicle after 2 weeks. Now, this is another important thing for the upper lip. Again, as I told you, aesthetic thing. This same lip, you can use it. If you look at this resection, the peri-alar crescent is very important in upper lip concept. You know, the reason is that if you had cut it and pulled it together, the dog ear will be in your peri-alar area. So you excise that in a crescentic fashion, which gives you a brilliant aesthetic result. So the suture will go into the alar area here, and the lip will be vertical scope. So this is a very important thing which you have to think in even in central defects, bilateral peri-alar, like as given in this picture, you can do a bilateral peri-alar crescent excision and bring the lip together so that the scar, there is no dog ear in this area, and the scar looks good. Borrowing tissue from the adjacent area, the easiest one is nasolabial flap. So this is a larger defect, and then you can see the nasolabial flap that has been transferred. It works very well. You can use the mucosa of the cheek and the lip to be everted back, or you can use, there is always a question of how do you manage the mucosa. Usually the mucosa yields. You can just release it on edges and then it comes over. Otherwise, you can turn over the nasolabial flap a bit interiorly so that you have the lining also made. Borrowing tissue from adjacent lip area for smaller defect can be by step ladder pattern also. So this is a defect that has been created. See, all these things like peri-alar crescent, step ladder, this is all to prevent the dog ear, in fact, which will come. If you move the whole thing this way, there will be a dog ear in this shaded area. So that is why the step ladder principle comes, and you can see it is closing, and you can see even though we had planned for 2 step ladders, only 1 was used. So it closes nicely. So this is a very good flap for even medium-sized defects. Unilateral carapandic is also very good flap. This is the unilateral carapandic. In carapandic flap, what you do is this is a borrowed slide. That's why the picture is different. See, you can incise entirely the lip and the nasolabial area. You incise the skin, incise the mucosa, tease out the nerve fibers and the muscle fibers, and the whole thing moves medially. And this is a central, naming. This is I think the pictures got confused. This is the bilateral step ladder pattern. The other one was a unilateral carapandic. Now, Gillies fan flap was the one which was described earlier for a total and large defect, which is, I don't think we have ever used, and many people, for theoretical sake, we will talk about it, we don't do it. Webster Bernard also, I think it's again very nice in design, but hardly we don't use much. Once the carapandic flap came, it became much more useful. The problem with the carapandic flap is the microstoma it causes, which has to be released later on. So this is a large lesion, one of our cases where we had to remove, including the marginal mandibulectomy. So again, a bilateral carapandic was raised, and then advancement from the neck, which gave a reasonably good sort of movement. But you can see the commissure has reduced a lot, which can be released later on, which can be, like a commissuroplasty later on. But carapandic, the greatest thing is that it gives a very good functional sort of integrity to the lip, because none of the muscles are denervated. Whereas in the Gillies fan flap and Webster Bernard, everything is cut. So the muscle movement is less. So this is another, again, bilateral nasolabial. Now coming to lastly to the total lip defects. See, this is a total lip defect. What are the options available now? Webster Bernard, bilateral nasolabial, forehead, free radial forearm, innervated gracilis muscle. These are the usual things that has been described. I wouldn't go to Webster Bernard much because personal experience on that is less. But bilateral nasolabial is a very, very good tool. If you have an old patient, this is the best thing to do. Take both the thing, cross them in the midline. The beauty of nasolabial flap is that because they are coming from the top, it acts as a sphincter. So it doesn't fall down. It doesn't, the lip doesn't pout down. So that is very good thing. And so this is the patient. It doesn't look very good, but functionally they're very good. So in an old patient, total lip may be the first thing you should think is a bilateral nasolabial. And this is this is for completion. This is one of the cases, odd cases, which we did a forehead flap. So you can see that this is the routine forehead flap, and you have connected the whole thing. It works so well because again, you see the pull is towards the top. So even the commissure also gets pulled upwards. Not, it doesn't sag. And this is the defect later on. And this can be corrected later on by edge resection. So again, don't right away forehead flap. In a case where you cannot do a free flap, maybe that is one thing which you can do. Our workhorse now for a total lip is a radial forearm flap like this. It is very simple. You have a radial forearm, you put it together. How do you get the competence? You take the palmaris longus and then thread it through this, through that, and then you can either, subcutaneously pedicle, thread it through the flap so that the pedicle doesn't kink. Most important thing in this reconstruction is to make sure that the radial vessel is not kinked by your palmaris tendon. So either you can put the radial vessel on the buccal side or in the labial side, away from the area where the palmaris longus tendon goes. And this is another case where we had a vascular malformation. This is another case. And this was the case which, why I told you our threshold for radiation came down with this. This was a brachytherapy, but the patient had a recurrence. And finally, in spite of the fact that we gave the brachytherapy for avoiding a radial forearm flap, he ended up with a radial forearm flap with a very good result. Now, this is again one odd case where you had to use the cheek, both cheeks were gone, both lips were gone. So you had to use both the both radial forearm flaps like this. And then finally, this was the appearance, and we had to do a secondary surgery to correct it, and then thread the palmaris through this. Finally, to summarize, this is a fairly, I would say, simplified way of looking at reconstruction. If you go through, as I told you, read about it, it is confusing. So I wanted to make it slightly clinically oriented, what we do. Make an algorithm based on the surgical expertise and patient characteristics. See, if you can do a free flap for a total reconstruction, you do a radial forearm. And patient is not capable, the patient characteristic, patient is sick, patient cannot stand a radial forearm, then go for a nasolabial or forehead flap. And your surgical expertise, your patient characteristics becomes important in this case. Local tissue is the best in any lip. So if you can use whatever way you can bring it, the lips together without compromising on the function, without compromising on the commissure, the opening, you do a local tissue. And neighboring tissue is good. Nasolabial is the best friend for these things. And looking the defect as a small, medium total helps to make you do that, which I think you understood with this thing. And then radial forearm flap with the palmaris is our choice even though I missed one slide, is using of gracilis, simple gracilis, and innervate to the facial nerve and allow it to put a graft on that, has been used as a dynamic sphincter for the lower lip, which we had done one case. But I would say it shrinks, so it doesn't give that good appearance. So radial forearm flap augmented by palmaris might be the choice for the upper lip. Thank you very much.
Thank you very much, sir, for your excellent presentation. And that was a wonderful demonstration and beautiful demonstration of all the reconstructive options of the surgical defects of cancer lip management. And I apologize for the initial confusion because I was stuck in Hall C managing that. So that was why the confusion. And the other chairperson was also not there. Now I invite our next speaker, Dr. Vinit Paleri. Vinit Paleri will be talking on recurrent head and neck cancers, rethinking management and research priorities. He is a consultant head and neck surgeon at the Royal Marsden NHS Foundation Trust, professor of head and neck surgery at the Institute of Cancer Research, and the director of International Center for Recurrent Head and Neck Cancer, and the president of British Association of Head and Neck Oncology. I thank you very much for accepting our invitation to deliver this keynote address. And over to you, Dr. Vinit.
Thank you, Elizabeth, for inviting me. It's indeed an honor to deliver a keynote here. It's a shame I can't be there. It's a crying shame the Omicron has scuppered plans. I was looking forward to being back in my home state and enjoying your hospitality. I'm going to start sharing my screen so we can get this going. Can you see my screen?
Yes, sir.
Thank you for the kind introduction. So I'm going to spend the next few minutes rethinking our approach to performing more robust work for recurrent head and neck cancer and where we are today, where we are heading, and our roadmap. And I'd be grateful for feedback and your thoughts on what more can be done. It's more of a headspace ramble than a robust clinical talk like Dr. Iyer delivered ahead of me. I have a conflict of interest. I proctor for Intuitive Surgical. So it's always good to start from the unknowns when it comes to dealing with a new entity and trying to approach it fairly systematically. The main unknowns for recurrent cancer are, I don't think we completely and fully understand the natural history of untreated recurrent head and neck cancer. We can't at this point in time predict how long a patient will survive after they have achieved, after recurrence has occurred. Because you and I know that some patients will linger on for quite a bit of time after recurrent cancer despite being untreated, and others are consumed by the disease fairly quickly. We have data on outcomes after surgical salvage for recurrent cancer, but these are mainly single center data. We have some meta-analysis, but again, these have flaws in them. I don't think we have good longer-term multi-center observational series. We don't understand the quality of life and function offered by treatment for head and neck cancer, for recurrent head and neck cancer, as well as we do for primary cancer. So we have a real dearth of knowledge when it comes to that, and we are unable to comprehensively counsel and advise our patients what their function and quality of life will be like after treatment for recurrent head and neck cancer. Tumor biology, again, this could help us predict tumor behavior, and we don't have good data on this too. All this leads to one thing. There is significant variation in care nationally and internationally for recurrent head and neck cancer. So these are some of the major drawbacks for surgical research outputs. The vast majority of papers in literature are single center retrospective data for surgical salvage of recurrent head and neck cancer. We don't have anything robustly prospective at this point in time. And usually the numbers are consistently less than 100, given the nature of the disease process, given the rarity of surgical salvage in the setting, and therefore not as good data as we would like to accumulate and that we can offer patients when we counsel and advise them for surgery. We have meta-analysis with heterogeneity in them, and heterogeneity gives us difficulty in, again, being certain about the results and how we can advise our patient group with these surgical salvage, who undergo surgical salvage. I'm as guilty as anyone else in performing meta-analysis, And apart from generating hypotheses and perhaps offering some data, I don't think it's good enough in terms of offering patients a good amount of information prior to treatment. Likewise for endoscopic surgery too. For minimal invasive surgery, we have meta-analysis, but beset by heterogeneity in this setting. We do have some decent data, which are the surgical salvage group following oncological failure who were recruited into oncologic trials. And this gives us slightly better, robust prospective data in this setting, but yet these are on the back of oncological-led trials, which are most often primarily industry-led larger scale trials. If you look at clinicaltrials.gov and search for phase 3 trials in recurrent head and neck cancer, you find 15 trials globally. Most of them, well, all of them are oncologically driven, and interestingly, many of them are industry-led too. But we have a real problem in interpreting and applying this consistently, because there are variable inclusion criteria, variable exclusion criteria, and the population is heterogeneous, and we have a population which are included into these particular trials include a mix of unresectable, recurrent, and distant metastatic disease too. And it's worthwhile thinking through the fact that the criteria for unresectability is not uniform either. Different people have different thresholds for unresectability within different clinical teams. And therefore, it makes it even more difficult to nicely extrapolate that data into your patient population. So what are the potential solutions I'm proposing in this particular space? We need a better and improved understanding of the recurrent head and neck cancer landscape. I don't think we have that yet. I think we need to create national, international networks to accelerate research for recurrent head and neck cancer and to define the role of surgery in this particular disease. And the only way forward would be to create networks who focus on recurrent cancer as a collaborative model, accelerate fundamental science and translational research, and also focus on cancer survivorship for recurrent cancer specifically, because these patients have a different need, a different requirement for support compared to patients with primary disease. So let's look at these things systematically and what we have done in this space so far. One way to fast track and obtain data relatively quickly in this relatively rare disease is to perform large data set mining. That is one thing we are set about doing. So it is feasible to define and validate methods to phenotype the cancer recurrence using large national clinical data sets. Let me show you an example and what we can do, what we do in the UK. But the aim is to develop indicators of cancer recurrence, to validate them, and to demonstrate use of the indicators in a clinical setting. Here's an example. When patients present to us with head and neck cancer, they go through imaging, chemotherapy treatments, radiation therapy treatments, and every time they come into hospital, there is a hospital episode statistic whereby patients are monitored for their hospital attendances, be it outpatients or inpatients. APC stands for admitted patient care. So you can see that when a patient, this is a hypothetical patient with colorectal cancer, let's say, the patient is diagnosed, and before diagnosis, they have an imaging entry, they have a COSDAYS cancer outcomes standardized data set, and in the COSDAY, you can see there's a colorectal cancer entry, they start chemotherapy, and the SACT goes up, they get radiation, the RTDS shows up, and once the treatment is complete, they go into regular follow-ups, occasional imaging, but regular outpatient follow-ups over the months. And you can see that as time goes on, let's say a recurrence happens at 36th month, then the outpatient frequency goes up, new imaging happens, and the systemic anti-cancer therapy kicks off again. So that's an indicator of recurrence. So it's feasible to use machine learning in this space to join data up across these different silos and create information, generate information to try and understand the national landscape of recurrent cancer in this setting, using merely hospital appointments and the treatments they have across larger patient numbers. Additionally, you can use machine learning in two formats: unsupervised or supervised learning, and the unsupervised being just a cluster I've showed here. So defining clusters of activity and then extrapolating them to indicate recurrent cancers. It's also feasible to use clinical rules and expert opinion in this space. You can see that you can take a volume of patients, audit them systematically, confirm they have recurrence, and then do a backward search to define the codes which led to the patient, which were present before the patient was diagnosed with the recurrence, and use that again to define recurrent cancers in larger data sets. This has been done in prostate cancer using skeletal mets as an indicator of advanced disease. My colleagues at the Royal College of Surgeons and the Clinical Epidemiology Unit, especially Jan van der Meulen, who is a professor of clinical epidemiology, he looked at admissions for fractures, for spinal cord compression, for certain surgical procedures to manage fractures in patients with prostate cancer. Instead of looking specifically for recurrence, correlated that with the stage of prostate cancer and showed that patients with advanced prostate cancer had a higher risk of these skeletal events indicating metastasis, as you would expect in advanced prostate cancer. So the data holds together really well in this setting. So certainly something to consider for recurrent head and neck cancer. That's one thing we intend to do over the next few years to try and define the national landscape of head and neck cancer. And interestingly, with this data, you could potentially look at survival and look at differential survival across the different areas of the country, and therefore even perform focused research and in places where additional resources need to be diverted. Let's go to the next entity, creation of national international networks to accelerate research. So we thought about it for a long time, and having worked on robotic surgery for recurrences, which is my subspecialist area of surgical practice, I thought the data was insufficient. The systematic review had heterogeneity. It just didn't cut the mustard for me. So we thought, can we perform an international multi-center observational cohort study by recruiting multiple centers, creating very tight timelines for inclusion, exclusion, and recruiting consecutive cohorts right across these multiple centers performing robotic surgery for recurrences. The numbers are small at each center. There are reporting biases. There are issues with what's considered as a good outcome, and issues about oncological follow-up. So all these things were ironed out by having a uniform Excel data tool. The major issue was data sharing agreement across these multiple centers internationally. We set a team up, and a legal team went through the DSA systematically, and we managed to recruit 16 global centers. You can see that 2 centers are from India, BLK Super Specialty Hospital and Tata Memorial Center in Mumbai. And I'm very grateful to my co-authors, Arun Balaji, Surendra Dabas, Gauri Pantvaidya, and Anand Subhash for helping me put this all together, and to my collaborators across the globe in other centers, both in the USA, Canada, and Europe, for helping put this data set together. And you can see that when we all come together, it really can make a difference to generate robust data. It's an observational cohort. We get that. It's not a randomized trial, but it's a consecutive cohort with very clear inclusion-exclusion criteria and very clear data sets on surgical management and on some aspects of functional outcomes. So we had 278 cases eligible for analysis, 13%, which is exactly what you'd expect even in high volume centers when you're looking for a rare disease process you want to put together in terms of outcomes analysis. Happily, we had a high percentage of data completion. You can see that the follow-up was again robust for survivors at 40 months or so, and for all subjects at 13 months as a median follow-up figure. And let's look at the data. Let's look at just some aspects of the data. So I can show you that by working together as a network in the setting, we can achieve good outcomes and good data that we can hang our hats on. So so all you and I as surgeons can impact on are the local recurrence-free survival. So in all subjects who underwent robotic salvage for recurrent head and neck cancer, robotic assisted salvage, the local recurrence-free survival was 69% at 2 years. And it was quite decent at 5 years, 62% at 5 years. And that is pretty decent given the fact that these are patients who have aggressive disease and the disease has come back despite previous treatment. Interestingly, here's a new entity we seem to have come up with, in that the difference in 2-year local recurrence-free survival and 5-year local recurrence-free survival was not different between HPV positive and HPV negative disease in the oropharynx. Again, a new hypothesis, but robustly generated using multi-center collaborative work. And it looks like when tumors come back after radiation, although the recurrent cancers are HPV positive, they don't seem to have that prognostic benefit that the primary tumors enjoy in the setting. We looked at margins, again, point of contention. People are always concerned about small margins with minimally invasive surgery, but that isn't what we saw. At 2 years, as long as patients have a more than 1 millimeter margin, you can see an 81% local recurrence-free survival. And if they have more than 1 millimeter margin, again, at 5 years, you got 75% local recurrence-free survival in this cohort. The reason for the 1 millimeter cutoff was based on analysis, including a MaxStat and the ROC analysis. We won't go into that, but we have generated data that can certainly be a platform for further studies. And of course, we understand these tumors better as surgeons. We understand the importance of residual disease, recurrent disease, and new primaries. But when we perform this analysis separately, again, when robotic surgery was performed for these smaller tumors, clearly the vast majority are T1, T2 tumors, you can see that the difference in survival, in local recurrence-free survival, between residual tumors that occur or recur within 1 year of treatment versus those that recur more than 1 year after treatment is not significant again. 61.7% at 5 years versus 61.8% for the recurrent and the new primary cancers. So reasonable data to indicate that we may not be offering patients optimal care if we don't salvage them, even if they are residual cancers. So key findings are, despite whatever key findings, my bigger point is that networked working, coming together on a rarer disease like this will have significant benefits for patients and for generating hypotheses for newer disease processes and newer modalities. Fundamental science is important. As surgeons, we need to participate in the fundamental science and translational research where we can. For example, we have RECA Plus, where we're establishing a multi-omic translational research platform for exclusively for recurrent head and neck cancer. And this involves picking up tumor from multiple sites and taking punch biopsies and performing a whole lot of multi-region omics to try and define the tumor better. And we have, you must have come across a STING agonist, for example, locally injectable therapies for recurrent head and neck cancer, which activate the STING. STING stands for stimulation of interferon genes, and STING stimulation leads to significant benefits in selected patients, and you can see that you can use viral vectors, HSV, Maraba, or Rio, or some of the small molecules, like the toll-like receptors, to try and activate the STING gene. And these are patients who have good response. But imagine combining this in those who respond partly with surgery in the setting, and we never know what the future might offer us by combining locally injectable therapies. And these patients had combos. They had locally injectable plus immunotherapy. And these are clearly good responses. There are many patients who may still benefit if we can figure out who are the ones who will benefit in this setting. Again, another patient who had the Replimune study, which is the herpes simplex virus driven STING therapy combined with Optivo, and you can see outcomes in this patient over a period of time. These are unresectable cancers, but imagine combining this with patients who are potentially resectable, where they can benefit significantly. And we shouldn't forget cancer survivorship, because when we did the recut data, it appears that patients who need counseling differently, it's not as simple to say that patients who have a gastrostomy at the beginning of treatment for primary cancer are likely to lose it. That's not always the case. A fair number of patients actually in the longer term, while they didn't have a tracheostomy, they pick up a tracheostomy. Those who didn't have a gastrostomy also need a gastrostomy. And we don't understand the functional outcome data for this patient group as well as we should. So with that in mind, they clearly need more intense interventions in this particular setting, and not understanding is a reason for starting from scratch again. Having completed a systematic review, there is now a prospective study to try and understand the functional and quality of life requirements for this particular patient group. So this is almost my concluding slide, I think, but the point is that we can come together to create national, international, collaborative partnership to try and understand this disease process better. And this is something that we intend to work on over the next few years within the Marsden. And I'm once again very grateful to my excellent partners who have helped us deliver on the recut and this has been a shot in the arm for us to allow us to build on this particular platform to show that working for surgery can really be. I'm very grateful to my colleagues who have helped me set this up from scratch, and contact me on Twitter if you need to, if you would wish to participate in this endeavor. And thank you once again for the invite. Pleasure to speak.
Thank you, Dr. Vineet, for enlightening us about this research priorities and rethinking about our recurrent head and neck cancers. So actually, traditionally, we were thinking about recurrent head and neck cancer with poor prognosis, with outcome, and most of these patients will end up in palliative intent treatment and only supportive care. But as he has enlightened and elaborated, there are some like molecular markers of recurrence, and with more machine learning and collaboration, networking and international collaboration, we should, like all these patients' outcome will be really, with encouraging results, we can treat these patients. And because of the shortage of time, our next session will start at 1 o'clock for poster viewing and discussion. I think one or two questions, a couple of questions in the chat box from Dr. Ashok Shenoy to Dr. Iyer. What about the Gates composite flap? Iyer, sir, are you there?
But I see, I wouldn't answer too much about it because there are a lot of flaps which I have not covered. There are a lot of flaps, if you look at the books, there are a lot of flaps for lip. So it is not, I think, I would say that you have to, in fact, if you have not done it, you read about it and do it. And then that's the only way to, but what I have suggested, what I have put it across is what we do routinely. There are a lot of other, see, if I start drawing the pictures of the flaps and describing each, it is endless for lip. So Ashok, thanks for reminding that my talk is totally incomplete, but I would say my talk was intended to be making a small practical.
One more question, sir, from Dr. Shaji Thomas, our head of the department. What is your experience regarding supraclavicular flap for lip reconstruction?
Supraclavicular has we have used up to the cheek only, not for the lip. I think it can be. See, the problem is that you were talking about total lips. Total lips, now with the consistently good results we get with the radial forearm, we tend to think short about it. See, and then the cases which I showed, the nasolabial flaps are not small. So those cases, but there are a lot of composite defects, that I didn't go because there are sort of cheek defects, mandibular defects, along with that lip is there. that is an entirely different entity to talk about. There are a lot of other things there. So there, ALT flap or supraclavicular pectoralis major with the DP, double flaps, everything works. So I think Shaji's point is right. Supraclavicular flap has got its own role. Even pectoralis major, even delta pectoral, everything has got a role. But I didn't go into those extensive defects. Total lip, I still believe, I would say, limit our choice to these.
Thank you, sir. And thank you, Dr. Vineet.
Vineet, can I ask one question to Vineet?
Of course.
Yeah, no,
Yes.
you're talking about the international consortium. No, it's very much interested in when you said that why don't you develop a consortium for rare diseases? It's a very good. I think you showed the way of doing it in a way. We are all sort of thinking that the retrospective data, doing that way. But if you do it properly, even the HNCOG, the studies are like that. So I would strongly suggest that we look very much deeply into forming a collaboration across the country centers with taking it forwards. It's a very good initiative.
Thank you. I think that's the only way to nail this problem if we intend to do it properly. Single center outcomes just don't cut it. They don't offer enough robust information. They are beset with biases, and it isn't something you can rely on completely. We need to do it better. We need to raise our game, and international collaboration would be a good way to do this. And we've shown that we can do that even with existing data sets, which will generate good hypotheses.
Yeah.
Yeah, if no more discussion, Dr. Vikram, can we wind up here?
Yeah, so thank you, Dr. Vinay, Dr. Iyer, for excellent keynote addresses. We look forward to your participation in the rest of the conference. Thank you, Chairperson. We'll close this session and then reconvene for the award paper session at around 2. Thank you.
Thank you. Hello. Yes.
Thank you, Vin. Excellent talk.
Oh, thanks. I was looking at a question from Sarbani that we haven't answered. I'll contact her.
Gurmeet?
Even there, no, I was the oldest person. All were engineering students, most of
One
them.
second. Can we start the award paper session now? Gurmeet, are the judges ready? Can I invite Dr. Deepak,
Dr. Satish,
Kiran,
Dr. Satish.
Devendra, and Dr. Satish? They are the judges for the prestigious oral paper session, the award paper session of FHNO 2021. So can I have all the judges online and the award contestants online? There are 8 papers that are being presented. Can the judges take over now? Dr. Satish?
Yeah. So who's the first? First is Itisha.
Yes, sir. Good morning, sir.
Gurmeet, go to the award paper list.
Sure, sir. Just 1 second, sir.
We'll put the list on. We'll have a timer of 7 minutes for the presentation and 2 minutes for the discussion. So can we start with the first presenter? Dr. Itisha?
Yes, sir.
Please.
Yes, sir. Shall I start presenting, sir?
Yeah.
Yeah.
Okay, sir. 1 second, sir.
Please put 7-minute timer.
There is a 7-minute timer and 2 minutes for discussion.
Sir, is my screen visible?
Yeah.
Yeah, it's visible. Yes.
I'll start now, sir. Good afternoon, judges. Good afternoon, my dear colleagues. So my presentation today, the topic of my study is radiological and histopathological correlation for assessment of depth of invasion in early oral squamous cell carcinoma. The study is being performed at All India Institute of Medical Sciences, Bhubaneswar, under the Department of Surgical Oncology, Radiology and Pathology. So coming to the background of the study, we know that depth of invasion is one of the important parameters in management of oral squamous cell carcinoma. It predicts the overall prognosis, the risk of recurrence, and cervical lymph node metastasis rates. So it has also been included as a part of the latest 8th edition AJCC oral cancer staging. Move my slides. Yeah, sorry. Yeah. So coming to clinical depth of invasion and radiological depth of invasion. Clinical depth of invasion is the gross depth of invasion that can be assessed on the basis of palpation. So there are 3 categories basically: less than 5 mm, 5 to 10 mm, and more than 10 mm. And this is basically a very subjective assessment, and it is thus prone to inter-observer variation. While radiological DOI, it can be assessed by MRI or CT scan. MRI considered to be more accurate, and especially for lesions more than 5 mm in depth. Now, why is the need for this depth? So we know that oral cancers can present as different kind of ulcers. It can be either proliferative ulcer or it can be an invasive ulcer. So ulcers which are basically small in dimension, maybe 1 or 2 centimeter in their breadth and length, but they can have a higher depth of invasion, maybe more than 1 centimeter or 2 centimeter. That kind of ulcers need special attention because they are the likelihood of going for a poor prognosis and a higher nodal metastasis and a higher a poorer biology is always there compared to a lesion which has got a same size and a lesser depth of invasion. So the aim and objective of this study was to evaluate the correlation between MRI and histopathology for estimation of depth of invasion. The study setting is Department of Surgical Oncology in Bhubaneswar, and we had started recruiting patients from November 2019, and it is still ongoing. Our initial aim was to recruit at least 50 patients, 50 in this sample. However, because of COVID and non-operation of the our functional OTs, the numbers has not been yet achieved. The study type is a single-arm prospective observational study, and it was started after institutional board review and ethics committee approval, and we have registered it under CTRI. The inclusion criteria was tongue and buccal mucosa carcinoma, clinically T1 to T3, age more than 18 years, who consented to be a part of the study, and excluding those who had skin or bone involvement, other subsite involvement where palpatory method might not be possible, and it will be difficult for radiological assessment of DOI as well. Patients who had undergone neoadjuvant chemotherapy and who had undergone previous surgery, excision biopsy, or radiotherapy. The MRI which we have used is 1.5 Tesla machine, and axial and coronal T1 weighted images with fat suppression and gadolinium for analyzing tumor dimension and depth of invasion was used. MRI assessment of depth of invasion was done by a single experienced radiologist assigned at the center, and preferably all the MRIs were done after the admission. All data, clinical, radiological, and histopathological, were prospectively entered in the master chart for analysis. So in this image, we can see this is for a tongue lesion, which has got a depth which is almost 17 mm. So it qualifies more than actually T3. It is T3 lesion. And if we look at the dimension wise also, it is significantly larger, occupying almost reaching up to the midline, not exactly up to the midline, but it is significantly. So MRI gives a very well assessment. It gives a good assessment of the depth. This is for a buccal mucosa lesion. We can see this was a very superficial lesion in one of our patients, in which the depth actually finally in the histopathology, it came out just as 2 mm. So it becomes actually very difficult at times for MRI for flat ulcer-like lesion to assess the accurate depth of invasion. The statistical analysis was performed using Stata software, and Cohen's kappa coefficient was used to measure the agreement between variables. We used a kappa is equal to kappa, yes, less than 0 was interpreted as no agreement, and 0.2 was slight agreement, till 0.4 it was fair agreement, 0.6 was moderate, 0.8 was substantial agreement, and 1 almost perfect agreement. And correlation between the radiological finding and histopathology was performed using Spearman's rank correlation. Coming to the results part of the study. So almost 64 patients, they underwent surgery for oral cancer between November 2019 and June 2021. 23 met the inclusion criteria for early oral cancer. 6 patients had to be excluded from the study because the MRIs showed either artifacts or there were very superficial lesions or flat ulcers which did not show any significant depth or enhancement. So final included in analysis were 17 patients. The median age of presentation was 50 years, and males were 15 in the sample, 2 females. Tongue, buccal mucosa and lip was taken. Tongue, 11 patients, 64% of the population was tongue, while 29% was buccal mucosa and 5.8% was lip. Clinically, 10 patients were clinically T1, that is 58%, 35% were T2, and 5.8% were T3. And most of the lesions were ulcero-infiltrative. 58% were ulcero-infiltrative, while 6 patients had ulcero-proliferative lesion. Only 1% had a very flat ulcer. When using the statistical analysis and comparing the patients, so initially what we did was radiological and histopathological T staging was compared. So in this, we can see that for T1 assessment, we got actually exactly similar, which was slightly contradicting to the previous studies, which had shown less sensitivity for T1 lesions. While for T2 and T3, some patients were understaged and some were overstaged. While comparing the agreement between MRI and histopathological data, we used Cohen's kappa coefficient, which came out to be around 0.125 agreement between MRI and histopathological data based on the depth of invasion. So using it as a continuous variable, when we used, there was a slight agreement. However, when this on the basis of depth of invasion, T staging was done, and on that, when we correlated with the MRI finding, it was the Cohen's kappa value was 0.624, which showed a substantial agreement. Correlation between MRI and histopathological data based on the Spearman's rho. So we tried to find a correlation between the 2 variables, that is the MRI and final histopathology based on the depth of invasion. The value came at as around 0.7229, which is definitely a high level of correlation. And the p-value was also significant. It was 0.001. And the correlation between MRI and final histopathology based on T stage was 0.6837, similar to what we previously found. And p-value for this was also significant, it was 0.0025. So we found slight agreement between MRI and histopathological data when we are using a continuous variable DOI, and substantial agreement when we were using it on the basis of T stage. While when we were correlating between Spearman correlation was found, it was a significant correlation between the MRI and final histopathology data, and based on the DOI, and between the final T stage also there was a significant correlation. Now, there has been previous studies. One of the study was, the first studies was reported from Canada, St. Margaret Cancer Institute. So this paper was published, basically, it showed they had compared clinical and pathological depth of invasion to histopathological data. And they had also found a strong correlation. However, in T1 lesions, they did not find this kind of correlation. Similarly, in 2021, there was another paper which was published, which also found significant correlation between the MRI and the final histopathological T stage. But however, they also found that when the depth of invasion was less than 5 mm, it was not significantly correlating. There has been a recent Indian study published in 2020. That study also found a good agreement between MRI depth of invasion and pathological depth of invasion, and their analysis methodology was also similar. They had used kappa coefficient, which was 0.844. That is highly, it was strongly in agreement with both the things were strongly in agreement. So in our study, all patients with T1 stage, what we had not previously seen, in our study, we found that all of those which had T1, as per DOI, were correctly staged by the MRI. 4 out of the 6 patients with radiological T2 were correctly staged by MRI, and 2 were overstaged. And 2 out of 4 patients with pathological T3 were actually understaged as T2 by MRI. So to conclude, we would like to say that depth of invasion on imaging, that is MRI, strongly correlates with the final histopathology, and MRI as imaging is reasonably accurate for measurement of depth of invasion. The strengths of our study is that we have, this is a very clinically relevant study because since the advent of this depth of invasion being included into the final histopathology, we need to be preoperatively ready with the kind of depth that we might might get in the final histopathological data. Secondly, this study is a prospective study, so it is less likely to be affected by various biases that are seen in retrospective studies which have been previously done. And we have strictly followed the protocol with the necessary inclusions and exclusions. Limitation is that it is still an ongoing study. Our recruitment had suffered a lot because of the COVID pandemic. And till now, there is a limited sample size. We had recruited 23 patients, out of which we have excluded few patients. So 17 has been the only analyzable sample. We plan to take 50 patients, include 50 patients in the final analysis. Thank you.
Your time has crossed by 2 minutes.
Okay, sir.
And one more question I'll ask. What is your take on ultrasound or post-operative ultrasound assessment?
So routinely, we are not using ultrasound assessment, although it has been documented in certain papers that assessment can be done. But for oral cavity, it is a difficult area. It is not a superficial area which can be easily localized. So for tongue and buccal mucosa, it is basically a difficult area if we can to use ultrasound. That is the major drawback. Although MRI has its own drawbacks, like it needs a good infrastructure, it has cost issues, and for each patient, it is an added cost in early lesions, where we might as well go ahead without doing any imaging, considering the various setups in India. However, because tongue malignancies are usually very aggressive, and depth of invasion plays a crucial role in planning for adjuvant therapy. So if we are aware of what kind of depth is there, we can plan our margins accordingly.
Anterior to that tongue lesion, I don't think MRI should have a problem. I mean, the ultrasound should have a problem in assessing the depth, because on table you are having, when you are not having MRI, in that case, probably it has a role.
Okay, sir.
Dr. Itisha, this is Dr. Satish Thayer here. It's a nice presentation by you.
Thank you, sir.
As you said, the study is not complete, so I'm not sure if these few numbers can actually give results. Point one.
Yes,
Point two, you said you're using T1 weighted images, not using T2 weighted contrast for these. Number three, you can respond. I'll just go through the things. The third thing is most of the literature talks about the smaller ones, the less than 5 millimeter, where there is overestimation. Whereas your early results say the other way, the T2, T3s are having estimations wrong as compared to this.
Right.
And lastly, you say that it's an early, your heading says early oral cancer, and you seem to have taken T1, T2, and T3 too.
Yes,
yeah,
sir.
please.
So we had taken, our sample size includes all T1, T2, T3, but what our major sample is basically T1, T2. Definitely, it is a part of the study. We are basically trying to look at lesions which have not infiltrated the skin or bone. So that way we are trying to look at the early ones. Second thing, sir, MRI, we are actually using both the images, but as per what the final, because we have to agree on to one of the either T1 or T2 based on the contrast and what kind of enhancement, we have agreed to look at these films for standardization, because the depth can actually, even in MRI, because of artifacts or because of the contrast enhancement uptake, it can change slightly. And even 1 mm can bring a patient from an early, like less than 5 mm to 6 mm. It can upstage the patient. So that is why for standardization procedure, we have kept it like that as a part of the protocol. Thank you, sir. So the study is still continuing. We will recruit more patients. The numbers are less, but whatever studies we could find, the Indian study that I have quoted, that sample also was 30 patients only. Probably this thing will gradually, with more studies coming up, we will have more numbers, and more studies will show similar results.
Yeah, Dr. Itisha, this is Dr. Arvind here.
Yes, sir. Good afternoon, sir.
Yeah, good afternoon. I just wanted to ask you, what is the clinical relevance of this study? So based on this, what treatment do you sort of change, or does it have any clinical impact at all? I know that this is I mean, you are trying to sort of not test your MRI versus the final histopathology, but does that change your clinical decision making in any way at all?
So the final treatment definitely, to most extent, it doesn't change. But whatever, with my little experience, since I've been involved in this project with the histopathology and everything, and grossing also, what I have observed is that many of the tongue lesions, they do look early. There have been few patients who looked like a smaller lesion, a 2 centimeter or 1.5 centimeter lesion. When on palpation, on MRI also, at times it did not pick up the exact depth. And at the time of grossing, when we are doing it, we are able to actually correlate what the MRI findings are. So basically, we can pre-operatively only we can prognosticate that, okay, this is not T1 based on the size. This is based on the depth of invasion. It is already T3. So definitely, so in the final histopath will be the one which will be the final pathological report. But MRI, if we already know what is, we can plan for the adjuvant therapy earlier. That is all we can say.
Right.
We can
anyway, that's what I wanted to ask, because your decision on treatment would be sort of, the extent and all would be, of course, based on the MRI and clinical thing, but your decision on adjuvant would sort of, be based on the histopathology. Anyway, well done. And I think looking forward for your complete paper and your publication subsequently. Best wishes.
Thank you, sir.
Can Dr. Vijay Lakshmi, the next paper presenter, come on? Yeah. Okay.
Opportunity. Slide is okay. So oral cancer, in case of oral cancer, diagnosing early seems to be the need of the hour. And pertaining to biomarker discoveries, one can take several routes, starting from the salivary sample or a blood sample or tissue sample pertaining to oral cancer. So what we have done here is we have taken the proteomics route. So starting from the tissue samples, we did the proteomic expression profiling, and through mass spec, we have tried to identify the biomarkers. The objective was to derive a biomarker based on quantitative proteomics, that is 2D DIGE followed by mass spectrometry in oral tongue cancers. So the study design here, namely, we had the discovery set with the tongue tumor and the adjacent normal samples, apparently normal areas, profiled with 2D DIGE followed by mass spectrometry. And then we looking at the protein expression profiles, we identified vimentin as the lead overexpressing biomarker. This was validated in the clinical samples by immunohistochemistry and by ELISA in saliva. So we used 345 samples for validation. So here what you see is the image of the differential proteomic expression profile compared to normal and tumor. And what you find here is an overexpression of vimentin protein compared to the normal. And vimentin indeed was the most upregulated protein that we got in our data. So the top upregulated proteins are listed here, and vimentin was the top in the list. And the earlier studies using other modalities also have shown vimentin to be an overexpressed protein. So vimentin is basically involved in the epithelial to mesenchymal transition. And so when the cells have to invade, then when they kind of assume a mesenchymal phenotype, vimentin is overexpressed. And vimentin is important for persistent invasion and resistance to deformation among the tumor cells. And it is also a protein which is widely interacting with a great class of proteins like growth factors, caspases, phosphatases. So it's a highly interactive protein. So after we found vimentin was really overexpressed, we validated it in a retrospective series of tongue cancers, which were exclusively early staged. We had 150 cases which were treated between 1995 to 2007. And we found that the pattern of vimentin expression was predominantly cytoplasmic, and the vimentin positivity was identified in 38.6% of cases. So what we found was the overexpression of vimentin was significantly associated with increased stage and increased size of the tumor. And looking at the failure pattern and the treatment outcome, we found that Vimentin overexpression was significantly correlated to failure of treatment and pattern of recurrence, and as well as poor progression-free survival in early stage tongue cancers. And we also found that positive expression of Vimentin in the invasive tumor front was highly correlating with the locoregional recurrence. So next we took prospective and independent series of samples, which included not only tongue cancers, but the cancers of the buccal cavity, as well as oral precancers and healthy normals. And we found that Vimentin expression was highly correlating with the severity of dysplasia, which was very significant, and also with increased age. So this is the immunohistochemistry images of Vimentin overexpression. And then next was, we wanted to see if this biomarker can be coming up and detected in the saliva. Why saliva? Because transformation of oral mucosal epithelial cells to a malignant oral squamous cell carcinoma is surrounded by saliva. So one could look at different methodologies to look at saliva, like immunoreactivity based or shotgun proteomic based or 2D gel based. Because we followed 2D gel based methodology for tissues, we followed ELISA, that is immunoreactivity based methodology, to look at Vimentin expression in saliva. So we collected saliva from 146 subjects, where we had normals, healthy volunteers, 39 samples, saliva from pre-cancers, which included leukoplakia and submucous fibrosis, 47, and oral cancers, 60. What we found was Vimentin secretion was significantly elevated in saliva samples obtained from oral pre-cancers and oral cancers. And the ROC curve was also very significant. We were able to get a very significant high level of submucous fibrosis samples and other oral precancer samples expressing Vimentin compared to the normals. So hence we conclude that Vimentin is emerged as the most upregulated protein in oral tongue squamous cell carcinoma by quantitative proteomics, and we have the validation studies show that Vimentin in the early stage tongue cancers functions as a poor prognostic indicator, and role of Vimentin has been evaluated in oral precancers in our study, showing that Vimentin can be a very useful marker in early detection of oral cancer. And finally, expression of Vimentin in saliva shows that it can be a suitable biomarker for oral cancer screening in future. So the one future scope could be developing a biosensor which could pick up Vimentin in saliva, and which can be used in oral cancer screening clinic. So I want to thank my collaborators, Dr. Anandi and Dr. Vidya, as a histopathologist, Dr. Arvind Krishnamurthy, who managed the patients clinically, Soundar Viveka, the student who did the immunohistochemistry, and Dr. Divyambika and Dr. Pratibha for the saliva samples, and Pallavi Kesavan, who also worked on the saliva ELISA. The study was funded by DBT, and which is thankfully acknowledged. I thank you all for your attention.
Thank you, ma'am, for a nice presentation. My question is, will it affect if a salivary gland neoplasm, suppose incidental finding, like pleomorphic adenoma or something the patient may be having in parotid or some other region, whether it can affect the value?
Yeah, sir, actually, Vimentin is a marker which is very closely related to inflammation. So wherever there is an inflammation, Vimentin is supposed to be overexpressed. So if you look at the probable mechanism of finding overexpressed Vimentin in saliva could be an inflammation which is ongoing in the oral precancers. So which is probably coming up in the saliva also. It's getting secreted into the saliva. Because there are other inflammatory markers like tumor necrosis factor alpha, TNF-alpha, which is supposed to be overexpressed in case of inflammation, and that is also promoting the expression of Vimentin. Studies have shown that these inflammatory markers in turn can promote the expression of Vimentin. Probably that is what we are finding out in the saliva. We are picking it up in the saliva.
Thank you, ma'am.
Nice presentation, ma'am, and it's a good study, especially if it is going to predict oral squamous cell carcinoma initially. When you said the people with submucous fibrils or pre-lesions, if they can, definitely it will be, and saliva being an easy method, like you said, you can scan and find out.
Yes, sir.
Is this study already published, ma'am?
We have already submitted it for publication, sir. It's under review.
Okay, thank you.
Yeah, we can move.
We go to the next paper.
Yeah, thank you. Thank you so much.
Can Dr. Bhavya come on? Is Dr. Bhavya there?
Yes, sir. I think I can. Everybody can hear me, sir.
Yeah. But we can't see you. You're not visible.
So. Sorry for the inconvenience, sir. I'm unable to share the screen.
Gurmeet, can you help out? Gurmeet, can you please help?
Can you send the your PPT?
PPT, how do you want me to share, sir?
Isn't you are not allowed to share, or what is the issue right now?
Hello.
Yeah.
Sir, actually, it is showing as share screen, but in that it is not getting allowed. Like it's not being allowed to share.
For the timing, shall we move to another participant?
Yeah, I think you go.
Yeah, I think so. Correct. I agree.
Sorry for the inconvenience, sir.
Hello.
Hello. Yes.
Yeah. Good afternoon, sir. Should I share my screen, sir?
Yeah.
So is my screen visible, sir?
Yes.
Okay. Good afternoon, everyone. Today I'll be presenting my paper on the topic laser-assisted microvascular anastomosis of free flap in reconstruction of orofacial defect, a comparative study among conventional suturing and a diode laser anastomosis. Advancement in microsurgery. Conventional microsuturing is the most common use technique of anastomosis. Some of the advancement in the anastomosis technique include the use of venous couplers, staplers, fibrin glue, and the laser-assisted vascular anastomosis. Recently, laser-assisted vascular anastomosis has gained popularity among the microvascular surgeons due to ease of availability, cost effectiveness, least application time, and moreover, tissue mismatch and the foreign body tissue reaction is not a problem seen with the laser-assisted vascular anastomosis. Coming to the conventional microsuturing, the three main technique which is used for the end-to-end anastomosis technique are the 180-degree technique, the back wall first technique, and the triangulation technique. Coming to the laser-assisted vascular anastomosis, absorption is the main interaction which takes place when we use the laser. When the two ends of the blood vessels are together, cell adhesion takes at the vessel edges and the coagulum is formed. During the healing period, this coagulum is replaced by fibrous and the muscular tissue. Along with the combination of the laser, sometimes a dye is used to increase the tensile strength of the anastomosis in order to withstand the physiological pressure of the blood. Aims and objective was to comparing the efficacy and the effectiveness of laser-assisted vascular anastomosis method over the conventional microsuturing for microvascular venous anastomosis. It was a randomized control trial. The inclusion criteria included patient who reported for reconstruction of hard and soft tissue maxillofacial defect, while the exclusion criteria included patient with known history of systemic comorbidities, vascular disease, diagnosed with abnormal anatomical variation of the indicated donor site. The sample size was 60, which included 48 male patients and 12 female patients. The distribution of the pathology necessary reconstruction are represented as follows. The sample size of 60 was divided into two groups. The group 1 consisted of the 30 patients which underwent conventional microsuturing, while the second group had 30 patients which underwent laser-assisted vascular anastomosis. The armamentarium used were the Jeweler forceps, the curved Jeweler forceps, dissecting scissors, dilators, bulldog clamps, vessel clamps, and the Adventia dissecting scissors. Intraoperative assessment: the recipient size was assessed for the size, site, and the situation of the defect, and suitable recipient vessels were isolated. The facial artery, superior thyroid artery and vein, common facial vein, and the intrajugular vein were used for anastomosis. All the vessels were anastomosed in the end-to-end fashion. Coming to the group 1 conventional microsuturing, veins were prepared, partial anatomy was performed under 10x magnification, lumen was flushed with 4% lignocaine and saline. The first suture was passed at the distance from the margin of the vessel, similar to that of the thickness of the wall. A counterforce was applied by passing the needle through the vessel by holding the forceps open inside the lumen instead of grasping the vessel wall. The next suture was placed in the exact opposite side. The third suture was placed in between the first and the second, and the two more interrupted sutures were placed on the same side. After finishing one side, the vascular clamps were turned to expose the other side of the anastomosis, and a similar suturing method was employed. Coming to the group 2, which was laser-assisted vascular anastomosis, a Zolar laser unit was used. It was a soft tissue diode laser. The vessels were prepared in a usual manner, and both ends of the vessels were brought together. We used a laser Zolar with a wavelength of 810 nanometer at a power of 2000 millivolts in a continuous mode. The vessel ends were grasped with a jeweler's forceps. The tension at the right angles to the vessel led to approximation and eversion of the vessel edges. Methylene blue dye was now applied to the approximated vessel wall to absorb the laser energy. The anastomosis was achieved by a total of 6 to 9 shots on the vessel walls. Using the diode laser with a fiber optic probe between the jewelers, 2-3 shots of the 0.67 spot diameter and 5-second duration was used. Once the anastomosis is complete, the vessel was opened to the circulation by unfastening both the clips, the distal one first. The parameter assessed were the time taken for anastomosis, leakage at the site of anastomosis, and the flap ischemic time. The statistical analysis was done using a t-test. The unpaired t-test was used to analyze the anastomotic time, while the Fisher's exact test was used to analyze the qualitative parameter in both the groups. The result of the study is as follows. The mean ischemic time for group 1 was 384.87 minutes, but for laser it was 138.7 minutes. The mean anastomotic time for the suturing was 19.75 minutes, while for laser it was 3.86 minutes. Leakage at the site of anastomosis was 18.3%, and for laser it was 3.3%. Patency, 13.3% delayed patency was seen for the suturing, while 100% immediate patency was seen for the laser group. This is a graphical representation of the ischemic time required for both the groups. This is a representation of the anastomotic time required for both the group. Leakage at the site of anastomosis, grade 1 leakage was seen in 4 cases in group 1, while it was seen in 1 cases in group 2. The patency was immediate in the 26 cases of the group 1, while it was slow in 4 cases, while in the laser group, all the 30 cases had immediate patency. Although all steps in microsurgery are important, the phase of the anastomosis play a remarkable predominant role in achieving positive results. Venous anastomosis is still a challenge in some cases, even in the experienced hands of a microsurgeon. The re-establishment of circulation to the flap within the ischemic time is the main challenge faced by the surgeon to obtain a high success rate. Laser helps to a great extent by not only connecting the vessel, but also alleviate the need for the vessel preparation before the anastomosis. The insult to the intimal layer almost always happens while microsuturing, which usually leads to the post-anastomotic spasm. Conventional suture material can cause multiple tissue reaction, leading to the occurrence of aneurysm and vessel occlusion. The learning curve and the time taken to anastomose the vessel using conventional suture are also quite high. All these drawbacks can be fulfilled with the use of the laser. The first repeated success laser use was carried out by Jain and Gornish in 1979. Even though various animal trials have been proven successful, application in human is rarely subjected and recorded. Post-operative aneurysm in the anastomotic vessel on the later stages have been reported in various animal studies based on their histological reports. However, the development of aneurysm is also reported to be less in laser anastomosis as compared to the hand-sewn anastomosis for vessel between 1 and 4 mm in diameter. In our study, no such aneurysm-induced thrombosis was noticed using the laser technique. Comparison between the suturing and the laser requires less time for anastomosis, reduced ischemic time for flap, overall less operating time and exposure to anesthesia, no interluminar foreign material, vessel mismatch can be easily managed. Advantage of laser, in our study, there was a significant decrease in the anastomotic time, which in turn reflected a reduction in the ischemic time and the total operating time. The operating time was reduced by almost an hour on an average. In this study, the anastomosis for laser was just 8 minutes compared to the suturing, which was 35 minutes. There was no tearing of vessels or any thrombus formation. There was immediate refilling of the vessels without any leakage at the anastomotic site. The good healing process of the tunica media in the first post-operative week minimizes the risk of stenosis or pseudoaneurysm formation. Certain studies have suggested that laser have limited tensile state compared to that of the suture anastomosis. However, our study did not show any incidence of anastomosis failure, and all the flap that used laser survived and healed uneventfully. The laser technique favored excellent parietal repair of microvessels, could be considered as a good challenge to the conventional manual anastomosis. To conclude, laser-assisted vascular anastomosis can be a good alternative to conventional microsuturing, as it has reduced anastomotic, ischemic, and operating time, ease of application, minimal vessel preparation, non-involvement of the intimal layer, least endothelial insult, less technique sensitive, and is safer with beginners. The main limitation of this study is the limited sample size. With the result of this pilot study, a larger randomized trial is being planned to properly evaluate the effect of each particular type of anastomosis. As the theme of the Fhno 2021 conference is mitigating complication with technologies and technique, laser could prove a good alternative to the conventional microvascular suturing. These are my references. Thank you. Hello.
I think Dr. Aditya, let me start off. Very excellent presentation. If you at all plan a study, this you said was a pilot study, right?
Yes, sir. Yes, sir.
Yeah. If at all you plan, say, a larger study and all, what do you think would be the primary endpoint of that study? And how many numbers do you think that you would
so the main yes. So the primary aim of a study with a larger group would be the anastomotic time required and the ischemic time, which is mainly required for the success of a microvascular free flap. So the sample size, with a bigger sample size of at least around like 50 patients in each group could be a good result which would give. And the post-operative result of like aneurysm, we would able to find better. The other thing is the patency rate, which helps in the success of the flap is also important. So that could also be considered. And as with the use of the laser, there is a minimal insert to the endothelial layer.
I understand.
So
I just wanted to know the primary, the endpoints that you were trying to measure. And patency, how do you sort of measure and at what time points?
Sir, we do at the interval patency rate, sir, at 5 minutes, 15 minutes, 25 minutes to see the refilling of the vessel by just milking. So we see whether it's immediate or delayed just after the anastomosis is done.
Oh, it is only a subjective thing. So
yes.
How can you objectively evaluate your thing? Any objective measure? Because whenever you're planning to do a study, and
yes, sir.
How do you sort of plan to objectively evaluate? You said that you're wanting to sort of do. That's the reason why I asked you. Otherwise, I would have
yes, sir. Yes, sir.
Right. Anyway, mull over it. I think very interesting, and I enjoyed your presentation.
Yeah. My question is, you didn't mention about that on the second poster day when you normally look at whether the flap takes up or not. Did you find in both the groups any changes, and what is the result, and any complication you encountered?
Sir, in the laser group, actually there was no complication encountered, sir. No post-operative thrombus formation, no vasospasm, like no complication was observed, sir. While in the microsurgery group, sir, 4 cases had, sir, post-operative congestion, venous congestion.
Okay.
Again, was this a subjective evaluation or any blinded person evaluate? So I just wanted to check on that.
So the congestion and the thing was a subjective evaluation on the, sir, within the first 24 hours. So when we evaluated by pricking the flap, the 4 cases had, sir, dark red, and the congestion was there in the 4 cases which we seen in the conventional microsuturing group. While on the other hand, laser groups, sir, all while pricking we had bright red and the diffuse speed of blood when we pricked, sir.
Great. Now, my suggestion, Aditya, to you is whenever you're planning the studies, try to have some objective sort of endpoints and try to have an independent person evaluate it. Because sometimes what happens is whenever you want to present a technology and you are sort of you are doing it and you are assessing it. Sometimes, I'm not telling you, but subconsciously or subconsciously, we tend to have that bias. So whenever you are doing this study in the future time, I think these are certain points that I thought I should sort of inform you or make you aware.
Yes, sir. Surely, sir.
You could have used a Doppler, or you could have looked at an ultrasound evaluation for color Doppler with ultrasound, whether the flow is adequate or not. Something
Yes,
like
sir.
that, or some radiological, like angiographic study, whether how the patency, any difference. Yeah.
Yes, sir. Yes, sir.
Next person,
Yeah, can we go to the next person, Dr. Hira Thomas? Is Dr. Hira there?
Hello, am I audible?
Yeah.
Good afternoon, one and all. Myself, Hira Thomas. I'm a speech and swallowing pathologist, BPS Lakeshore, Cochin. So the title of the presentation is the difference in the speech and swallowing outcome based on the type of flap reconstruction, the insert technique, and the site-selective targeted speech therapy for anterior tongue and the floor of mouth defects. So the need of the study. The anterior tongue and the floor of mouth plays a very important role in articulation. Any defect involving this portion of oral cavity greatly affect the quality of speech. So the speech outcome can be improved with appropriate flap selection and insert technique, along with reconstruction site-oriented selective speech therapy. So the aim of the study to focus on how anterior tongue function varies with different reconstruction techniques and the importance of flap insert and the site-selective targeted speech therapy for anterior tongue and the floor of mouth defects. So moving on to the materials and methods, total participants, total 105 patients, and the participants were divided into group 1, that is anterior and the lateral tongue defects, and the group 2 is floor of mouth defects. So the inclusion criteria, the patients with T1, T2, and T3, anterior, lateral, and the floor of mouth defects, and the exclusion criteria, the patients with T4, oral tongue cancers, and the patients with the recurrence of the disease. So the two groups were studied based upon first one on choice of flap, that is faciocutaneous free flaps, local tongue advancement flaps, and IFAM flaps. And second one based upon the technique of insert, and third one is based on the targeted speech therapy. So both group were assessed based upon speech and as well as swallowing. So speech is assessed on Washington 7-point intelligibility score and also based upon different articulatory signs. So this is Washington 7-point intelligibility score, and the score of 1 means no noticeable differences from normal, and score 7 means highly unintelligible speech. And this is based on different articulatory sites, that is lingo-alveolar, lingo-velar, interdental sounds, lingo-palatal sounds, and the retroplex r sound. Swallowing assessed based on functional oral intake scale, that is FOI scale. Score of 1 means no oral intake, and score 7 means total oral intake with no restrictions. So all the patients were assessed post-surgery and 3 to 6 months post-targeted speech therapy. So the targeted speech therapy mainly focused on the anterior and the tongue tip sounds, along with the tongue range of motion exercises with a certain rhythm pattern. For example, for R and L sound, I can sing like re 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 ro for R alveolar sounds, and also for L sound la 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 la, also with retroplex R sound. Few more anterior sounds were focused, that is one tap for each syllables like sa, ri, ni, sa, and one tap for 2 syllables sa, sa, ri, ri, ni, ni, sa, sa, and again one tap for 3 syllables sa, 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 ri, 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 ni, 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 sa, sa, sa. So and so on. So these are few examples of the targeted speech therapy which we focused. And moving on to the analysis. So this is the pre-therapy speech intelligibility score, and this is the post-therapy speech intelligibility score based on the Washington scale. So it's clearly seen there is a remarkable difference in the speech intelligibility score post-therapy, and better results obtained for IFAM patients as well as the tongue advancement patients compared with the free flap patients. A score of 1 and 2, that is better intelligible speech obtained for the two groups. This is pre-therapy voice graph, And this one is a post-therapy voice graph. In this also a remarkable difference in post-therapy, and IFAM patients as well as the tongue advancement patients showed better results compared with the free flap patients. A score of 7 and 6 obtained for these two groups. This is based on the articulatory sides. In this also, IFAM as well as the tongue advancement patients showed better results, especially for the toughest sound, retroflex sound. So this is a faciocutaneous free flaps for tongue. So this is a pre and the post-operative free flap patients. So along with the choice of flap, the technique of inset also very, very important. That is the exact size of the flap to the defect area is important for better speech and swallowing outcome. So these are the few images of the free flap. And this is lateral tongue advancement. That is for the limited anterior tongue lesions, the tongue advancement can be done, which helps in the preservation of the better anterior and the tongue tip sounds. So these are few more images, better speech outcome for this tongue advancement patients post-operatively. So this is the IFAM flap, that is a technical advancement of the FAM flap, which helps an excellent movement of the flap. So technique of, as I mentioned earlier, technique of inset is also important for IFAM flap. Correct exact size of the flap to the defect area is very important for the proper speech swallowing outcomes. So this is an image how the IFAM patient 6 months post-operatively. So in this image, it's clearly visible how that difference matters. This is another example for the tip and the dorsum of the tongue lesions, how the preoperative and the post-operative. So this is a video which I can show. Sorry, I'm not able to play the video. Okay. So this is how the floor of mouth defects with IFAM flaps. The rotation movement can be clearly visible in this video. And another one is a for floor of mouth defects, how the movement using the free flap. So in this video, it's clearly visible. So this is the mouth opening in the IFAM patients. So moving on to the results, the patients of both group 1 and group 2 had a better speech outcome targeted speech therapy. All speech intelligibility scores, voice scores, and articulatory mode for different patients with IFAM got better results. So moving on to the conclusion, the choice of the flap and the technique of inset plays a very important role for the anterior oral cavity reconstruction, and the mucosal line flaps produced better functional results in the reconstruction of floor of mouth defects. So the limited anterior third tip of tongue defects benefit best from the tongue advancement flaps, and the site selective targeted speech therapy is also important, especially for the anterior oral cavity defects. And the positioning of the correct flap size to the defect size is very important, which helps in the better speech and swallowing outcome for all the patients. So this is all about the study. Thank you.
Thank you for your nice presentation.
Thank you, sir.
So I would like to know, but did you even mention about the staging, the T staging? Because the stage will decide how much you dissect. That will also bring the overall outcome of the reconstruction side and in the speech management and also swallowing management.
Sir, actually, in our study, we included T1, T2, and T3 oral tongue cancers. All the T4 patients were excluded.
Okay. But did you find T1 and T2 and T3 any difference in the speech and swallowing outcome?
Yes, sir, there is difference. If more is the size of the flap and also the size of the resection is also important. And T3 patients, but depends upon the size of the flap and the inset technique. We also saw better outcomes for T2 and T3 patients compared with the T1 patients. But T1 patients performed much better comparing with the other two graphs.
Did you compare with any of the primary reconstruction versus the flaps?
Sorry, sir.
Primary reconstruction, because T1 lesion sometimes can go with the primary reconstruction without going for a flap.
Yes, sir. Yes, sir. But we took the patients T1 and T2, T3, and comparatively T2 and T3 patients were more compared with the T1 patients. So only few patients were there for T1.
Because primary reconstruction always will give a better speech outcome and your swallowing also.
Yes,
when you're treating with a smaller lesion, then giving any term of sort of free flap or local flaps or island flap, whatever it is. So always there'll be some disparity in the speech outcome when you talk about T1 lesion with a primary reconstruction and T1 lesion with a flap reconstruction.
Yes.
No, a great presentation, Dr. Hira. No, I just wanted to understand that, again, the same thing from just to pick up from where Dr. Deepak sir left. Were all the wounds closed, or was any of the things left raw? Nothing like that, right? Everything was closed. Like in the advancement, also it was sutured, and just to understand the thing.
Yes, sir. Yes, sir.
Nothing was left raw to heal by secondary intention.
No, sir.
Okay, that is one thing. The other thing is, I just want, somehow I didn't get the whole thing. All patients received therapy, right?
Yes, sir.
So it was a standard therapy across all the patients received your standard your protocol of therapy.
Actually, every 2 weeks we used to actually follow up the patients. So they are actually doing the speech exercises at home, and every 2 weeks we have a
Yeah, but it was same for all the group of patients.
Yes, sir, yes, sir. And it also depends upon the how they perform and the extent of the lesion.
Great. So what did you actually want to study in this? No, I just want what was your main conclusion of this study? I understand that this is extremely important, and you guys are doing a remarkable job, because rehabilitation of some of these patients is extremely important. But I just wanted to check from the perspective of this study, what was your primary outcome that you wanted to study, and what is the larger message that you want to give us by this study?
Hello, sir. Sorry, sir. Sorry for the interruption.
Yeah, go ahead. Can you hear me?
Yes, yes, sir.
I just wanted to know, because every patient received the standard therapy. So I just wanted to know what exactly did you derive new from the study, and the larger message that you wanted to do from the study is something that I wanted you all to give us, basically.
The speech and the swallowing outcome actually really it has a great impact with the size of the flap selection and the choice of the flap and the technique of insert. So if we are actually the selection of the flap as well as the size and the technique of insert, which helps in the better speech and swallow outcome for these patients. And if we are focusing also the targeted speech therapy, especially we are focusing on the floor of mouth and anterior patients. So we are targeting the speech therapy based on these sounds. So along with the speech therapy and with the proper choice of flap and with the proper insert technique, the patients will have a better speech and swallowing outcome comparing with any other normal individuals.
Great. Thank you, Dr. Hina. And I'll leave it, Dr. Satish, you wanted to ask.
So sorry to interrupt.
Yes.
Just Hira Thomas, not Dr. Hira Thomas. I'm just
sorry.
Yeah, I think it's a nice presentation and a good study about rehabilitation. But then I think what you really want to tell is that a particular kind of flap is better than the others. So that's what your result is.
Yes. IFAM flap at the tongue advancement better for the anterior and the floor of mouth defects. The video which I showed, it's clearly seen how that IFAM patient with the floor of mouth defects is correctly moving, or how that rotatory movement is present for the IFAM flap.
Yeah. Okay.
So you're batting for a flap rather than your therapy. Good.
Yeah. It's based upon choice of the flap, insert, as well as the targeted speech. We are focusing on these three things.
Thank you.
Thank you, sir.
The next presenter is Dr. Sandeep. Is he online? Is Dr. Sandeep there?
Yes, sir. Yes, sir.
Okay, start.
Sorry, sir. I have a problem sharing my slides. Hello, am I audible?
Yeah, you're audible, but your slide is not shared. Can we move on to the next presenter then? Yeah, it's fine. Okay.
Yes, sir. Is it okay, sir?
Oh yeah, it's now seen.
Good afternoon, judges, senior colleagues. Today, I'll be presenting on the role of BRAF TERT co-mutations in predicting aggressiveness of well-differentiated thyroid cancers.
Your slide is not moving. Yeah, okay.
Yes, sir. There is no conflict of interest pertaining to this study. Just want to bring in the definition of aggressive, well-differentiated thyroid cancers. By this definition, what we mean is, like the American Thyroid Association guidelines say, biologically aggressive histological variant like a tall cell variant of papillary carcinoma thyroid, or a hobnail variant, or a columnar cell carcinoma. Or other high-risk clinicopathological parameters like extrathyroidal spread, lymph node metastasis, advanced tumor stages, and extranodal extension. Why is it that we had thought about bringing in these two gene mutations into our study? We actually assessed a panel of genes including RAS, RET, and PTEN genes. But however, we realized that in our population in South India, the most common gene mutations that were seen in thyroid cancers were actually the BRAF and the TERT mutations. Of course, we had financial constraints in doing a bigger panel because of resource constraints, and we also realized that BRAF plus TERT combination has a proven role in prognostication of thyroid cancers. Our study objectives were actually to find out the association of clinicopathological parameters with mutations in well-differentiated thyroid cancers, and also to assess the prognostic significance of gene mutations in predicting aggressiveness of thyroid cancers. Our methodology included experimental study using archival blocks. These archival blocks were collected from 91 patients who underwent total thyroidectomy for well-differentiated thyroid cancers in 2009-2010. We divided them into two groups. One is a clinically aggressive group, and the second one was a control group, which comprised of the non-aggressive thyroid cancers, which were around 43 patients in number. The aggressive group comprised of 48 patients. The treatment was completed based on institutional protocol, and the patients were followed up for a longer time. The workflow included sectioning the tissue blocks, isolating the DNA, DNA amplification, purification of PCR products, and sequencing of the gene mutations. The statistical analysis were done using logistic regression and Fisher exact tests. Our results: the frequency distribution of thyroid cancers, as you can see here, we had around 85% of classical papillary carcinoma thyroid cases in our study. The follicular variant of papillary carcinoma thyroid were around 11%, and the follicular carcinoma comprised of around 3%. Well, coming on to the frequency distribution, in the classical variant of papillary carcinoma thyroid, there were 56% were actually falling into the aggressive group. In the follicular variant of papillary carcinoma thyroid, it was around 20%, and well-differentiated follicular carcinoma thyroid, it was around 67%. Coming on to the prognostic factors involved in aggressive thyroid cancers, we found that there were around 5 parameters which were all significant on statistical analysis with a p-value of less than 0.05. Lymph node metastasis was quite high with around 92% prevalence. Extranodal extension, extrathyroidal extension, distant metastasis, and recurrence. There were around 33% of cases which recurred in our study. So using logistical regression, we found that BRAF mutations were seen in around 58% of aggressive thyroid cancers. At the same time, unfortunately, we also found that around 51% of the control group too had BRAF mutation with a p-value which was more than 0.05. So that wasn't significant. Again, coming to TERT mutations, we found that the aggressive group of thyroid cancers had around 23% TERT positivity, whereas the control group all two had around 19% TERT positivity. Again, this wasn't clinically significant. Coming on to the association of a combination of BRAF with TERT co-mutations in thyroid cancers, in the aggressive group, there were around 10 cases of BRAF with TERT positivity, the co-mutations, comprising of 20% of cases. cases, and the control, whereas the control group also had around 5 patients comprising of around 11% of cases, with an insignificant p-value that, as you can see, this was done using chi-square tests. Coming on to the results, what we realized was when doing a statistical analysis, logistical regression did not show any significant association of any mutations individually or a mutation combinations. In fact, we had tried all combinations, including BRAF positive, TERT positive, BRAF negative, TERT positive, BRAF positive, TERT negative. With none of these combinations had any significant association with prognostic variables like lymph node metastasis, distant metastasis, or tumor recurrence. Chi-square test also did not show any association with mutations within the aggressive thyroid cancer group. So coming to the conclusions of this study, there is no definite association of BRAF, TERT mutations with aggressive thyroid cancers. However, these mutations do have a major role in identifying aggressive variants amongst the early thyroid cancers, especially the T1, T2, N0 stage thyroid cancers, and hence they have a potential role in analyzing and planning adjuvant treatment. What we need is more multicentric trials with larger sample size, with of course more resources, which would actually help us in bringing a conclusion regarding the mutation panel, the usefulness of mutation panel in predicting the aggressiveness of well-differentiated thyroid cancers. With this, I would like to end my talk. Thank you.
So what's your take on papillary carcinoma thyroid alone versus your follicular variegated papillary carcinoma or follicular carcinoma thyroid? Did you find any difference in your both RAF and BRAF and TERT?
Sir, no, we did not find much of a difference. In fact, when we subclassified the groups, we had actually analyzed each group separately. We had 3 different groups histologically, and we had analyzed all 3 groups separately. However, we did not find any clinical significant difference amongst the histological variants either.
So according to the literature, Dr.
Yeah, go ahead.
No, according to the literature, Dr. Sandeep, I think which of the histologies would have more of BRAF and TERT? Any thoughts?
The histology, sir.
Yeah, which histology?
So the aggressive biological variants, like the papillary carcinoma thyroid, the aggressive biological variants, that is the hobnail variant and the torsal variants, they definitely have increased co-mutations of BRAF and TERT.
Generally, they are seen more in papillary. Just to follow out of what Dr. Deepak Ranjan sir had asked. No, the other thing I wanted to ask was what method of detection did you use? Was it IHC or PCR?
No, sir, we had used PCR. We had actually used PCR. We had done a QIA amplification DNA using DNA extraction kits. And after the quantification, PCR amplification was done, and then the sequencing was done.
But then maybe because of that, because generally the literature is, you have data to suggest that at least they are related to adverse histology, lymph node metastasis. It's also poor prognostic in a way. But I guess, as you rightly said, maybe if you've done it in a larger sample, possibly you could have sort of gotten the result. But nonetheless, I think your data is also something that is very important in the contribution to what we understand about these larger mutations.
There are very few studies from our subcontinent, so
And some of these studies did show actually some correlation with the aggressive variants. That's some of the published studies did show some correlation, but yours was not. But again, as I said, it's not different results. They add to our understanding of how the mutations function in our set of patients. Yeah, Dr. Satish.
Yeah, Dr. Sandeep, the same thing I would say. You must have seen the literature on this,
yes,
and
sir.
most of the literature does talk about being a poor prognostic for these. But then, why do you think that you have a different result? Do you find have you tried to find out why you are having a different result? Is it the kind of patients, or is it a sample, or is it the way you've done it?
Sir, we had a problem with paraffin embedded sections because especially in identifying the third mutations, we had a tough we had to repeat our experiment multiple times to actually identify third mutations. And being a retrospective study, being an archival block study, we had limitation in our samples as well. So probably these are the reasons I believe which has actually probably not given us the desired results. Of course, we need to run the samples in a bigger population.
No, these results also are desired, they're not undesired. Like you almost said it is that unfortunately we got the result. But yes, these are, whatever results you have found, they are actually good enough.
Yes,
but for the literature, and you can always go back and think why you got this kind of result as compared to everybody else getting, especially they say when you add the two, you definitely have a high correlation with this kind of disease.
I also agree with Dr. Satish. No, you have to, you're presented to the data. Scientific integrity is important, and we really appreciate that. So we need not your results need not always match with whatever is the standard or something. You may have a different result, but then what is more important, as Dr. Satish and probably Dr. Deepak sir also said, you must sort of introspect as to why it would have happened, and also I think that's really important. Really appreciate your and your team's work.
Thank you, sir. Thank you, sirs.
Can we have the next presenter, Dr. Deepa Nair?
Good afternoon. I'll just quickly share my screen. Is it visible?
Yeah.
Yeah, it is.
So on behalf of the Head and Neck Disease Management Group at Tata Memorial Hospital, Mumbai, I'd like to present the results of a randomized controlled trial. This is a CTRI registered trial, which was funded by the DAY-2. It is prophylactic antibiotics in operable oral cancer, short course versus prolonged course. I have no conflicts to declare. As head neck surgeons, all of us know that surgical site infections are an important cause of postoperative morbidity and mortality. And it not just increases the hospital stay of patients or increased antibiotics and cost of antibiotics for patients, but also can impact the delay and cause delay in starting adjuvant treatment for these patients. Giving appropriate antibiotic prophylaxis is one of the strategies which is known to reduce SSIs. But in head neck cancer surgery, there are very few randomized trials on the role of prophylactic antibiotics in clean contaminated head neck surgery, especially cancer surgery, and there's not very strong level 1 evidence available. So with this in mind, we proposed a trial in 2015 with the hypothesis that administration of 1-day prophylactic perioperative antibiotics was not inferior to 5-day prophylactic perioperative antibiotics in operable oral cancer. Our primary endpoint was to determine whether the administration of 1-day antibiotics resulted in similar SSI rates as those of 5-day antibiotics. It was a prospective, randomized, assessor-blinded, non-inferiority trial with 2 parallel groups. The population was operable oral cancer operated at Tata Memorial Center, patients who were 18 and above with a good ECOG status, biopsy-proven oral squamous cell carcinoma who were planned for surgery, which was clean contaminated. That means they were undergoing surgery of both the primary and the neck, were included in the study. The other usual inclusion and exclusion criteria were applied as well. This is the trial schema. And once the patients were eligible for the study and consented for the study, we stratified them by stage, type of reconstruction, and what prior treatment was received or not. We randomized them, 1:1 block randomization pattern into 2 groups. The experimental group, which was a 1-day antibiotic prophylaxis, and a control group, which is a 5-day antibiotic prophylaxis. All patients received intravenous cefuroxime, amikacin, and metronidazole up to 1 hour prior to the surgical incision or at time of induction of anesthesia. If the surgery went on for more than 6 hours, the dose was repeated after 4 hours. The dose in the short control group was continued for 5 days, and in the test group, it was repeated up to 24 hours. Now, all patients underwent assessments by blinded observers for the presence of SSIs. These assessments were done between the 3rd and 5th day, the 5th and 7th day, and until discharge. All patients were followed up to the development of SSI or for 30 days postoperatively. Now, we define surgical site infection by Johnson's criteria using Johnson's grade 4 or more criteria. If the operating team or the investigator felt that there was presence of SSI and documented that in the case report forms, or there was restart or change of antibiotic for SSI, all of these were considered as surgical site infections. How did we calculate the sample size? Based on our prior data from our hospital, we found a baseline SSI rate of 20%, and assuming the rate of 20% SSI for both groups and a non-inferiority margin of 6%, a sample size of 1236 was planned. Assuming 10% attrition, the final sample size was 1360 patients. In the protocol, we also planned an interim analysis after the accrual of 680 patients with stoppage rules, which define that if you have p-values less than 0.001 or more than 0.004, it would reject the null hypothesis and indicate termination of the study. The primary outcome, of course, was rate of SSI in each group calculated by the chi-square test. Now, I'm presenting the results of this planned interim analysis. Of the 1168 patients assessed for eligibility, 676 patients were randomized, 343 into the experimental arm and 333 into the control arm. Due to some or the other reasons, 16 patients in the experimental arm and 12 patients in the control arm did not receive the allocated interventions. And so we analyzed 327 patients in the experimental arm and 321 patients in the control arm. As expected, the demographics were equally balanced in both groups, this being a randomized control trial. All patients were equally balanced with no difference in the 2 groups with the respects of age, gender, subsite, stage, etc. Coming to the results, the primary endpoint, the rate of SSI, 70 patients out of 327 patients in the 1-day arm developed SSI. 37 patients out of 321 patients in the 5-day arm developed SSI. That is, there was a difference of 9.9% in the SSI rates between the 2 groups, which was statistically significant. If we look at the intention to treat population versus the per protocol population, again, this difference did not reach the non-inferiority margin, which was pre-specified, showing that there was significantly higher rates of SSI in the experimental arm. We charted forest plots looking at preoperative factors like the stage, the prior treatment, but in all of them, again, we showed that patients who receive more antibiotics seem to do better. Similarly, when we looked at intraoperative details like duration of surgery, type of reconstruction, or blood loss, again, everything favored a longer course of antibiotics for these patients. Interesting data which we saw was then when we looked for SSI by tumor stage, patients with advanced tumors had more infections when given less antibiotics. Similarly, buccal mucosa and GBS cancers had more infections when given less antibiotics. An important interesting finding was that when you look at primary closures and local and pedicle flaps, patients who received less antibiotics did worse, but not so in free flap, where there was no difference in the SSI rates, which was statistically significant. Again, when the impact of prior therapy on SSI, patients who had prior chemotherapy, most of them were neoadjuvant chemotherapy, had significantly more rates of SSI in the experimental arm. As these difference in the SSI rates was significant and met the pre-specified stoppage rules, on recommendation of IEC, the study was terminated. Now, this is one of the largest studies on the role of prophylactic antibiotics for oral cancer surgery, and it is the first large randomized control trial in India on the same topic. It conclusively proves that in our settings in India, long-course perioperative antibiotics may be better in reducing postoperative SSIs, especially in oral cancer surgery. Now, when we compare this to data, which is available in literature, Johnson's data, which is the first randomized double-blind study, showed no difference if you give antibiotics, or no benefit giving antibiotics more than 24 hours. Another meta-analysis recently in 2017 showed of 340 patients, showed again no difference in wound infections 1 day versus 5 days. But the difference in these studies is that our study is a very homogeneous population, only oral cancer patients, all are clean contaminated, whereas these groups are not just head neck cancer, but all head neck surgeries. So maybe the results of our patients and our population is different. So I'd like to conclude the administration of 1-day prophylactic antibiotics was not non-inferior to 5-day prophylactic antibiotics in operable oral cancer. And we should now consider 5-day prophylactic antibiotics possibly as better and safer for our patients. Thank you.
Good afternoon, madam. That's a nice presentation.
Thank you.
I mean, maybe I missed out. What is the antibiotic course that you're giving to all of them?
So we gave, as per what our standard of protocol was there, and during our recommendations of infection committee, when we started out in 2015, we used to give all patients injections, cefuroxime, amikacin, and metronidazole for 5 days. That was our standard of care in 2015. Over the years, the infection committee has actually changed the protocols in our institute, and we now tend to give augmentin rather than cefuroxime, amikacin, and metrogyl. But since the patients on this study received the same protocols, so that it was homogeneous in spite of change in the protocols.
And as you know, most of the patients of head and neck would be, the age group 50 to 70 maybe, and maybe have some comorbidities. Did you have any problem giving amikacin for 5 days?
So we had patients in the Tata Hospital. Our population, actually, the median age is around 48 years. It's a lower age group. Initially, we had a couple of patients who are for lower body weight, where the body weight was less than 50 kgs. And so we created an amendment to include only those patients who had body weight more than 50 kgs, so that we won't have a problem with the dosage of amikacin. But otherwise, we had most of the patients tolerated the study without any major side effects.
Deepa, I think I must congratulate you and your team for having chosen it's a relatively sort of straightforward concept, but the fact that that none of the people have managed to do such a study and that you guys have sort of managed to do this, I must really congratulate you and your team for that. Firstly, the other thing, a couple of questions, Deepa, just for my interest and for my larger understanding. Was diaptics a stratification or no?
I didn't get your question. Sorry.
Were the patients with diabetes mellitus were they?
We didn't stratify by that. We looked actually at as a subgroup analysis, comorbidities, especially diabetics, and there was no difference in both groups in the diabetics. So they were equally matched across both groups, but there was no difference in the SSI rates. I didn't put it up because the slide would get too crowded.
Okay. Because sometimes, I think we find a lot of diabetics nowadays, and that might be one of the confounding factors, at least in the infection part. The other issue is that were all the patients taken as the first patient on the day of the surgery, or were there any repeat? Like, you took it at the end of, like, for some 4 o'clock, some quick you talk to the anesthetist and give a case, or was it all the first surgery? Any preference like that was there in your cases?
We treated them as standard of care. You know how the OTs run in Tata Hospital. Wherever we got place, we used to take the patients. The patients were all consented, and the day before, once they were induced, we randomized the patient so that we would know which arm the patient comes on only after induction.
Oh, that's sobering. So that means we can still apply these data to patients who you are taking by begging the anesthetist at 4 o'clock to give this case also. The other thing, of course, just to the follow-up question of what Dr. Satish, you said you repeated the antibiotics at 6 hours, you said, Deepa?
No, at 4 hours. We normally do it if we know that the surgery is going to be prolonged. After 4 hours, as per protocol, we repeated the antibiotics once.
Oh, but amikacin also you repeated?
No.
Or?
Yeah, it's mainly cefuroxime and metronidazole. Amikacin is OD dose.
Yeah. I just wanted to check on that. And again, the same thing as the choice of antibiotics. Like, do you feel that 3 antibiotics is sort of, because when you see across the board, when you see some standard prophylactic antibiotics, we don't really come across this, but I also concur with you. Sometimes I also find even though you want to stop antibiotics for our patients earlier, sometimes based on some clinical parameters, we tend to sort of continue antibiotics for much longer than what we sort of the standard guidelines. So what are your thoughts? And this is very important because this sorts of helps me sort of give these antibiotics for a longer period of time. But your choice on 3 antibiotics versus lesser, I know that you said that based on your infection control committee recommendations, but did you also want to consider 2 antibiotics or omit amikacin, or how is it
Arvind, that's actually very interesting. When we started off the study, Gauri, Anuja and I are co-PIs on the study. And our thinking was that looking at data from thoracic in our institute, we said that we felt that perioperative short course antibiotics will be enough. So we were very strongly convinced. And because there was a dichotomy or there was a difference in opinion in the department, we actually started the study. So I think I was convinced that short course antibiotics is enough. And at that time, our standard of care, like I said, was to give 3 antibiotics together. Since the last 4 years, we have switched to giving only Augmentin as perioperative prophylaxis. But because the study was started before that, patients on the study continued receiving prophylactic antibiotics. My take on what antibiotics should be given depends on what your local organisms and the sensitivity is. So if you see Tata Hospital, and I've not put up that data, most of our organisms are either Pseudomonas or E. coli. So they do respond to Augmentin, but again, it's going to be something which we are going to take back to the infection control committee, the results of the study, and then work on it and see how we can move forward.
Right. My only thing is, by the time your study gets published, then you'd recommend actually the 3 antibiotics, but your infection control committee would sort of say Augmentin, and then it'll sort of
my take would be, rather than the type of antibiotics, and there's actually a lot of data on other meta-analysis which look at the type of antibiotics, clindamycin versus ampicillin. Ampicillin sulbactam is a good combination. You don't need 3 antibiotics, but what you need is possibly longer duration of antibiotics, is what I feel.
One final question: did you do any pre-operative swabs for these patients from the throat or something of that sort?
No,
just to know that, because sometimes I feel and this was done in our medical oncology in a different sort of a setting, and they found a lot of patients had organisms in their throat, in their stool, and all those things, so I thought that could have sort of helped us through.
No, we try to keep it as real world as possible, so that the results could be generally applied. We excluded patients who had obviously infected wounds and obviously fungating wounds which were infected. So in those cases where we felt that there was fungation and there's infection preoperatively, we gave them antibiotics before surgery.
Great. Yeah, thank you. Sorry, I took a lot of time because I was genuinely interested in knowing all these things. Dr. Deepak was saying something, but sir, you have to unmute.
Yes. Now, did you have any data on the radiotherapy, RT or CTRT? Was this the primary treatment without any preoperative?
Yes, so we looked at prior therapy. As a whole, prior therapy does not seem to impact in the 2 subgroups, but when we did a subgroup analysis, patients who have undergone prior chemotherapy, and most of these patients who are in post-neoadjuvant chemotherapy, tended to do poorly, have more infections with 1-day antibiotics as a subgroup analysis.
Because what my observation is, sometimes we get MRSA in those patients. We have few cases who came positive for MRSA post-CTRT or RT or CT as neoadjuvant. So they developed MRSA infection, not resistant to most of the antibiotics. That's why I asked. Okay, thank you.
Thank you, sir.
Thanks.
Can we have the next presenter, Dr. Alok Shetty?
Yes, sir. Am I audible?
Yeah.
Yeah. Okay. Good afternoon. So I'll be presenting this additional data from a phase 3 trial, which is the quality of life analysis of patients with locally advanced head and neck cancer who were treated with concurrent CTRT on one arm with only cisplatin and the other arm where nimotuzumab was added. Small background, we know that chemoradiation does have some benefit over radiation alone, but probably we need further strategies to improve outcomes further. There are also benefits in overall survival. So efforts for improvement in this direction would be things like neoadjuvant chemotherapy, altered radiation schedules, or probably addition of a second chemotherapeutic agent to cisplatin. However, these have not really improved outcomes that much and have not really shown much of a benefit. EGFR overexpression is a common entity in head and neck squamous cell carcinomas and confers poor prognosis. The addition of agents such as cetuximab has shown some survival benefit in along with radiation, and also it has shown a benefit in the palliative chemotherapy setting. Nimotuzumab, which is a more novel molecule, again an antibody directed against the extracellular domain of EGFR and devoid of class-specific side effects, has shown benefit in a phase 2 study. So this phase 3 trial, which was conducted at our center, which enrolled patients who were more than 18 years, involving squamous cell carcinomas of the oropharynx, hypopharynx, larynx, and less commonly of oral cavity, were randomized in a 1:1 fashion with 268 patients along each arm, where one arm received a weekly cisplatin with radiation and the other arm received cisplatin along with nimotuzumab. And patients were followed up weekly, then 3 monthly, and then up to 2 years, and then 6 monthly. So this primary phase 3 trial showed benefit in the PFS, in the DFS, in local regional control, and in but not so much in overall survival though. And some increase in adverse events in the nimotuzumab arm. So we have seen that there are benefits in the DFS, local regional control, and PFS. So, but what about quality of life? So probably we should think twice about adding another drug. If it's going to really affect the quality of life, then one would probably think twice about adding that drug to a standard regimen. So this secondary analysis was done to assess the quality of life analysis in these patients. We know that head and neck cancer and its treatment significantly impacts patients' quality of life. And both acute and delayed toxicities impact the quality of life, especially in parameters such as xerostomia and domains such as physical, mental, emotional, and social health. So this addition of nimotuzumab show improved outcomes, but we need to analyze the impact on quality of life further. So the quality of life assessment was done using standard EORTC questionnaires. So the quality of life questionnaire and the head and neck module was used. So this was collected at baseline at 3 months, 6 months, 12 months, 18 months, 24 months, and 36 months from the date of randomization, depending on follow-up. And the responses were included if they were self-administered and were within the time window, and translated versions were used when needed. So this is how the EORTC questionnaire has come up. So the EORTC questionnaire has mainly components from the global health status, functional scales, symptom scales, and items including fatigue, nausea, vomiting, pain, dyspnea. And this is a more specific module for the head and neck patients, which comprises around 35 questions. So statistical analysis which were done, linear mixed effects model was used, and where there was no data imputation that was performed. So moving on to the results. So these are the baseline characteristics. QOL was available in only 423 patients out of the total 536 patients that were randomized. Most of them belong to the oropharynx group, and most of them were TNM stage 3 or 4. So these were the baseline scores. So the baseline scores we could see were almost similar, or the mean scores were similar across all components in both the arms. Even in the head and neck specific module, the mean scores were similar across all components in both the arms. Moving on to each of the components, so there was a no difference between the two arms in the global. There was, however, change in the global health status of QOL scores over time, which was expected. So it was low during treatment and at the end of 3 months, and improved steadily and plateaued thereafter. Functional scales such as physical function and social function was lowest at 3 months, and then gradually started improving by around 12 months or 18th month. There was some improvement. And in social function, best scores were seen at 36 months in both arms. Again, here there was no difference in both the arms. Role function, there was again a decline at 3 months and then started improving, reaching baseline score by 12 months. No changes in cognition function. Emotional function again lower at 3 months, but then again improved by around 18 months and plateaued thereafter. With respect to individual scales, during the treatment in both the arms, the appetite decreased and nausea, vomiting, diarrhea, and financial difficulties increased. But then this again we peaked at 3 months and then improved gradually over time till 12 months. Again, importantly, no difference in both the arms of cisplatin and cisplatin with nimotuzumab. With respect to again the other parameters, symptoms such as weight gain and there was progressive weight gain that happened after 3 months with higher scores at 18 months, and other problematic components such as dry mouth or xerostomia increased steadily during and after treatment and peaked at 6 months, which we know that xerostomia is a slightly more delayed complication. So what the main components that I would like to say is the longitudinal analysis showed there's no significant difference in the QOL in patients who received nimotuzumab in addition to cisplatin, and the most significant changes in QOL scores over time with follow-up were noted in the physical, social role, and emotional function scales, and also with other parameters such as appetite, fatigue, cough, dry mouth, decreased mouth opening, sticky saliva, sensory and speech problems, need for NG tube and nutritional supplements. The temporal profile corresponds to development of acute and delayed toxicities of any chemoradiation regimen. Though the initial primary analysis showed that grade 3 to 5 mucositis was slightly higher in the nimotuzumab arm when compared to the CRT arm, but this was not really reflected in the QOL scores for parameters such as difficulty in swallowing, cough, pain, all of which are likely to be affected due to severe mucositis. In comparison with certain other studies, I think with respect to at least cetuximab, which was added to radiotherapy. So in this too, the QOL worsened during treatment and improved after cessation of treatment, reaching baseline levels at 12 months. And there was no significance in QOL scores between the treatment arms. Limitations of the study being it is a single center study, and although 536 patients were enrolled, QOL was not available for all patients at various time points. So concluding, I would say that the addition of nimotuzumab is a feasible option in patients with head and neck squamous cell carcinoma who are undergoing CTRT, where there's no effect on the quality of life, but there is improvement in outcomes. So acknowledgement of the head and neck DMG and our Dr. Atanu, who was helped us with statistics. Thank you.
Yeah, I think great presentation, Alok. I really enjoyed your I just wanted to know, is this the commonly used regimen now in your clinical practice?
If feasible, yes. I think costs are a problem with nimotuzumab currently. If not, yes. And the other problem, other issue being with the weekly versus we are probably also shifting to 3 weekly cisplatin in some patients, otherwise 5 patients. But when the study was designed, the weekly regimen was being used. So that is the concern.
So, and anything you can add to the OS outcomes, or I know this is not a part of your domain of presentation, but I just wanted to ask any thoughts on that for you.
As in, so I mean, the addition did not
overall survival outcomes.
There was no benefit in overall survival with the addition of
okay. So even in the updated analysis, you are not able to find any.
Yeah, so this was not this analysis was not to analyze further OS, but I mean, this is only for quality of life, but in the primary analysis, there is no benefit with overall survival.
Right. No, I thought in a longer follow-up, did you all have any different finding, or was the same finding sort of,
So that I have not looked into that. Yes.
And because I'm privy to that data, I've actually read extensively that study. So of course, this is a very new and important flavor, and definitely I think it sort of adds value to what data that you all already have presented. Congratulations to you and your team. I think I leave it to the other judges to sort of share their thoughts. I think.
Do we have any more questions? Can we have the next presentation then? Dr. Bhavya is there, right? She has not presented.
Yeah.
Okay.
Good afternoon, everyone. Sorry for the technical inconvenience caused earlier. I hope everybody can hear.
Yeah, it's audible.
Thank you, sir. So I'll be giving a presentation on tumor host interface histopathological characteristics as a potential predictor of aggressive behavior of oral squamous cell carcinomas. As we all know, oral squamous cell carcinomas comprise of 90%. As we all know, oral squamous cell carcinomas comprise of 90% of all oral cancers, and more than 60% of patients present with lymph node metastasis at presentation. A 5-year survival rate in oral squamous cell carcinomas is around 50 to 60%. Literature review has multiple histopathological factors which have already been proven prognostic impact on the aggressiveness of oral squamous cell cancers. In our study, we wanted to analyze tumor budding, tumor host interface, and immune cell response at tumor host interface. The main, what is tumor budding? Tumor budding is a scattered pattern of invasion of isolated cells, tumor cells or nests of less than 5 cells at the invasive front from variable distance of the main tumor bud. Tumor budding is not only associated with the tumor grade or depth of invasion or tumor differentiation, it also has a strong association with tumor microenvironment, which is defined as a dynamic cellular milieu interacting with the tumor cells, which are undergoing epithelial mesenchymal transition. These cells show these cells show enhanced expression of stromal myofibroblasts and carcinoma-associated fibroblasts, which provide a conducive environment for the tumor bud cells to grow more and give a invasive phenotype. What are the aims of our study? What we wanted to basically evaluate, the main aim of our study was to evaluate the role of tumor host interface histopathological characteristics in predicting biological behavior of oral squamous cell carcinomas, and also to evaluate the association of tumor budding intensity with aggressiveness of oral squamous cell carcinomas. We evaluated, this was a retrospective study of a prospectively maintained database. We evaluated 108 patients with oral squamous cell carcinoma who underwent surgery with or without adjuvant treatment between June 2018 to June 2019. And post-op HPR pathological review was done for the tumor host interface factors. And the invasive front of the tumor bud was identified. Invasive front of the tumor was identified. Tumor bud was identified. Expression of E-cadherin and vimentin were also tested. This slide shows tumor buds or islands of cell nests of less than 5 centimeters size cells. Coming to the clinico-pathological details of our cohort, I would not be going in detail of all the factors we analyzed. Mean age in our cohort was around 48, mostly comprised of males. We had 48 patients of early disease, that included T1, T2, and 60 patients of T3, T4 disease. Type 4 was the most common worst pattern of invasion, and more than 5 millimeter depth of invasion was noted in 90 out of 108 patients. We analyzed tumor bud intensity based on number of tumor buds per hypa field. High intensity budding was named as 5 per hypa field or more, and low intensity or absent when it was less of 5 per hypa field. What are the factors we analyzed? Under tumor microenvironment, we analyzed lymphocyte response pattern, expression of E-cadherin, vimentin positivity, type of the matrix, either fibroid or myxoid stroma, tumor characteristics like tumor bud intensity, depth of invasion, pattern of invasion, tumor differentiation, perineural invasion, and lymphovascular invasion. When we analyzed the results, we compared tumor bud intensity to depth of invasion, lymphovascular and perineural invasion, and other factors like E-cadherin, vimentin, stromal factors, and lymphocyte response. We found a statistically significant association of high tumor bud intensity with depth of invasion, lymphovascular, and perineural invasion. However, I want to stress on a point that when we analyzed high intensity stromal buds when associated with type of stroma, we found that fibrous stroma had a lesser intensity of propensity for high intensity buds. Coming to the results, we noticed that high intensity tumor budding had a significant association with depth of invasion, perineural invasion, lymphovascular invasion with a significant p-value of 0.02 and 0.004. High intensity buds were noted in 44% of the cases who had depth of invasion of more than 5 millimeter, and around 68% of the patients with perineural invasion had high intensity buds, and 43% of the patients with lymphovascular invasion had high intensity buds. And when compared with the stroma, again, as I mentioned earlier, 31% of the patients with myxoid stroma had high intensity buds as compared to the fibrous stroma. The tumor host interface characteristic, the fibroid stroma associated with less aggressive disease. So we noticed a pattern 1 lymphocyte response which had a significant p-value, and pattern 2 lymphocyte response had a significant p-value when noted in early disease and lymph node metastasis, where pattern 1 and pattern 2 was the predominant pattern in early disease and nodal disease with either N0 neck or single node disease. Reduced E-cadherin and vimentin positivity was noted in patients who had multiple nodal metastasis. These are the lymphocyte patterns we noticed. Pattern 1, where you have a dense lymphocyte infiltration. Pattern 2, you have patchy dense infiltration. And pattern 3, there are no patches of lymphocyte infiltration seen. Coming to the current literature, there are numerous studies which already have a proven factor, the tumor bud or tumor budding intensity has a proven impact on prognosis and aggressiveness of oral squamous cell carcinomas. One of the systematic review article was by Amangush et al., where they noticed tumor bud is a independent factor which hampers the overall survival, disease-specific survival, and also the disease-specific mortality rates. There was another study by Wong et al. Who noticed tumor bud high intensity was associated with reduced overall survival and increased disease-specific mortality. To conclude, tumor bud intensity as an independent morphological feature denotes a biologically aggressive behavior of the tumor. Pattern 1 lymphocyte response in fibroid stroma had a less aggressive behavior. Tumor host interface factors need to be included in treatment decision making, which can help for effective and personalized treatment options. And further prospective studies are needed to evaluate the effect of these factors on prognosis and also about the loco-regional recurrence rates and aggressive behavior of the tumor. Thank you, sir.
Yeah, interesting presentation. Of course, tumor budding is a very new concept, and over the couple of years also they've been, as you rightly summed up. What is your main take from your study? Because your conclusions, what you made was more generic. So, did you all make any change based on the tumor bud, or was it just only an observational data?
Sir, we are doing 2 parallel studies. This one, what I'm presenting, is more of an observational, and there's another parallel study which is happening on depth of invasion, tumor budding, and pattern of invasion, specific with survival rates as well. In that study, we have noted the pattern of invasion and tumor budding intensity, like high intensity buds have an impact on overall survival and disease specific survival. And since the follow-up, it has been only 2 years till now, sir, so we cannot comment on the exact overall survival rates.
No, but 2 years is a reasonably good sort of, in terms of head and neck, 2 years outcome should be reasonable. So, any preliminary thoughts on association with this in outcomes from your thing?
So, as I mentioned, we have a parallel study with associated for survival rates as well. In that, we have found, we have observed that the overall survival reduction as well as local regional recurrences are more with patients who had higher tumor bud intensity and also the worst pattern of invasion as well as depth of invasion more than 10 millimeter.
Right.
Can you, is it possible to correlate with HPV negative patient of oropharyngeal cancer? Has it a role in that?
Sir, we have included only oral cancers, not the oropharyngeal cancers, sir.
No, I know, but has it any, did you get any research on that?
No, sir.
Okay.
Great. Looking forward for your formal results, Dr.
Thank you, sir.
Congratulations on a good presentation, and I hope you carry it forward.
Thank you, sir. Yes.
That brings us to the end of the award paper session. Thank you, the judges and the contestants. Since we are running a bit late, we'll wind up here and then go on to the next session. Gurmeet?
Thank you. Thank you.
Thank you. Thanks, Arvind.
Yeah. Thank you. My pleasure, sir.
The next session is evolving issues in neck. Dr. Asim Moinuddin is the moderator. Gurmeet? Yeah. Dr. Asim Moinuddin, professor in ENT and head and neck surgery.
Good afternoon, sir.
Medical College. And his areas of interest are compartment resection in locally advanced oral cancers, epigenetics in oral cancers, and surgical voice rehabilitation.
Good afternoon, sir. Am I audible?
Yeah.
Am I audible, sir?
Yeah.
Good afternoon, everybody. And I would like to thank the organizers for giving us this opportunity. Actually, I would have loved to be there in the beautiful city of Thiruvananthapuram. Just an introduction of my speakers as well as panel. We'll have 2 talks by Dr. Gauri Pantvaidya from Tata Memorial, and she'll be talking on sentinel lymph node. And the next talk will be by Rajiv Michael, and he'll be talking on carcinoma of unknown primary, and he's from Vellore, CMC Vellore. And we have a panel, Dr. Preeti Jain, Dr. Vishal Choksi, Dr. Anand Subhash, Dr. Ramandeep Kaur, Dr. Aman Sharma, and Dr. Vipin Arora. I think we'll start with the talks. I would like to invite Dr. Gauri Pantvaidya, who is from Tata Memorial, and she's done excellent work on the neck, especially her paper on level 4 clearance and tongue cancers, etc. Tongue cancers with clinically N0 neck. So Dr. Gauri, could you please start your talk?
Good afternoon, everyone, and thank you, Dr. Mohyuddin, for that kind introduction.
Thank you.
At the outset, I'd like to thank the organizers for giving me a topic of my choice to speak on, and I'm going to be speaking on today on sentinel node biopsy guided management for the N0 neck. Are we ready to use this in clinical practice? Now, we are all aware of what a sentinel node biopsy procedure is. It's a minimally invasive procedure using radio tracers, which allows us, the surgeon, to identify and excise targeted upper echelon nodes. If the sentinel node is positive, we go ahead and do a complete neck dissection. If the sentinel node is negative, we may be able to avoid a neck dissection. Now, what the sentinel node biopsy is actually doing is it's trying to bridge the gap between diagnosis and treatment of patients with early oral cancers who may have occult neck node metastasis, which forms around 30% of patients which are not picked up on clinico-radiological evaluation. Now, the question that I am trying to answer today is, are we ready for sentinel node biopsy guided neck management in our clinical practice, or are we really stretching ourselves to bridge this gap and getting this into our clinical practice? Now, when you want to implement a technique in clinical practice, there are two things that you need to see. One, you need to see if you have appropriate and good quality evidence for this technique. And two is what is the feasibility and the infrastructure that's available to use this technique in our clinical practice. And we'll look at both these things. We'll first start with the evidence for sentinel node biopsy in early cancers. I must say that sentinel node biopsy is one area which has seen really good systematic evolution of evidence. It started with studies looking at localization of sentinel nodes in oral cancers. This is a very early study in 1998 which looked at lymphatic mapping using isosulfan blue. We then had the study by Sandro Stockley in 2001 that tried to look at gamma probes and radio tracers and tried to standardize the procedure of sentinel node biopsy. Over the next 2 decades, we have over 250 published papers. Many of them are prospective. Most of these papers did look at refining the actual role of sentinel node biopsy, the procedure, looking at the sensitivity, specificity, nodal yield, positive predictive value and negative predictive value. And we, as recently as 2020, had a look at 98 such studies which looked at evaluating the role of SNB in early oral cancer. So a lot of retrospective, prospective studies done in the last 2.5 decades. But what really clinched the role of sentinel node biopsies and what I call the final appropriate evidence for use of SNB in oral cancer are these 3 studies. The SENT study published by Claire Schilling in the European Journal of Cancer in 2015, the Sentimeroral study and the Japanese study both published in the JCO in 2021. The SENT study was a prospective multi-center EORTC group study done over 14 centers in Europe. A really well done study at the time in 2015. Both the Sentimeroral study and the Japanese studies are phase 3 multicentric randomized trials from the French collaborative group and the Japanese collaborative group. Now, both these randomized trials looked at comparison of sentinel node biopsy versus elective neck dissection. I'm not going to have a lot of time in my 12 minutes to go through each of these studies. Most of you all are familiar with these studies. But what I'm going to look at is what are the kind of tumors which were included on these studies for us to know which patients in our clinical practice should we use sentinel node biopsy in. In all the 3 studies, most patients were tongue cancers. In both the Sentimeroral study and the Schilling trial, both had higher incidence of T1 tumors. The Japanese study, of course, had higher numbers of T2 tumors. Whether we could do sentinel node biopsy in the presence of reconstruction, unfortunately, both these randomized trials don't give us details on. But the SENT study did not include patients in whom you plan a microvascular reconstruction. And in none of the studies, we included patients who had previous treatment. So this is the group of patients, if we want to do sentinel node biopsy, and that we're going to target small lesion of the tongue, where probably you don't want microvascular reconstruction without any previous treatment. Now, the SENT study was 415 patient study. Positive sentinel node biopsies underwent an elective neck dissection. Negative sentinel node biopsies were observed. They found that the SNB negative patients had a good overall survival. They had a slightly higher false negative rate, but Claire Schilling has a very nice reasoning for why they had found a nice high 14% rate, and it did not really affect survival. It then came into the NCCN guidelines, and as of today, sentinel lymph node biopsy is given as a choice for treatment of the N0 neck in early oral cancers. The two randomized trials, the Sentimer-oral study and the Japanese studies, both of these were non-inferiority studies, and they very conclusively proved that sentinel node biopsy is non-inferior to elective neck dissection for early oral cancers. So what this all showed us was that the disease outcomes were not any different whether you did sentinel node biopsy guided neck dissection or you did an elective neck dissection. And the final verdict comes from this meta-analysis, which is really hot off the press, published just 10 days back from our group. It is so hot off the press that I must honestly say I haven't really read it very threadbare. Nevertheless, this meta-analysis looks at 3 randomized trials. 2 of them you're aware with. This first randomized trial is a smaller randomized trial from the Amrita group, which has been published in Nuclear Medicine Communications, and they looked at the overall survival rate in only the 2 studies which reported it, and they found that there was no statistically significant difference between SLNB and END for any of the efficacy related outcomes. The pooled hazard rate of death for SLNB versus END was 1.18, which was not statistically significant. We don't expect elective neck dissection to have a superior outcome as compared to SNB, especially in these 2 studies, which were both non-inferiority studies. But what really happened now is that we had a good bit of evidence. All evidence always has a little bit of flaws. There are issues with the possible underpowering of the 2 non-inferiority studies. Cost effectiveness not very well written in these studies, though Claire Schilling has shown that it is more cost effective to do sentinel node biopsy, but whether their cost effectiveness analysis can be applied to us, I don't think it's possible, and we need to do our cost effectiveness study. The use of reconstruction with SNB was not well detailed, and I really think that the major endpoint of a sentinel node biopsy, the major advantage is probably decreased shoulder morbidity, which though was written in the French study is a little sketchy and we are not very sure. And we really look forward to this ongoing randomized controlled trial by Stephen Lai's group, where patient-reported shoulder function is actually the primary endpoint. Now, keeping all of this in mind, what we need to think is the evidence seems strong. What is the feasibility of using SNB in our routine practice? What do you need? You need trained surgeons, you need a good nuclear medicine department, good pathology and radiology backup, you need money, and you need enthusiasm. We are very much in our comfort zone doing a small elective neck dissection, a supraomohyoid neck dissection. And most importantly, at your institution, you need SOPs, you need quality assurance and analysis of your results of this quality assurance to get good results with sentinel node biopsy. At TMH, we are in the process of quality assurance and pilot testing. We have put up this 5-page SOP, which looks at all the procedures for standardization. It has details on how every step of the sentinel node biopsy is going to be done. All our patients will be entered into these procedural details, which is a 4-page pro forma, and we will be analyzing these procedural details. Now, while we are doing this, we find that sentinel node biopsy does have many other clinical implications also. Now, this was the first case of sentinel node biopsy that I did. Early tongue cancer. The first sentinel node that was identified was a 1 centimeter really small lymph node at level 3, level 4, almost at the posterior border of the sternomastoid. And if we really didn't do a good wide supraomohyoid neck dissection, this node would have been missed if I had not done the sentinel node biopsy. It came positive on frozen section and was the only metastatic node at final histopathology. My second case was again a small left-sided lateral border tongue lesion, was clinico-radiologically node negative. Now, if you look at the SPECT scans, as you see the early SPECT scans, the first echelon of spread of this lateral border tongue was actually the contralateral level 4 lymph node, and then as the scan proceeded, we found it coming to the ipsilateral side also. Now, in a small lateral border tongue lesion like this, which was lateralized. I don't think anybody would have thought of doing a contralateral lymph node positive. When we picked this up on sentinel node, on the sentinel node biopsy procedure, this patient had a single contralateral level 4 positive, which was positive both on frozen section and on histopathology. So yes, the feasibility is a little doubtful, but I think there is a whole lot of clinical help that sentinel node biopsy can give you as you proceed to do more of these procedures. So if you look at the summary, sentinel node biopsy directed neck management, I think, is ready for standard of care in T1, T2, N0 oral cancers. But I'd say it's subject to one, availability of a team, availability of infrastructure, and most importantly, completion of the quality assurance at your institution for us to be safe for our patients using sentinel node biopsy. In fact, at Tata Memorial Hospital, we are moving ahead from this controversy of whether sentinel node biopsy is actually standard of care or no. We have now designed a randomized controlled trial of 538 patients of T1, T2, N0 clinico-radiologically N0 patients. This is going to be a non-inferiority randomization 1:1, where one arm will undergo a sentinel node biopsy directed neck dissection, while the other arm will undergo a limited neck dissection, which is a very much homegrown concept for us, where our level 2B would be cleared only if level 2A is metastatic on frozen section. In this randomized trial, we are considering sentinel node biopsy as standard of care, whereas limited neck dissection would be the experimental arm, with a primary endpoint of overall survival and a secondary endpoint of shoulder mobility evaluation. So the final conclusion, I think, would be that sentinel node biopsy is ready to adopt for clinical practice, but you need to have your quality assurance, your infrastructure, and your team in place. Thank you very much for your kind attention.
Thank you, Dr. Gauri, for that excellent presentation. I have a few questions. Of course, I would not take too much time, but you have finished well in time. So you have rightly put it, the cost effectiveness, the feasibility and availability of infrastructure and multidisciplinary team. And I have one important question, which I feel from our point of view, especially in the rural areas. How many early cancers do we get? And even if we get, even a histopath report takes approximately 1 week here. So doing a frozen on table, depending on it, gamma probe availability is another big question. And having a lymphoscintigraphy or planar camera is almost impossible in the periphery. So is it feasible except for a few nodal centers in our country?
So it's a very good question, and I completely understand your situation. And I think if you don't have the infrastructure, and we don't have, then there is absolutely no reason that you should not do an elective neck dissection. An elective neck dissection is a good enough procedure, does not have a whole lot of morbidity. But if you have, and I think a large number of our centers in India would have all of this infrastructure. So the question was whether, if you have the infrastructure, should you do it? My answer is yes. If you have the infrastructure, you should try and do sentinel node biopsy after everything is put into place. But if you don't have, then we have an excellent and a very safe treatment option of an elective neck dissection, which should be what should be done.
Thank you. Do we have any other questions from audience or any of the panelists? Anyway, we'll come back to you, Dr. Gauri. I would request you to be around for the panel discussion also.
Sure. Thank you. Thank you very much.
Thank you. Again, it's my pleasure once again to invite Dr. Rajiv Michael for his talk on diagnostics, rather the diagnostic exercise in carcinoma of unknown primary. Dr. Rajiv. Dr. Rajiv, can we?
Yes. I'm just trying to share my screen.
Yeah.
Is my screen seen?
The slides are not being seen. We are seeing you.
I'm not able to share my screen.
Oh.
Is it seen now?
Yeah, now it's seen. Yeah.
Am I audible?
Yes, sir, you are very much audible.
Okay, thank you, Dr. Asim. And after that excellent talk by Gauri, some back to basics, as I call it, a topic which is a bit of a challenge for everyone, because especially for a junior or a trainee who's starting, and that's where I've started to try to address my talk. Because when you have a lesion staring at you in the face, then staging, management, most of it is a matter of putting together the information that you already have by good documentation, good visualization, good radiology. But when you only have a neck node and no primary, then that is when your knowledge is tested. And that is when it's important to know protocols and to know how do we approach these patients to give them the best results, because some of these studies, which I'll show you, have got excellent results. So by definition, without any ado, I'll start off with the subject directly. And carcinoma unknown primary, or CUP as it's abbreviated, as I'll show you, may be a bit of a misnomer. And a person with a suspected metastatic cervical node and no evident primary cancer is called carcinoma unknown primary, or metastasis of unknown primary. And this terminology should only be used when the patient is already evaluated with a complete clinical evaluation and very often imaging as well. And as the study below mentions, probably the more appropriate terminology is neck carcinoma with unknown primary. So they suggest the abbreviation NCUP rather than CUP, because carcinoma unknown primary is a widely used term for infraclavicular cancer metastasis as well. Now, as per the latest TNM staging, when you say T0 or no obvious primary, that means that node is already negative for P16 and EB1. That means you've already tested the node for these two. Now, this is very often the presentation that you'll get in your clinic of somebody with a lateral or a neck mass, which is persistent and progressive and no other symptoms at all. So this occurs about 1 to 7% of the time. And this percentage, studies have shown, declines with the extensiveness of your search for the primary. So if you do a good complete history and physical examination, including an endoscopic evaluation under general anesthesia, and I'll show you what they allude to, the percentage drops from 7 to a maximum of 3%. And many studies have now suggested that neck carcinoma of unknown primary is increasing merely because a larger number of patients are HPV positive oropharyngeal cancers. And because of the peculiarities of both the palatine and the lingual tonsil, sometimes a small primary can be well hidden. So when you see this diagram, what should strike your mind is the old adage of a supraclavicular node, look below the clavicle. So if you have a level 4 or a level 5B node, look for infraclavicular causes in your mind. If you have level 1 to 3 and 5A, look for an upper aerodigestive tract primary. So we focus on patients who are 1, 2, 3, and 5A. These are usually squamous cell carcinomas, usually from the upper aerodigestive tract, the sites which we know. You can often also get papillary carcinoma thyroid, melanomas, Merkel cell carcinomas, neuroendocrine carcinomas. These are rarer. Salivary gland cancers, the commonest would be adenocarcinomas and mucoepidermoid carcinomas. If you have an isolated supraclavicular node, that is lower level 4 or 5B, you have to include infraclavicular causes in your evaluation. The classical Virchow's node, we all know from our surgery textbooks, the commonest causes in the gastrointestinal tract. Rarely, don't forget that in a supraclavicular node, you can have a brachial plexus tumor, you can have a tumor of neural origin, or you can have a soft tissue sarcoma. Increasingly, a lot of fibromatosis also can present as a mass in the neck. So symptoms, this is something I'll skip over quickly. Patients can come with ipsilateral autalgia, nasal obstruction, persistent voice change. Don't forget the ipsilateral hearing loss or the ipsilateral autalgia, which can be the only symptom. Also look for type B symptoms. What are type B symptoms? Fever, weight loss, night sweats, widespread lymphadenopathy. Don't forget to examine the abdomen, because this could mean you're dealing with a lymphoma rather than squamous cell carcinoma. There's been a lot of interest in narrowband imaging, and we have a recent paper from our institution as well, where we looked at narrowband imaging in all patients with hoarseness of voice. And we found, and this study as well has shown, that a significant number of patients in their meta-analysis, out of 169 patients who were classified as unknown primary, 61 could be picked up, a primary could be picked up just with narrowband imaging alone. So this tool adds a significant shift in your diagnostic accuracy. An open lymph node biopsy is not appropriate as the initial test of choice unless you're suspecting a lymphoma. An FNAC, this we all know, this is standard knowledge, is the test of choice. In most neck nodes, the FNAC will be positive in upwards of 80%. Now, where can this be false negative? Usually in cystic nodes or in nodes with a large necrotic center. So if you've tapped that, then you may not get a positive FNAC. What do you do if your FNAC is negative? You can add to the sensitivity of the FNAC by doing it image guided, or as often done nowadays, an outpatient procedure of a core needle biopsy can be done by the surgeon himself. This gives you more tissue, particularly for immunocytochemistry. Now, very often we see inconclusive FNACs. So your pathologist tells you he doesn't have enough sample. This could be either due to the sample error or to the paucity of viable material. So if you only see a few atypical cells, what do? You can ask your pathologist to do a P16 and or an ISH for HPV along with EBV. So these two are now considered basic standard, which you should ask for in all your FNAC cell blocks. Now, from an FNAC cell block, it's also possible to look at P53 mutations, to do other markers like PAX8, cytokeratin, TTF. If you get only fluid, you can do a thyroglobulin level on your fluid. An initial core biopsy, according to this study and some other studies, may soon become the investigation of first choice, especially if you have an accessible node and you have the facilities to do a good core needle biopsy. So far, we've done a good complete history and a physical examination. You've done an endoscopy with narrowband imaging. You've done your FNAC, but you still don't have a primary. So where do you go? So if your FNAC shows carcinoma, the imaging of choice in most guidelines is a PET CT scan, either a whole body PET CT scan or a regional PET CT scan, at least till the diaphragm. For many reasons, and in our country, as Dr. Asim pointed out, resources are very scarce in most of our rural areas. So if for some reason a PET is not possible or not feasible due to technical reasons, a basic minimum is a contrast enhanced CT of the neck and thorax. Where do you ask for an MRI if you find induration on the tongue base or if you find induration on the tonsils? So you're suspecting an oropharyngeal primary, or you suspect a lesion in the parotid, which is poorly defined on other imaging. An MRI at the skull base or the parotid or the tongue base may add to your knowledge. So what really is the role of an ultrasound? Now, in our country, I believe that an ultrasound still has a large role to play, because this may be your initial screening tool. Don't forget, tuberculosis is still very rampant in our country. A guided biopsy can be added to your ultrasound. It can tell you about the characteristics of the node, whether the node has a necrotic center, is it a cystic node? So your likelihood of getting a positive FNAC increases with the ultrasound. So far you can land up with three scenarios. You can land up with a patient whom you've labeled as T0 with a P16 positive result on your FNAC. There you will treat this as oropharyngeal cancer. Or you have T0 with Epstein-Barr virus positive on your FNAC, you will treat it as you would treat nasopharyngeal cancer. Or you have an obvious primary which has been picked up by your PET or your narrowband imaging, you treat as per the guidelines of the primary tumor. Now, recently there has been, with the advent of TORS and TLM to the armamentarium for an unknown primary, there's been a lot of literature on the role of examination under anesthesia added to a pan endoscopy, a tonsillectomy. Now there's a lot of debate. Do you do ipsilateral? Do you do a bilateral tonsillectomy along with a lingual tonsillectomy, or as the TORS terminology goes, a tongue-based mucosectomy? Along with this, in this particular study from the University of Washington, which was published in Laryngoscope and back in 2011, they did a neck dissection, actually ipsilateral 2 to 4 and contralateral 2 to 4. And they only radiated adjuvant RT based on risk factors. So in many of their cases, we'll look at this paper later, they actually did not radiate the contralateral neck, and they spared large areas of the pharynx, thereby decreasing the morbidity of wide field mucosal irradiation. If, on the other hand, you have an isolated supraclavicular node, direct your attention also to the pelvis and the abdomen. If you still don't find your primary, possible neck dissection or radiotherapy depending on the characteristics of the node. If your FNAC yields a adenocarcinoma or a salivary gland origin tumor, if this is from the upper nodes, you can consider adding a parotidectomy to your neck node. Or if you have an supraclavicular node, look carefully for an infraclavicular primary. Now, I've looked at a few papers, and this was one interesting paper which looked at the management of HPV-related unknown primaries, which forms a very significant part of the literature on unknown primaries. So this study was an observational cohort study of 65 P16 positive primary patients from 2001 to 12. And just look at those survival rates. These survival rates are almost 100%, 5-year survival rates. And they justify the 100% in the undetected group by saying your tonsillectomy might have overtreated or tackled your primary tumor. And therefore, your undetected group is also coming up with a survival of 100. Okay. Many patients, they could avoid radiation to the pharynx. They did not radiate the contralateral neck. Now, this is not standard practice again in our country. So this was the flow chart that they used. So you start with the neck node, and on your FNAC, if you get a P16 positive neck node, you then plan for a EUA under anesthesia with a transoral search. So they have used the operating microscope to then look for potential sites of primaries, including the palatine tonsil, the lingual tonsil, the nasopharynx. Now, using the operating microscope, they've then sent frozen sections from these sites. And if the frozen was positive, they proceeded to resect the area till they got a negative margin. They combined this with a neck dissection that completed your treatment. If on your search under anesthesia, you did not find a primary on frozen, you then proceed to do an ipsilateral palatine and lingual tonsillectomy. They also went ahead and did biopsies from the contralateral lingual tonsil. They sent all these again for frozen, and they went ahead with a neck dissection, again, as I said, 2 to 4 ipsilateral and contralateral. If your primary is identified, you resect with margins negative, no further resection is required, and your radiation can be tailored to the risk factors that you have. If you have a margin positive, you can always go back in and do a second transoral resection. This could be with TORS, it could be with transoral laser, depending on the technique you use or that you're familiar with and what you have in your institution. Your nodal staging can also decide the treatment that you do. So if you have an unknown primary with a single node, or your nodal staging is N1, they strongly suggest that your initial treatment of choice should be a neck dissection rather than radiotherapy. Okay, and this should be combined with the previous panendoscopy along with an ipsilateral tonsillectomy and a tongue-based mucosectomy. If you have multiple nodes, so N2 or N3, with or without ENE, they suggest induction chemotherapy or CT-RT as the treatment of choice. All these decisions were made MDT based after discussion with the radiation oncologist as well. So you have quite a complex algorithm for this management, and that's what adds to the confusion. So you start with the pathological lateral neck mass, and all these three arms have equal weightage. So your complete examination, your FNAC, which if negative leads to a core biopsy, and probably a baseline as a CT. Now, if any of this show a carcinoma, squamous cell, you straight away go to a baseline PET CT scan, which from 20 to 40% can directly pick up your primary tumor. You can do a panendoscopy, an ipsilateral, tongue-based and palatine tonsillectomy, contralateral tonsillectomy, a bit of, again, a debate in literature. Avoid circumferential oropharyngeal resection is what they say. It's not very clear to me what that means. Along with the neck dissection, IPSI and contralateral. This should be the management of choice, according to them, to achieve a success rate of close to 100%, 5-year survival rate. But remember that a majority of their patients, and all these studies were from HPV positive. Now in our country, we still await literature as to the exact percentage of our patients who constitute this percentage of HPV positive unknown primary tumors. There is a significant paucity of literature in the subcontinent regarding this. So I'll go back to guidelines, both the NCCN as well as the Royal College or the UK guidelines. So all your patients with an unknown primary should have a PET CT as a baseline if possible, combined with a panendoscopy, a tonsillectomy, both palatine and lingual. In a majority of cases, your treatment should include clearance of the neck at the same sitting, since you have the patient under general anesthesia. If your policy is not to do an upfront neck dissection, CTRT is a valid alternative. If at all you don't use upfront surgery and use surgery only as a salvage, then definitely IMRT should be the treatment of choice. Thank you.
Thank you, Dr. Rajiv, for that excellent talk. You have hit quite a few nails on the head. The only issue is when we are talking of PET CT, of course, you rightly told where it's not available or not affordable, you can go in for a contrast enhanced CT scan. Same thing, the guidelines also say, the NCCN guidelines. And if that is negative, you have no option but to send the patient for a PET CT. My question is, quite often we do come across squamous cell carcinoma low down, presenting with a supraclavicular node. And often we say the primary is most often in oropharynx. What is your experience regarding hypopharyngeal primary throwing nodes here, or any other non-squamous malignancies throwing nodes low down in the neck as CUP?
So if we take the patient for a panendoscopy, then definitely we include hypopharynx in our evaluation. So we don't stop with oropharynx. I totally agree with you. I would pay equal attention to both rigid endoscopy of the nasopharynx. So the old adage of ipsilateral fossa of Rosenmuller, ipsilateral PFS, we would still do that. We don't stop with oropharynx. Even though in all Western literature, the focus is on the lingual endopalatine tonsil rather than on hypopharynx or nasopharynx.
But of course, that, as you rightly said, they deal with different cancers. Many of them are HPV positive. And regarding the prevalence in our country, whatever few studies have been done, it's mainly urban. The prevalence is less. And in rural area, we did a study here. Out of 60 cases, of course, it was slightly misdirected. They did on oral cancers, nil HPV by RT-PCR. We need to do that. We need to do that more for the pharynx.
Yeah, we have 2 papers as well on HPV with laryngeal and hypopharyngeal cancers. Again, we didn't see anything at all. The Western literature says 26% up to 40% for even larynx and hypopharynx.
Yeah.
And the second thing is we see a lot of patients from the Northeast and from the Eastern part.
Yes,
we tend to see more of nasopharyngeal
nasopharyngeal
primaries. So again, we tend to be quite aggressive with our biopsies of the nasopharynx. And I would even refer to my colleagues for a more deeper biopsy, because I think a wide field mucosal irradiation should not be the treatment of choice because you haven't looked hard enough for your primary.
Sir, can we start the panel because we are running?
Sure, sir. Yeah, I think I'll invite the other panelists, and I would request Dr. Gauri and Dr. Rajiv to be around when the panel goes on. Dr. Preeti Jain, she is head of the Department of Surgical Oncology from Mahavir Jain Hospital, Patna. Dr. Vishal Choksi, the Director Head and Neck Cancer Surgeon from Apollo, Hyderabad. Dr. Anand Subhash, Head and Neck Oncologist from HCG, Bangalore. Dr. Vipin Arora, the Director of ENT and Head and Neck Oncosurgery, University College of Medical Sciences, Delhi. I beg your pardon. I would like to know which specialty Dr. Aman Sharma and Dr. Ramandeep Kaur belong to. Madam Ramandeep Kaur and Dr. Aman Sharma, can you please update me?
Hello, sir. I'm Dr. Ramandeep Kaur, and I'm a consultant in Patel Hospital, Jalandhar.
Oh, Jalandhar. Okay.
Yeah.
With Dr. Shamit. And
Yes, sir.
you are
Yes, sir.
you are surgeon or radiation oncologist?
Sir, I'm a head and neck surgeon.
Yeah. Thank you, madam. Do we have any radiation oncologists? What about Dr. Aman Sharma?
Good afternoon, everyone. Thanks for the invitation. I'm Dr. Aman Sharma. I'm assistant professor working in NCI, National Cancer Institute, Jhajjar AIMS, and I'm a radiation oncologist.
Okay, sir. So we have one radiation oncologist. Otherwise, it's a panel of mainly surgeons. Thank you. Well, let me start off right away with my slides. Are my slides visible?
Yes, sir.
Yeah, we can see the slides, sir.
Yes, sir. I think we'll proceed. This is my esteemed panel. It's indeed a pleasure to be with you. These are the topics which have been discussed in detail. I'd just like to touch a few issues. Of course, we are running badly short of time, and we should have started at 3:15. I'll try to make it as short as possible, but I would like to touch upon issues which are relevant to our population, which includes rural population. So just a few touches on sentinel lymph node and carcinoma unknown primary, which have been spoken of so well by both the speakers, and a small touch on small primary with large neck node. And I would like to specify radio sensitive primary. The role of neoadjuvant chemotherapy also has been touched upon by Dr. Rajiv. A few issues would just revisit here. As we all know, management of neck remains one of the most important parameters in the outcome of head and neck oncosurgery, and it has almost predictable pattern of drainage, and the levels have been detailed. I'll not go into it. The only problem is in a comprehensive neck dissection, be it radical or be it modified radical, there is morbidity. Even when we save the accessory nerve, we have about 25 to 30% cases who have injury to a spinal accessory nerve. And we are seeing the outcome here. It does have significant morbidity. And this can, because of this, they went in for selective neck dissections. Again, I'll not go into details, but definitely brings down morbidity. But I would like to highlight, even in this, the level 2, particularly if you are clearing level 2B nodes, you will have accessory nerve dysfunction. You are seeing the difference in the appearance of the two as well as the functionality. We had an excellent paper in NEJM from Tata Memorial, which insisted on elective neck dissection, of course, with a lot of evidence. But in spite of that, we have to acknowledge the fact that almost 70 to 80% of elective neck dissections are node negative on histopath. And as I said, accessory nerve injury is quite common, and most of our patients are manual laborers for whom their livelihood depends on their shoulder function. So came in the super selective neck dissection, so aptly spoken by Dr. Gauri. And one point I would like to re-emphasize, just for my younger colleagues in the audience, all this talk about selective neck dissection or super selective neck dissection holds good when you are addressing a small primary, which can be tackled transoral. If you have to raise a cheek flap, there's no reason why you should not do an elective neck dissection. all examples of small primaries which can be tackled transoral or by laser. A special mention here, a verrucous carcinoma. I would like to ask my panelist, Dr. Preeti Jain, would you do an elective neck dissection, or if you have the facility, a sentinel lymph node biopsy in this case? Dr. Preeti?
Yeah, good evening, everyone.
Yeah.
Sir, having said that, this is a verrucous carcinoma.
Yeah.
See, at a good number of times, we have seen that on final histopathology, when we excise these lesions and send for histopath, you get quite a bit of infiltration.
Yes.
And lymph node metastasis is a possibility in these cases also.
Yeah.
So, given that we do not have facilities for sentinel node biopsy at our center, we definitely would like to go for an elective neck dissection in these cases, because one of the factors is that our patients, they come from far off places. They can't be relied upon for their follow-ups also. So I would like to go ahead and do a decent selective neck dissection.
Yeah, you brought out a very good point. In fact, there are large studies from Tata Memorial, 101 cases verrucous carcinoma. Even we published about 52 cases recently. We are seeing node positivity in very innocuous looking lesions. So the dictum that a T2 requires attention to neck is a must. Dr. Gauri, my question to you, in the periphery, we have been using methylene blue, or even few areas have been using isosulfan blue, with sentinel lymph node started with it. My major issue here is whatever we are injecting peritumoral is blind. And as we know with Abraham's study, depth of invasion is a major factor which influences lymph node metastasis. So are we really addressing the real issue where we are injecting blind? We don't know how deep we are injecting unless it's image guided. If we inject deep and have a sentinel lymph node at any particular level, what are the chances of having histopath negative nodes in this? Because on an average, they say 1/3 of the sentinel lymph nodes harvested show metastasis.
Right. So I think your question has two parts. One is on the only use of methylene blue in centers which doesn't have radio tracers. I would not recommend that. It has not been standardized and shown to have reliable rates. As of today, you could use radio tracers or a combination of radio tracers with methylene blue, but only methylene blue really is not today to be done for sentinel. With regard to the injection technique and the depth of invasion, if for sentinel node biopsies, as I showed in my table, you are going to choose very small tumors. You're not going to be choosing very deep tumors, and that's why you'll be most of these studies chose only T1 tumors, in fact. So really, the procedure for sentinel node biopsy injection is very standardized. You give it in 4 quadrants. These tumors are not very deep, not very thick. If you have a very thick tumor, you probably will not take this patient up for sentinel node biopsy for the reasons that you said. So anything that's going on to T3 because of its depth of invasion, you wouldn't take for a sentinel node biopsy. For everything that's T1 and T2, you can very reliably on your palpation, because you inject it in 4 quadrants, give a good enough amount of radio tracer to the primary tumor and pick up the sentinel nodes.
But one issue, Dr. Gauri, most of the studies take 4 mm depth as cutoff for injecting the radio tracer or the dye.
Yeah, so if you looked at the Japanese study, they looked at 4 mm, but they had 4 mm as the cutoff. So, which is exactly what I was trying to tell you, that you should use thin tumors, early tumors, not very deep and thick tumors.
So would you image it before going in for sentinel lymph node biopsy?
We will definitely be doing an imaging for all our tongue cancers, except for very really small ones. In all tongue cancers, we definitely image our patients with an MRI.
And as you rightly said, you can see even with a blue dye, it's not uniform uptake, it's just speckled patches.
Yeah, it's not a very standardized method if you're using it alone. It's been proven in even breast cancer, in penile cancer, that only methylene blue is not something that you can do single. You can combine it or use only radiotracing.
Exactly. And my next question would be to Dr. Vishal Chokshi. Sir, of course, in Apollo you will have, earlier you were in government service, I think in Gujarat Medical College. What was your experience with the availability of radio tracer, gamma probe, or a lymphoscintigraphy?
Yes, hello, Dr. Azim. We didn't have any of these technology methods at Gujarat Cancer Research Institute, nor do I have it even at Apollo in Ahmedabad. So I used them previously when I was in the US, but not in India for the last several years.
Exactly. So when we don't have a gamma camera or a gamma probe, the SPECT is quite out of question in peripheral institutions.
Right.
So I come back to our questions. Is it reliable in this environment? Dr. Gauri has said yes. If you have the infrastructure, if you have a multidisciplinary team, you can do it and you should do it. Now, weighing the advantages and the pitfalls, as the literature says, it's best suited for oral cancer, which can be removed transoral. And a difference from Western literature, I know Maharashtra and Gujarat, there are more tongue cancers, but in Southern India, we mainly deal with lower gingivobuccal sulcus, mainly buccal mucosa. And another issue is a frozen section is not always available, and if available, they take their time. So adding immunohistochemistry to it, or RT-PCR, which the literature mentions, could be, you'll be getting the reports RT-PCR at the best next day. And I had seen maybe after 5 or 6 days. So in the periphery, it's still not that easy to make this a standard of care. But yes, we need to move towards it. This is another problem. I would like to ask Dr. Vipin Arora. Sir, in the setting of submucous fibrosis, which is so common in our country with trismus, and also a tumor from the lateral border of tongue extending into oropharynx, how effective would you think sentinel lymph node biopsy would work out here?
Thank you, sir. So these are the two images of the same patient?
Pardon? No, it's different patients.
These are two different patients.
Yeah.
Okay. So the patient which has a tumor on the lateral border of the tongue, I think it is a T2, maybe at the most T2 tumor. So currently the standard practice is to decide the neck dissection based on the site and size of the tumor.
Yes.
On the basis of which we decide in which case we need to do a neck dissection. We do neck dissection in most of our cases except for very small primaries.
Yeah.
Otherwise, we do neck dissection in most of our cases. But as far as sentinel lymph node biopsy is concerned, we do not have the infrastructure to do a sentinel lymph node biopsy. But as Dr. Gauri rightly said, that if you have the infrastructure, go ahead and do it. So I have the same philosophy. We don't have it, so I can't say about these.
Exactly.
But certainly I would do a neck dissection in this patient.
Sir, you brought out another question here for a small primary. There is literature coming out these days that even with T1 tongue cancer, we need to address the neck.
Certainly, sir. It is, so we decide on the basis of size and site also, sir.
Yes, sir.
So tongue, there are more chances of throwing metastasis rather if the same lesion is on the hard palate.
Yeah.
So I think a small tumor, maybe a centimeter or so, we would not have decided to do a neck dissection in this patient. So site and size both has to be taken into consideration along with the depth of invasion.
Exactly. Dr. Gauri?
Yes.
Yeah, just a few more
Sure.
questions to you. One pitfall, or rather limitation, of sentinel lymph node biopsy has been emphasized in floor of mouth tumors. because it's like holding a torch against the sun. When the primary tumor itself shows the radio tracer, the actual lymph node lying just beyond the floor of mouth may really not be picked up. That is one area. And another is when we use a radio tracer, there may be delay at the site of injection to reach the lymph node. What is your take on this? How often does it happen?
So two things. One is that for floor of mouth lesions, I agree with you. There is a problem with using radio tracers, but many people have circumvented that, and now people are using doing sentinel node biopsies even for floor of mouth. I do not have any experience. I have still not done a floor of mouth cancer for sentinel node biopsy. The one thing that you can try using is ICG, because ICG is something that does not have it's again a dye, so you won't have a problem with the shine through effect, but again that's not been very well standardized yet. So floor of mouth tumors, I would say, would be, especially when you're just starting with your sentinel node biopsy, would be a contraindication for sentinel node biopsy. And what was your second question, sorry?
The delay at the site of injection.
Yeah, I from whatever sentinel node biopsies that we have done, we have not found a great amount of delay. We have found the sentinel, so the pickup of sentinel node biopsy with a radio tracer, if it has been done in adequate time, adequate dose has been given, is generally standardized. You will pick up a sentinel node sentinel node in 99% of your patients. That's what literature says, that you will pick up at least 1 to 3 sentinel nodes. So if you're not picking up, then it's probably an issue with the amount that you are injecting, the way you are injecting, and those are the things that need to be followed. The good thing is now with all these randomized trials, the SENT study, they have described how to do the sentinel node biopsy. The whole SOP and protocol is described in these papers.
Even the quantity of radio
just have to follow that systematically, and we'll probably get a sentinel node biopsy in almost all patients.
Yeah, even the quantity of radio tracer used has been described, but then even then there is up to 4% chances of not getting sentinel nodes and having it positive on HPE.
Most definitely. So if you don't get a sentinel node biopsy, the sentinel node, you must do an elective neck dissection in that patient. You can't say the patient does not have a metastatic.
Exactly.
You should do an elective neck dissection in that patient.
Yeah, I think that's a take-home message.
Yes.
And of course, there are few more things described in literature. For example, whatever they call delay, they say it's due to large molecules and the solution is soluble, small molecules for injection. And blue dyes have to be tagged, as Dr. Gauri has said, with radioisotope, and preferably, if available, monoclonal antibody again against the antibody to what is it? The epithelium calcium adhesion molecule, or you can use fluorescence, as she said, indocyanine green, and again in large lymph nodes. Suppose there's a large lymph node on one side and a primary tumor close to midline, as you rightly showed in your talk, you can pick up contralateral nodes. So how often do you see that? Dr. Gauri, I think you have muted.
So you're asking me in a large tumor or in a small tumor?
In a large tumor, say a T3 tongue.
Yeah, so in a large tumor, it will depend on whether the tumor is crossing the midline or no. If the tumor is crossing the midline, there is higher incidence of contralateral nodal metastasis.
Yeah,
The other factor on which contralateral nodal metastasis largely depends on is ipsilateral involved nodes. So depending on those two, so if you have a large tumor, you'll never do a sentinel node biopsy, you'll probably do a contralateral neck also.
No. If it's reaching the midline or crossing it, you will do. But there are a few cases mentioned in literature where even when the primary, a T3 or a larger volume T2 is not reaching the midline, you do have contralateral nodes. In fact, that's one of the plus points mentioned in literature.
Yes, for sentinel node biopsy, I do agree that you would pick up a contralateral node. I don't know if we are going to pick up as we go and we gain experience. I don't know if we are going to pick up a whole lot of unnecessary contralateral nodes. So you will be taking incisions on the other side. In the case that I did, it turned out to be positive, but you may be just picking up. So We will know the answer to that only after we do a good bit of number of cases on contralateral nodes. But yes, that is a very well-known advantage of sentinel node biopsy.
Thank you. As you rightly said, indocyanine green has a role, and there have been other small molecules. For example, they call it tilmancetam or lymphoseek, or the trade names. The actual name is a very long name, diethylene penta-acetic acid, mannal glucose, etc., etc. Anyway, I'll not go into it, but then the small molecules have very long names. So sentinel lymph node biopsy is an upcoming field. It's here to stay. And now we go on to the other area. With this, I would also like to address small radiosensitive primary and large node. Dr. Rajiv Michael, I would request you to be around, please. As you rightly said, up to 5% of malignancies in head and neck turn out to be MUOs, and cause and etiology can be the primary tumor could have been destroyed by the patient's immune response, or it may be a very small tumor which has not been picked up. Even with a PET scan, you need to have 2 mm diameter to be picked up. And you have given a very vivid description of how to evaluate the diagnostic workup. Suppose you get a patient like this. This was an interesting case we had. A large node, supraclavicular, on the right side. I repeat, on the right side. And if you look at almost globular, I would hardly expect a squamous carcinoma in this. What are all the areas we would look for? I would like to first invite Dr. Ramandeep to answer this.
Thank you, sir. Sir, as you have mentioned that this is a large right side neck node is there, and I would first of all do a Fhno, a fine needle aspiration cytology of this lymph node, and see what is the histology.
As
Then depending upon the histology, and I'll simultaneously do the mucosal examination of the oral cavity oropharynx as well as the hypopharynx, the larynx also, and I would see, like, if suppose the primary, if the Fhno comes out to be a squamous cell carcinoma, and I don't get any the primary any primary site, then I would go for a PET CT, whole body PET CT scan, to see to know that where is my the primary.
Yeah. Dr. Rajiv, my question to you.
Just one added comment, that if the patient is a lady, it's important to do an examination of the breast.
Yeah.
Right, sir. Right, sir.
Before we proceed with any other tests.
Dr. Rajiv, I would like to take your help here also. Would you suspect the esophagus or maybe the lung as a primary tumor in this?
Being supraclavicular in origin and this size of a tumor, if there are no other symptoms, we'll have to consider strongly an infraclavicular primary also. One, because the patient is a lady, and two, because of the size of the node with no other symptoms.
Very true.
To me, an infraclavicular primary would be remain hidden for a longer time rather than a head and neck primary.
Exactly.
Can I interrupt here, sir? Can I interrupt?
Yeah, sure.
I would also be interested in seeing the thyroid of this lady, because she being a female, having a supraclavicular kind of a location. Exactly. I don't mind looking at the thyroid also in this case.
Exactly. I think you partly answered my next question. This was a very interesting case. The Fhno showed squamous carcinoma. Esophagoscopy was normal, breast was normal, and thyroid showed nodule in both lobe and turned out to be follicular neoplasm on Fhno, but the node was squamous. So are we, Dr. Michael, are we seeing two primaries, or maybe a primary which has disappeared due to body's immune response, and thyroid is just a incidental pickup?
So first of all, you'll need, in addition to your current imaging, I assume you would also done an ultrasound of the thyroid.
Yeah.
You categorize the thyroid lesion.
We did a guided FNA from both the nodules. Both were follicular neoplasm, Bethesda 4.
Okay, and the node was squamous cell carcinoma.
Yeah, exactly.
Okay, that's a bit of a puzzle. So maybe you're looking at two synchronous lesions, and if all other intraclavicular causes are ruled out, so there's no lung.
Ruled out, sir. Yeah.
Okay. Then you're assuming that all other sites are negative. You're to proceed with surgery to the thyroid and to the neck node, assuming it's operable.
And Dr. Anand, what would you do in this case for treatment? Assuming it's a true squamous.
Sir, recently I had a similar patient wherein was papillary CA thyroid, but had one of the 5 nodes had squamous differentiation.
Yeah.
So this could be a situation wherein there is this anaplastic transformation which could be happening, because we got in that patient, we particularly got all the thyroid. The primary was still papillary CA thyroid itself, but of the nodes, 5 nodes had a squamous transformation. So it could be one such possibility as well. Else, to do a neck dissection as well as to do a total thyroidectomy in this patient.
Yeah, so buy one, get one free.
Yes, sir. And then proceed with the usual treatment of radioiodine, and then depending on the further analysis, probably an IHC will be the clinching tool here on the diagnosis, that is it a squamous differentiation or is it a squamous cell carcinoma itself metastatic.
Yeah. Why I put up this slide was, it's very tempting to get straight towards the thyroid in this, seeing the right-sided supraclavicular node, globular, and nodules in the thyroid. I've had a bad experience 10 years back, a similar case where I did a total thyroidectomy, of course, with a neck dissection. It turned out to be normal thyroid, benign thyroid nodule with a squamous carcinoma stuck to it. And there was a small primary 20 centimeters from incisors in the esophagus.
Dr. Mohidin, if I can just interrupt you and just let you know that Dr. Thakkar has put it on the chat box that we have gone beyond our time. So I will.
Okay. Yeah, I think I'll rush through.
Yeah, thank you.
Yeah. Thank you. So all this has been spoken in detail by Dr. Rajiv. My only issue is, sir, regarding bilateral tonsillectomy, they say there are up to 16 to 25% cases turning positive, especially in the tonsillolingual sulcus. How often do we see it in our country?
I think our proportion of HPV positive and oropharyngeal cancers are much less than the West. And that's probably the reason, one of the reasons. The other reason is, of course, the paucity of literature. So we don't have comprehensive literature on these cases there's no big series from, as I don't know, God can correct me if I'm wrong, but I haven't seen any big series from any of our centers here. So probably in the future, we will come out with literature on.
Dr. Aman Sharma, suppose you pick up a HPV positive metastasis of unknown origin. Would you go in with a routine treatment, considering small volume disease, a surgical treatment first, and reserving adjuvant depending on the histopath report? Or would you go in for upfront radiation alone? Or for a large node, would you go for chemotherapy with radiotherapy? Dr. Aman?
Yes, sir. Thank you for the question. Because it's a P16 positive tumor.
Yes, sir.
So first, I think I would like to stage it and then plan the treatment accordingly. If it's an early stage tumor, there's a node also, sir, and it's a big node or a small node.
That's what I was asking. If it's a small node, would you go in for surgery and reserve adjuvant depending on histopath? Or if it's a large node, would you give radiation alone, or would you go in for chemoradiation?
Yeah, I think that's a very fair question. I think normally what we do, we discuss in our multidisciplinary tumor board, and we give the patient both the options. And we can just say that like oropharyngeal cancers, P16 are quite positive to radiation, and maybe we can avoid surgery in this case if the node is small, and I think the local control rate will be excellent. And also we are doing swelling sparing IMRT. So our results are, I think, very encouraging for us. If it is a bigger node, normally we are not preferring induction chemotherapy. Instead, we are escalating the dose to the N3 node, and we are like giving 70 gray in 6 weeks, not 7 weeks, in 6 weeks. And we have accumulated, we have done around, I think, 30 patients, and the results are very encouraging, but we are in a verge of analyzing our data. So whenever there's a small primary and a big node, we are escalating the dose to that node. Following by far has been excellent. One patient has developed neuropathic pain, and
sorry to interrupt.
Yeah,
I'm having on my screen that time's up, and we have slightly, rather far overshot the time. Just one last issue. Dr. Michael was saying mucosectomy. Initially, few people started with attending to the entire internal Waldier's ring. Maybe that's what was discouraged, because the present literature only says mucosectomy of the lingual tonsils if the palatine tonsil is negative after a tonsillectomy. Dr. Michael, would you just add to this?
Yeah, that's exactly what they suggest. They have done an ipsilateral lingual tonsillectomy or a tongue-based mucosectomy and biopsied the contralateral side, sent it for frozen, along with the bilateral palatine tonsillectomy.
Yes, sir. I think we'll close with this, sir. We have far outshot the time. It was a pleasure being with all of you. I wish I had been there physically. It's a beautiful city, and with such a esteemed panel, I would have loved to be there. Thank you. Thanks one and all, and a big thanks to the chairperson and the audience as well as organizers. Thank you.
Thank you, Dr. Moyuddin, for an excellent panel. Thank you.
Thank you, Dr.
Thank you, sir.
Thank you.
Thank you.
It is time for the keynote addresses now. Can I invite Professor Shailin Kumar and Professor Ramdas K to chair the session? Professor Shailin Kumar is the director of SSI Lucknow and president of the Society of Neuro-Oncology. He is professor of radiotherapy from SGPGI, and Professor Ramdas K has retired from Regional Cancer Center Trivandrum as professor and head of Department of Radiotherapy, and is now leading Karkinos group of cancer care. Over to you, sir.
Is Shailin going to join?
Yes, just going to join. Yes, I am.
Shailin, are you
Yes,
there?
thank you. Yes, I'm there. Very much there.
Oh,
Yeah.
okay. Nice seeing you. Okay.
Right.
Okay, you want to go?
I think. Why don't you take the lead, sir? Why don't you introduce Professor DN? first?
Okay.
Yes, go ahead.
It's
Hello,
nice.
DN. Hi. Hi.
Okay. Warm good evening to all of you. And at the outset, let me congratulate RCC team for conducting such a wonderful program. I have attended a couple of these sessions. It's all very good. And I thank organizers for inviting us to chair this session. And in this session, we have two keynote addresses, one by DN Sharma on brachytherapy, role of brachytherapy in head and neck, and the second one is on immunotherapy in head and neck by Kumar Prabhash. So over to you, Dr. DN Sharma. He does not need any introduction. He is a well-known radiation oncologist. He's the head of the radiation oncology AIMS, and he has done a lot of. He has a passion towards brachytherapy treatment in head and neck as well as in other sites. Over to you, Professor Sharma.
Can you see the slides now, sir?
Yeah, we can see.
Okay, sir. Thank you very much, sir, for the warm introduction, sir. Thank you very much, sir. So, respected chairpersons, ladies and gentlemen, a very good afternoon, and thank you, Fhno, for inviting me and giving me the opportunity to share my views. And thank you once again, the scientific committee, for not forgetting the brachytherapy for the head and neck cancer, because people think that it's declining, it's not in use, and kind of thing, So thank you once again for keeping this topic in this kind of a August gathering. So the topic assigned to me is the brachytherapy for the early oral cancer. And I will keep the talk very simple and begin with a clinical case which reflects the real case scenario in day-to-day practice. We face these kind of patients every day in our clinic. So I'll just begin with a simple clinical case. He's a 45-year-old gentleman. He's a smoker, and he's got around a 2 cm lesion on the left little bit of the tongue. He doesn't have any neck nodes. Biopsy revealed the well-defined squamous cell carcinoma. And therefore, he was staged as a carcinoma little bit of tongue, T1 N0. The treatment option for this patient, the answer is usually the surgery. In general, people think that surgery is the standard treatment, and that's to a large extent this is true. That surgery is the usual answer for this patient. Why surgery? There's a rationale for this kind of treatment. It is a tradition. It's being done for so many years. Surgery provides a very good local control, about 85%, more than 85% probability of local control. And the mobility of the surgery is acceptable, usually acceptable. So this is how the surgery is chosen as a treatment choice for this kind of a treatment, for lesion, this kind of a lesion. But I have a treatment to suggest for this kind of a lesion, which provides a local control probability of equally 85 to 90%. And that modality preserves the organ as well. And there is sufficient literature on the treatment which I am going to suggest. And of course, there are no comparative studies comparing the surgery versus the treatment proposed. So in my opinion, I will say brachytherapy is an equally good option for this patient. And why I say so? Without going into the details of the literature, I just picked up one slide from the Green Journal. This publication published in 2009 in Green Journal, where the various trials have been summarized in this table. And if you see the right hand side of the table, the local control with brachytherapy for oral cancer is about 90 to 95%, 80 to 90%, and so on. So in that way, the brachy is not inferior to the surgery, which we often see as a preferred treatment. And there's no dearth of the literature on the brachytherapy for oral cancers. Although there are no randomized controlled trials, there are no comparative trials. But that doesn't mean that if there are no trials comparing surgery versus brachy, that doesn't mean that the surgery becomes a better treatment and the brachy becomes an inferior option. Just to remind the audience about the potential of brachytherapy, we all know the brachy is an ultimate form of conformal radiotherapy. It is actually 4D treatment. It is a gated treatment. It has tracking, inbuilt tracking, and everything in it. The dose with brachytherapy is auto-escalated. You don't have to escalate the dose, by doing some extra treatment also. It is automatically escalated within the target area. As you can see in this picture, in the central part of the tumor always gets a higher dose. Conformity, as you can see in this picture, the breast brachy is so conformal that it can match any other conformal treatment with SBRT or IMRT. Although it remains an underutilized treatment modality for various reasons, I will not go in details. But yes, there's a lot of potential in brachytherapy, but people are not using it. Why they are not using it? Well, there are various reasons. The general belief in our own radiation community is that brachy is an invasive treatment. It is a traumatic treatment. It requires special skill and the training. There are limited randomized controlled trials. We have better techniques like SBRT, and brachy is not very popular. So these are the various reasons people, I would say these are excuses people take for not doing brachytherapy. But the fact is that the brachy requires simple skills and it is minimally invasive. It's not very invasive like surgery, There is a sufficient literature. If somebody wants to practice brachytherapy, there is no dearth of the literature on oral cancer brachytherapy. Although the SBRT and IMRT are good techniques, but let me tell you that the brachy is ultra conformal. If the SBRT and IMRT cannot match the dosimetry of the brachytherapy. popularity, it keeps changing. Sometimes proton is popular, sometimes VMAT is popular, sometimes brachy is popular. So maybe there's a slight dip in the popularity temporarily, but I don't think it is going to stay for a long time, because brachy has a substance in it. It provides very good dosimetry. There is a study published from our own country which compares the IMRT and the brachytherapy for the tongue cancers, and they've shown that the SBRT or the IMRT, it provides the as good as dosimetry as interstitial brachytherapy, but the dose to the OR is better conformal with the interstitial brachytherapy, and the planning time was also less with the brachytherapy. Now let's come back to the patient again, where we discussed that what's the treatment option. Usually people think that the brachy will be invasive in this patient, but let me just tell you, this is how I treat this patient. Just inserting 5 catheters and covering the lesion very well. Now, if I don't do brachy for this patient, obviously this patient is going to go to surgery, and what the surgical procedure is kept for this as an option for this patient, that it might require even hemiglossectomy. Now, I don't understand why people call this brachy as invasive, and they do not think surgery is not invasive. But still the surgery is being preferred for these kind of lesions in day-to-day practice. So just to tell you that the brachy is not that invasive as surgery, and therefore we must not hesitate in offering the brachytherapy to these kind of patients. Now, this is a genuine question that people think that brachytherapy is declining in the oral cavity cancers. Well, that's a genuine concern, and this concern has been addressed in one of the publications from the United States. It was published in 2016, and this reflects the survey based on the National Cancer Database, where the authors tried to see the trend of the brachytherapy in the oral cancers. And as you can see, there is definitely a decline in the practice of brachytherapy in the oral cavity cancers in the United States, and it is decreasing by 0.5% every year. There is no doubt of that. But to surprise, they have analyzed the outcome of the patients who were treated by brachy and the EBRT. And this Kaplan-Meier survival shows that the patients who were treated by brachy, in some form of the brachy, whether brachy alone or brachy plus EBRT, the survival is far better than the patients who were treated by EBRT alone, even at 30 years of the follow-up. So this data is very convincing. There are many more data I can show you, but this is one data which reflects the day-to-day practice in the United States. But it also reflects that if you don't do brachy for the oral cavity lesions, then the survival is going to be compromised. So this should be enough convincing data for all of us. And then they did the subgroup analysis also, and they found that in this forest plot, that across all the subsites, all the stages, and all the various subsites and everything, the brachy had a better survival as compared to the patients who were treated by EBRT alone. So this should be clear to everybody that the brachy, if you do incorporate into day-to-day practice for oral cavity lesions, the survival is going to be better as compared to EBRT alone. And just to show you, people think that the brachy is only for like early case oral cavity cancers. Well, today we are discussing early oral cancer, but in real practice, you can offer brachy for T3, T4 cancers also for boost. And these are the data where the people have used brachy for the boost. And you can see the this red box, it reflects the T4 tumors where the brachy was offered as a boost. People often say that there's no data on the brachytherapy, but well, there are enough guidelines, enough data for oral cavity cancers. This is one Jack Estro guidelines for head and neck brachytherapy. Then we have ABS guidelines for head and neck brachytherapy published in 2016. Then we again Jack Estro guidelines published in updated in 2017 in Green Journal. Then we have, in fact, Indian Brachy Society guidelines as well, published just about a year back. So if somebody wants to practice brachytherapy, there's no doubt of data and guidelines. But of course, if somebody is very nihilistic and does not want to practice brachytherapy as a rigid attitude, obviously you are going to negate this kind of data that these are not randomized controlled trials, these are just the guidelines and everything. This is just the workflow of the brachytherapy. We first select the patients. Of course, patient selection is very important. Then the PAC clearance, and then the patient is taken to the operation theater for brachy. And then when patient recovers, we take the patient for the simulation, and then the treatment is delivered. And of course, implant removal is equally important. So this just reflects the workflow of the brachytherapy in oral cavity cancer. These are the various subsites of the oral cavity where the brachy can practice, starting the lip, floor, mouth, buccal mucosa, gingiva, anterior tongue, and heart plate. Although the brachy for lip and floor mouth is easier than the tongue cancer, And as we go posteriorly, the implant becomes a little difficult, but for the lip and the the floor of mouth and the buccal mucosa, it's quite easier. And we all know that the oral cavity cancers are quite common in India, although locally advanced cancers, they present late in the clinics. But definitely, a good number of patients do come in early stages where brachy can be offered. And head and neck is one region where they are closely abutting organs with having diverse function, and therefore the organ presence is very important in this head and neck subsite, the site. And then we know that the brachy is an organ prevention has the capability, so it must be chosen, and we must choose the most conformal technique of radiotherapy when it comes to the radiation. And this is just to show that the head and neck has many organs which are tightly packed against each other, and therefore you need a conformal technique. Otherwise, your OR going to get a reasonably good, very high dose. So for this reason, brachy is very good. And the head and neck site, which are these are the organs which are located in the head and neck site, which are very close to the oral cavity, like smell, taste, speech, sight, and cosmesis. So if you compromise the treatment somewhere, if you choose a treatment which has a lot of OR toxicity, then these functions are going to be compromised. So you have to select the treatment in such a way that the OR dose is less, and therefore these functions can be preserved as well. Just to briefly tell how the brachytherapy is offered for oral cavity cancers, it can be offered as a definitive or a sole treatment for T1 and small T2 tumors. It can be offered with a boost for the T1, T2 tumors where the brachy may be difficult to perform for access reasons. And it can be also offered for T3, T4 tumors as a boost. And it can be offered as an adjunct treatment with surgery in the recurrent tumors and tumors where the surgery is likely to cause significant loss of the function. Just the workflow, and again the patient selection, the procedure for the brachytherapy, the proper counseling with the patient, and then we usually prefer general anesthesia, although some implants can be done under the local anesthesia, especially the lip cancers. Then usually a single plane for a thickness of less than a centimeter, otherwise a volume implant is preferred. Demarcate the area of the implant by taking 1 or 2 centimeters extra around the gross visible lesion. Distance between two catheters is 1 to 1.2 centimeter, and between two planes is about 1.2 to 1.5 centimeter. Avoid too much trauma by taking care of applying the good pressure when you have a small bleeding point, and don't hesitate to call a surgical help if there is a need for the surgical help. And this is why I say that oral cavity brachy is very easy, because as you can see in this picture, these oral cancers are very easily amenable to the local examination, clinical examination, naked eye, and therefore it is very easy. You can do a very good hand-eye coordination while performing the brachytherapy. So I would say you don't require ultrasound guidance for performing these kind of implants. So I say it's very easy. You can just use clinical hands and the eyes for doing the implant. Another simple rule: people are afraid of doing the head and neck brachy because there is a lot of risk of bleeding. But just to show in this picture, all the major vessels are behind the angle of the mandible. So if you want to avoid the puncture of the bleeding the blood vessels, then remain in front of the angle of mandible. Try and confine your implant anterior to the angle of mandible, and therefore then there will be no risk of the bleeding. Although small vessels are there, but that they can be taken care by applying the pressure and other methods. Various techniques: interstitial brachytherapy, mold brachy for especially the superficial like lip tumors. At times it can be offered as intraoperative and perioperative for the post-RT recurrences as well. The dose preference schedules, usually for LDR, we give around 6 to 70, although now the LDR practice is slightly is disappearing. But with SDR, the dose fraction schedules are kept between 45 to 60 gray as a total load, and those preference kept between 3 to 4 gray in a single fraction, and then 2 fractions a day are the usual preferred regime. When you combine this as a boost, then boost dose is usually in the range of 20 to 30 gray. Intraoperative dose is around 10 gray. And for recurrent tumors, you have to think of the previous dose and then accordingly titrate the further dose as per the disease-free interval and the previous dose as well. This is our protocol, AIMS protocol. Brachy alone, our dose schedule is 44 gray, 11 fraction 6 days by following the BID regime by SDR. Boost dose is 21 gray in 7 fraction over 4 days for T1, T2 lesions, and for Larger T3, T4 lesions boost doses of 21 to 24 gray, and sometimes even higher as well. So this is our schedule. This is one of the patients I want to show you as an example. Gingival patient of having a gingival tumor, which was not very deeply invasive, and therefore we prepared a mold, and this is how the treatment was done in this patient. Lip cancer, it is usually a horizontal sort of arrangement for the catheters. This is another patient where we implanted this patient, and then we did a CT scan and then the dosimetry. This is another patient who had a carcinoma at the angle of the mouth, and usually the surgery is discouraged because then there is a lot of deformity in the closure of mouth will be the opening of mouth will be a difficult option. This is how we treated. This was the lesion here, and then we took a margin and then we implanted in a single plane. You can see the picture post treatment. And here the lesion has disappeared. Only thing, the slight discoloration because of brachy, which is what deliberate, because a good dose at this area was required, and therefore it was. And you see the mouth opening is very good. On the contrary, if you do the surgery for this kind of patient, then a lot of graft and a lot of reconstruction will be required. Mouth opening will not be very good. You know this person very well. He underwent the surgery for angle of mouth carcinoma, and then he had this kind of difficulty in speech and swallowing, and even the cosmesis. So surgeries are not really good for angle of mouth cancers. Again, coming to the same patient, because this is how we treat the patient. A simple technique: you just take a mark with the ink or a marker pen 1 to 1.5 distance, and then cover with the brachytherapy, and make sure that 1 or 2 needles goes through your lesion, so that you can give a very high escalated dose there, because the dose around the catheter is really high. This was just the dosimetry. I will not go into details. Keep a seal between the mandible and your tongue, so that the dose of the mandible is not high. This is another picture. This is how the patient was treated. Implant removal is equally important, and we have the policy of removing the implants in the operation theater, which is very safe. Another patient who had a residual node after the 70 degree of the X-ray beam treatment with the chemotherapy, and therefore this node was adherent to the vessel, so there were limited options. Surgeons said we cannot do the surgery, so it was unacceptable. Therefore, we took this patient for the nodal brachy, which people do not usually believe that the brachy can be offered with the nodes also. But for us, any nodal mass is actually malignant mass for us. We do not differentiate between the primary and the node, because they're just the malignant tumors for us. Under the Doppler ultrasound guided brachy guidance will be the brachy, because with that you can see the vessel, which is a major risk or major fear when we're doing the implant, because this was a node and this was the underlying vessel. So it was closed. So with the help of Doppler, we could identify this vessel, and then we could perform the implant. This is how we implanted this node by 2-plane implant. And this is the dosimetry. We did a carotid angiogram along with the CT angiogram. So then you can identify the vessels very well. You can see the node, which was the residual node, and then the catheters as well. So people think that brachy is not very fancy, but if you see it with the fancy eyes, it looks very fancy as well. This is one study which I would like to quote, which was published in Head and Neck in 2013, where the authors combined the best of the two treatments, best of EBRT in the form of IMRT and the brachytherapy as a boost. And they found that the local control and survival was as high as 94%. So therefore, the IMRT lobby and the brachy lobby need not compete, need not confront. In fact, they should shake hands, they should combine their treatments, because if you combine the best of the two, the results are going to be better and better. So therefore, IMRT and the brachy should be practiced in future whenever there is a need for the combining the EBRT and the brachy as a boost. In order to summarize the talk, brachyneural cancer is indicated in early stage tumors, but of course it can be offered for T3, T4 tumors as a boost. It provides excellent local control and survival with the minimal toxicity, and these results are comparable to surgery. Plus, you can preserve the organs in brachytherapy. It is a very good option for recurrent tumors, because in recurrent tumors, even surgery is not a very good option, and there are a lot of morbidity if the surgery is performed after the previous post-RT recurrences. And therefore, as I said, the IMRT brachy should not compete, and they should be complementing each other for better results. Thank you very much, sir. Thank you.
Thank you, Professor Sharma.
Thank you, sir.
It was really a wonderful lecture, and it's very informative.
Thank you,
Shalin, why don't you take over?
Right, sir.
Professor Shalin?
Yes, I'm there.
Should I stay for questions as well, sir? Dr. Sally?
It's a keynote.
Okay, fine. Thank you very much, sir. Thank you, sir. Thank you, sir.
Thank you.
Thank you, sir.
Over to you, Shalin.
Right. Thank you. The next speaker is Professor Kumar Prabhash, and Professor Kumar Prabhash is very well regarded in the Indian oncology community as a medical oncologist. He's leading the head neck team in medical oncology at the Tata Memorial Hospital. A huge number of publications, and he's very passionate about it. So Professor Kumar Prabhash will share with us his views on the promise of immunotherapy in head and neck cancer today. And this is really a hot topic, and I'm sure Professor Kumar Prabhash will do that. Okay, I stand corrected. He's HOD of medical oncology, and of course, he has a special interest in head and neck cancer. Of course, Professor Kumar Prabhash, all yours.
Thank you, sir, and thank you for a kind introduction, sir. And nice to see you, sir, after a long time.
Back, yes.
I'll just share my slide. My slides are visible.
Yeah, it is visible.
And I'm audible. Just to confirm.
You're audible also.
Thank you, sir. Thank you so much. At the outset, let me thank the organizer for this opportunity to talk about promise of immunotherapy in head and neck cancer today. And coming to my first slide, and I'll be talking about mechanism, the role in first-line setting for immunotherapy in advanced stage disease, the role of immunotherapy in second-line setting in advanced stage disease, what's the data of immunotherapy in with radiotherapy or chemoradiation, and what is the data for immunotherapy in neoadjuvant setting before you want to do surgery, and my concluding slides. So if we see the cancer is supposed to be a foreign body, and we expect that body immunity should find out, and after finding out, they should recognize it and they should kill it. But not necessarily it always happens, and that's why many of us gets cancer. And that's primarily because you do have pathways which camouflages the cancer from the immunity, and that's because we do have inhibitory signal which is there, which is to ensure that we don't have uncontrolled immune activation in these patients in general. But when we have that same when we have the same inhibitory signals which camouflage those cancer cells, then cancer cells do grow. And if we do have a treatment or the drugs which can work on inhibitory signals, and it allows the immune pathways in the body to work, then this immune pathway in the body, they again start recognizing this cancer cell as a foreign body, and they do kill it. And that's the premise based on which this immunotherapy has been developed, which we call checkpoint inhibitor. So what I'll be doing today, we'll be talking about checkpoint inhibitor. Otherwise, immunotherapy means many things, from interferon to CAR T cell, but that's not what I'll be talking about. And anyway, the role for those treatment in head and neck cancer is limited or almost nil. Starting with the first-line treatment in squamous cell head and neck cancer. And this all started with this phase 3 randomized trial. We did have the data earlier, but this was something which was practice changing, where a trial in which the advanced stage disease, which were treated with palliative intent therapy, that was recurrent and metastatic disease, they were randomized between the 3 arms. It included pembrolizumab plus chemotherapy, or extreme, that is what we call 5-FU platinum plus cetuximab. These were the 3 arms in this study. This is a pretty complicated study, and where the stratification was for PD-L1 expression, it was TPS 50 or more versus less, and subsequently it became CPS 20 when it was analyzed, and for P16 and also for ECOG performance status. These were the primary endpoint, That was to see that overall survival and PFS for CPS more than 20, then more than 1 or more than 1, and the total population, and then followed by a whole series of secondary endpoints in these population, including the safety profile and tolerability of these treatment, which also included quality of life analysis. These were the baseline characteristics of this population of the patient who were included in the study. And what we can see that P16 positivity, which are the factors which we think that can impact the outcome, it appears they were fairly well balanced, including the age, the gender, the performance status, and the P16, the PDL1 status in this population, and the kind of disease we had. Strikingly, majority of the patients were metastatic disease, and this is in contrast, and primarily that may be the reason because of the kind of patients seen in Western world and what we see being the loco-regional disease. The loco-regional disease were 1/3 of the population. Now, starting with the outcome, that is the overall survival, this was the initial data published where chemotherapy plus immunotherapy was compared with cetuximab plus chemotherapy. And what I'll focus on is at the 3-year survival improved from 8% to 33%. I do know the median survival improved from 11 months to 14.7 months. But this is something a bit typical for immunotherapy, that in the initial part of those curves, the benefits has been limited by and large in the most of the studies and most of the tumor. And as the time goes by, the patients who benefits, they keep benefiting. And what we see here, that the survival of the patient jumped from 8% to 33%, meaning almost 4 times what we see with the routine treatment at present. If we take the population, which was 1% or more than 1% CPS, the 3-year survival improved from 6.5% to 25.6% in this population, with p-value being significant. In the total population, this improved from, at 3 years, improved from 10% to 22%, that is doubling of those survival in this term, not in median. Median remains, again, around 3 to 4 months improvement in survival. But again, as I said, this is one of the aspects of this treatment which is seen across the tumor. Coming to progression-free survival, here the chemotherapy plus immunotherapy as compared to the extreme regime was better. And at 2 years, it improved from 3% to 14.7%. That is in CPS more than 20 or 20. And CPS 1% or more than 1%, it improved from 4% to 11%. But here we need to remember, this is one of the important issue to understand the immunotherapy trials, that PFS has its own problem. When you give immunotherapy, many times you do have disease increasing, but maybe patient benefiting, and you do continue the immunotherapy, but you have to document them as a progressive disease. And this is important aspect in, again, most of the immunotherapy trials in this setting. The other group which was compared was pembrolizumab again, alone, as compared to extreme regime. And here, what we see that at 3 years, the overall survival improved from 9% to 29% in the group of patients who had CPS 20% or more than 20%. And if we take the population 1% or more, it improved from 8% to 22%, again, being statistically and clinically relevant. Now we take the overall survival data for pembrolizumab versus extreme, and now we have update data, that is the 4-year survival. And here, if we compare, when the pembrolizumab was compared with extreme regime, the 4-year survival improved from 6% to 15%, which is relatively significant. But if we see the data for in the different subgroups, that is CPS 20 and plus, then at the 4-year, the survival improved from 8% to 21%, meaning that 1 out of every 5 patients will be surviving beyond 4 years in these group of patients. And the CPS score 1 and more, it improved from 5.9% to 16.7%. Again, relevant, but less significant. When the pembrolizumab plus chemotherapy was compared in the same group of patients, and now we have extended survival, that is a 4-year survival data in overall population, and then it appears that the survival improved from 4.5% to 19.4%, meaning that 1 out of 5 patients in overall group of patients will survive beyond 4 years in this group of patients when this treatment is given. And if we take this subgroup, that is CPS 20% and more, then the survival improved from 6.6% to 28.6%. And what does it mean? That 1 out of 3 patients in this group will survive beyond 4 years if this treatment is given in these population. And the survival gets, jumps by almost 4 times in these group of patients. If we take 1% and more, then it improves from 4.1% to 21.8%, meaning 1 out of 5 patients will be surviving beyond 4 years in these group of patients. I do understand sometimes because the way the trials are done, it is a bit complicated, but I'll try to put it and try to make it relatively simpler. Having said that, I need to concede that we struggle to do observational study. I'm not sure if we can do these kind of study ever in our country, but having said that, let's interpret it. It appears if we give single agent immunotherapy, that is pembrolizumab, and compared with extreme response rate, no benefit. Combination also, or that is pembrolizumab plus chemotherapy, response rate, there's no benefit. Progression-free survival, the same, no benefit alone, no benefit in combination. Treatment-related toxicity, similar or less if alone. If in combination, again similar. What is important and what is good, that if the CPS score is 20 and more, then it is superior. That is again single agent immunotherapy. If you give immunotherapy plus chemotherapy, then it is again better. CPS score 1% and more, single agent immunotherapy is better. Combination is also better. If we take total population, then single agent immunotherapy is not better, but immunotherapy plus chemotherapy is better in this population. So one can summarize that this combination treatment and alone treatment of pembrolizumab, if we given, it improves survival in majority of the patient, except for pembrolizumab alone. In a patient, if the PD-L1 expression is less than 1%, then it appears most likely it does not improve survival in these group of patients. But do we have only this data? No, we do have some sobering data also, because at the same time there was another trial which was going on where the other immunotherapy combination was being compared with chemotherapy plus rituximab, and this is called Checkmate 651. And what it suggested that this combination was not better than rituximab plus chemotherapy in these population. But what it did suggest that as the time goes by, immunotherapy patient who responds, they keep responding. So it has the proof of concept that yes, immunotherapy works. When it works long term. But having said that, in this trial, it was not what we saw in the previous trial, suggesting that we need to choose the treatment and also the patient correctly. We know that we have been developing our own immunotherapy in our setting, and what we call is oral metronomic chemotherapy. It has a anti-angiogenic activity, and also it also works in Treg cells. This was our randomized trial. That is a phase 3 randomized trial comparing chemotherapy, that is cisplatin alone, as compared to metronomic chemotherapy, that is methotrexate and celecoxib. Primary endpoint was overall survival, and the secondary endpoint was PFS, toxicity, and quality of life. It did meet its primary endpoint, that it was non-inferior to IV chemotherapy, and it turned out to be that it was superior. And also the quality of life data suggested that giving this oral tablet in these group of patients was better than giving chemotherapy in these population. Now moving on to the next group of patients, that is a platinum refractory disease, or one can call second line treatment in squamous cell carcinoma of head and neck. This was one of the first drug which was tried, which was compared with this is the immunotherapy PD-1 inhibitor, and was compared with any chemotherapy which the investigator chose. And what was found that PFS was not so significant, but overall survival at 12 months improved from 16% to 36%, meaning that there was absolute improvement in survival by around 20%. And again, median improvement in survival was from 5 months to around 7.5 months, again highlighting that in most of the immunotherapy studies, the initial benefit is not seen And as the time goes by, the benefit is seen in these group of patients subsequently. So when the patient responds, they keep responding, but in chemotherapy arm, the patient who responds, they start failing subsequently. There was another drug which was being developed at the same time, pembrolizumab, in the same setting. They have failed in the first line chemotherapy, or they were platinum refractory. And it was observed that they had a similar outcome what we have seen with nivolumab. In these patients, the nominal p-value was clinically significant, statistically not, because they had the interim analysis where they had divided the p-value, and which was finally not significant, but FDA has continued with the approval for this treatment. But again, I always say that for any treatment, if we look for, there's always some sobering data. And here also what we see, there was another trial which was going on at the same time in a similar group of patients, where immunotherapy alone, that's the durvalumab, that's a PD-L1 inhibitor, and alone and in combination with tremelimumab, that is a CTLA-4 inhibitor, was compared with standard of care chemotherapy, whatever the investigator chose. And what was found, that it didn't appear that any of the immunotherapy arm was better than the usual chemotherapy, highlighting again how we choose the patient and what kind of treatment we give. It means not every checkpoint inhibitor or every immunotherapy works everywhere. That has to be right immunotherapy and in right place. Again, we were developing our own metronomic chemotherapy. Again, I suggested it does have its own immune modulatory effect. And this was rather than having two drugs, that is 3 drugs, we added erlotinib to methotrexate and celecoxib. And this was a phase 1/phase 2 trial. There was adaptive design. And what it showed, that if we give this treatment, almost 40% of the patient, they respond. The responses are not very prolonged, but substantial enough to be for us to be interested. And in this study, the PFS was around 4 months, and overall survival was around 7 months in these group of patients who are platinum refractory in this setting. And it also showed that if this drug is given, you do have overall improvement in quality of life in these patients. Now, coming to the next situation where we can use immunotherapy, and what is the data for it, that is combining immunotherapy with radiotherapy or chemoradiation. This was the initial data which came for platinum ineligible patient, where immunotherapy was combined with radiotherapy, and it was looked promising, and we are awaiting. There is a randomized trial going where in platinum ineligible patient, this combination is being explored to see that if it works or not. But at the same time, there was in platinum eligible patient with who were eligible for cisplatinum immunotherapy, that is one of the immunotherapy called evolumab, a checkpoint inhibitor, was given before starting CTRT, during CTRT, and subsequently. And what was observed, that in chemoradiation trial, when immunotherapy, that is checkpoint inhibitor, is added, that is evolumab, it doesn't improve progression-free survival. That was the primary endpoint for this study. Again, highlighting that we need to have for all modalities and all treatment to show that it benefits in those specific situations, before we can conclude that it always works. Another situation, that is neoadjuvant immunotherapy, because we do want to explore treatments which are effective in early phases. There are almost a dozen studies which has explored with promising result, with the response rate which has been strikingly good with a single dose. With more than one dose, the responses increases. And if you combine with chemotherapy, then responses becomes far better. In this ASCO, this was a data presented, and it appears very promising. That is in intermediate risk group of patient, the 1-year DFS, which was in RTOs, 950,169%, improved to 97% in this study. But again, that's an indirect comparison. But again, data looks promising. And there are more than one data to suggest that if the patient, they do respond to immunotherapy initially, they do far better with subsequent therapy. But again, we will be waiting for data to mature. This is one of the patients which we gave immunotherapy in our OPD, that was sent for palliative intent therapy. And one can see the striking response. And subsequently, the patient went for surgery. But what we need to remember here, that the PD-L1 score was very high for this patient, suggesting the chance of benefit was there in these patients. and looks like that's the reason he benefited. So if we have a responses to immunotherapy in the clinic, these are the kind of responses you get. If they don't, patient really don't benefit. You do have multiple randomized trial going on for neoadjuvant immunotherapy in head and neck cancer. This is one of those examples where immunotherapy is being either tried in only neoadjuvant setting, or they have been trying neoadjuvant setting followed by in adjuvant setting, or neoadjuvant setting followed by chemoradiation and then followed by adjuvant setting. And we need to see that in which of these combination there is activity of this drug. Do we have some data from India? What happens with PD-L1 expression and what happens with outcome? This is some data for PD-L1 expression, and what we can see here that majority of the patients, that is 2/3 of them, they are PD-L1 positive. If you take histology-wise, it looks like squamous cell carcinoma. The positivity is higher than other histopathology, and that is usually expected. Site-wise, it looks like squamous cell carcinoma in those sites are more positive as compared to other sites. And in nasopharyngeal carcinoma, it was high, and that's what explains that in nasopharyngeal carcinoma, in this ASCO, we had a randomized trial to show that the checkpoint inhibitor improved outcome in these group of patients. We also have some data regarding outcome, and we did give a fair number of patients of immunotherapy. This was initial analysis of 155 patients. Out of those, around 50 were head and neck cancer. The median PFS was not striking, around 2.5 months. Again, I keep highlighting that the median has not been striking for immunotherapy. The median OS also was not so striking, 5.3 months. But this was something was important. If those patients who respond to immunotherapy, less than half of them, they fail. They keep responding as the time goes by. And this is also seen in our database that if you give an immunotherapy, if they don't respond, they fail pretty fast. But if they respond, then half of them, they will continue responding subsequently with immunotherapy in these patients after a few years to come. You do have those side effects. These are some of those classical side effects with immunotherapy, because we activate the immune mechanism and it leads to autoimmune phenomenon in the body. And almost every part of the body, you do have some immune reaction. But that is usually what has been satisfying, that most of the time it is in less than 10% in most of the sites, and most of the side effects showing the different side effects what we had in our population. One of the major issue for immunotherapy, which is important treatment in head and neck cancer, and for that matter in many other cancer, is the accessibility. When we analyze our data and try to see what percentage of patient who required it and got it, that was 1.61%, meaning that almost majority of the patient, that will be silly to say that majority, almost all patients couldn't get it. There are very few patients who could get this treatment, which is found to be effective in these population, but because of cost, majority of the patient can't take it. So we do have a responsibility as a clinician. And I was just listening to the oration by Dr. Ravi Kannan and from Silchar, and he made a very important point that as a clinician, we have a responsibility. And this was told to him by his own boss, that if a patient can't afford it, we find out ways and means to do it. And what I understand, the only ways and means to do it, to develop these drugs in a way that it is affordable for our patients. And if we don't do it, then we do fail in our duty. And we all are responsible for it, including clinicians, researchers, the ethics committee members, those regulators, that are we working enough, that our patients are able to get the effective treatment which we talk about. I only focused on immunotherapy in squamous cell carcinoma and head and neck, but there are many other places. Should I stop at one slide? Is that okay?
Yes, please. Thank you so much.
So many other places where you do have squamous cell, where you have immunotherapy, which is standard of care in head and neck cancer, nasopharyngeal cancer, squamous cell cancer of the skin, basal cell cancer, MSI positive cancer, skull melanoma, mucosal melanoma, and high TMB tumors in advanced stage. So in head and neck cancer, immunotherapy is not restricted only to squamous cell. And I conclude that it is effective treatment, and we need to find out ways and means to see that we are able to give it to the patient, but not every patient requires it. And my acknowledgement to my colleagues who works together, because I showed some data, and my coordinators who works hard. Thank you so much. And sorry if I exceeded the time.
Not at all. Thank you very much, Professor Kumar Prabhash. That was very comprehensive indeed. And you have been fair, I would say, talking about the high points as well as the challenges. And of course, affordability. This is the buzzword nowadays, and strategies to mitigate the affordability problem. Thank you very much. I think since the time is up, Professor Ramdas, any final comments? Or
No. I think its time is up. They are waiting for the oration, I think.
Right. So thank you very much. Over to the organizers. Thank you for the opportunity to participate.
Thank you,
Dr. Thakur.
Professor and Professor Shalin Kumar. That is the end of the keynote address, and now it is time for the prestigious PA Shah oration. I would like to invite Dr. Kudush Ahmed. He is a chief consultant ENT and head and neck surgery at Dispur Hospital and Nightingale Hospital, Guwahati, and he is a former honorary secretary of FHNO and founder member of FHNO, and at present the governing council member of Federation of Head and Neck Oncology. The other chairperson is Dr. Vikram Kekatpure. He is a senior consultant head and neck surgeon at Aster CMI Hospital, Hebbal, Bangalore, and he is at present the honorary secretary, Foundation of Head and Neck Oncology. Over to you, sirs.
Thank you, organizers, for having asked us to chair this prestigious session, where we'll be having Professor Cesar Piazza from the University of Brescia, Italy, delivering today's oration. So before the oration, it is customary to introduce or say a few words about the oration itself. So can we have Dr. P.A. Shah's photograph on the screen, please, tech team? Dr. P.A. Shah was born in November 1926 in Jamnagar in the state of Gujarat, India. He passed his MBBS in 1949 from Bombay University, MS in 1953 from Bombay University. Then he did his FRCS Edinburgh in 1953 and did FRCS in otolaryngology from London in 1959. So about a few words about his experience. He worked in London, UK for 5 years before returning to India. And after returning, he was an honorary professor of ENT in Grant Medical College and Sir J.J. Ghosh group of hospitals in Mumbai from 1959 to 1984. He was a pioneer in head and neck surgery in his time and was greatly loved by his students, and also he made some pioneering additions to the practice of head and neck oncology in his time. Some of them have been included, like he did this vocal rehabilitation surgery following laryngectomy and introduced the technique of Asai and neoglottis phoronatoria for the first time in India. He carried out bilateral maxillectomy in a single stage and single stage reconstruction of the palate for the first time in India. So these two were, great contributions that he had in head and neck surgery. But he passed away tragically in a car accident in 1989 at the young age of 63 years. So with these few words, I'd like to pass the baton on to Dr. Kegatpure to introduce the speaker, the orator for this oration. Dr. Kegatpure, please.
The mic is muted, I think. Dr. Vikram, your mic is muted.
So good evening, all. Dr. Kekatpur is having some problems with his audio at the moment, which is quite inexplicable, but nevertheless, we are very pleased to have Professor Cesar Piazza with us today. Professor Piazza is the designated orator for the P.A. Shah oration, and he works in Italy. He's a full professor and chief of the Department of Otolaryngology, Head Neck Surgery at the University of Brescia. And he's research director at the Department of Medical and Surgical Specialties, Radiological Sciences, and Public Health in the same university. He got his MD from the University of Pavia in 1996. And of course, is very, very well known in the subject initially for his contributions to endoscopic surgery for the larynx, primarily with the laser. And while he has made a great name for himself and has had significant publications to that event, which have been practice changing and practice adopting all over the world, today we are going to ask him to speak on a somewhat different topic. And that topic relates to cancers of the tongue. Currently, Professor Piazza is professor and chairman at Brescia. He is also the president of the European Laryngological Society. And as I said, today we have asked him to speak to us on a topic which relates to compartmental tongue resections for cancers of the tongue. So Dr. Piazza, we are not going to stand between you and the audience. This is an eagerly awaited lecture. Please do take the stage.
Thank you very much for your kind invitation. I hope the next time I will share with you this fantastic opportunity will be on live, not like webinar like this, but you know, these times are quite difficult for everyone, and we have to accomplish it. So it's a great honor for me to be here and share with you my ideas on compartmental tongue resection, philosophy, indication, and outcomes as a P.A. Shah oration. I will try to give you some of the fundamentals idea about this big issue, which is the surgery of the tongue, which is mainly a muscular hydrostat. It means a sponge essentially full of blood, which is very similar in its anatomical and quintessential structure to the tentacles of the octopus or the trunk of the elephant. Essentially, a vast muscular organ without any skeleton within it. As you all know, the muscular structures of the tongue is quite complicated, and it's based essentially on a wide range of intrinsic and extrinsic muscles that all together merge in a very complicated three-dimensional way through longitudinal, vertical, and transverse fibers. At the beginning of your surgical experience, you certainly remember that orientating yourself within this complicated array of muscular fibers was not easy at all. And this is one of the main issues of my lecture today. In the try of simplifying the anatomical structure of the tongue, Takemoto, at the beginning of this century, introduced this three-layer model of the tongue, distinguished into a cover, a core, and a stem. The cover is essentially the external part of the tongue, composed by mucosa, submucosa, and mostly intrinsic muscles. Its depth is around 1 centimeter. And as you see in this picture, it constitutes the external layer of the tongue. The stem, by contrast, is just composed by the genioglossus muscle, and it's the origin of the tongue, at least from the anatomical point of view, from the mandible, while all the vast majority of the tongue is composed by the core, which is essentially made by extrinsic muscles, 90% of it, and a small minority of intrinsic muscle, mainly the vertical and transverse muscles, while the longitudinal superior and longitudinal inferior intrinsic muscles lays into the cover of the tongue. We first mentioned the tongue as a muscular hydrostat without any skeleton within it. It's partially true. Indeed, it has got a fibrous skeleton, which is composed essentially by a median fibroadipose raphe, which starts not from the tip of the tongue, but about from 3/4 of its body, since the real tip of the tongue is just composed by intrinsic muscle and mucosa. But this median raphe goes through the body of the tongue, dividing it into two alphas, and reaches the level of the hyoid bone, the hyoglossal membrane, which is a coronal membrane in which meets the median raphe in a 90-degree fashion. In this way, the tongue is divided into two independent compartments with only two minor breakpoints, which are represented by the superior longitudinal muscle and the septal lymphatics, which travel in between one and the other compartment through the median fibroadipose raphe. The compartmentalization of the tongue will not be adequately understood if you don't take in mind the landmark paper of Abd al-Malek, an Egyptian anatomic professor, that in 1938 published a very important manuscript on the intrinsic anatomical description of the tongue, especially focusing on the paramedian septum and lateral septum. These two connective tissue are landmark structure, as I will show you in a moment, since they make the road of lingual vessels, hypoglossal nerve, glossopharyngeal nerve, and obviously the lingual nerve, together with a lot of lymphatic vessels that carries to the lingual Rouvier's lymph nodes in the floor of the mouth. So if you consider the position of these two structures that you can always observe in your patient through every coronal MRI or CT scan, as you can see in the right of this picture, this is the paramedian septum and this is the lateral septum. These two structures are lying less than 1 centimeter from the mucosal layer of the tongue, and inside them they travel a lot of fundamental structures, arterial veins and lymphatic vessels, together with nerves of the tongue that explain the fundamental importance in the oncologic behavior of the oral tongue tumors. So the tongue can be considered as made up by two anatomofunctional units, two compartments independent each other, in which the midline boundary is represented by the midline raphe, while the peripheral boundary is represented by the mandible and hyoid bone. In between these boundaries, every tongue compartment can be treated separately from the other, at least when you can be sure that the tumor as I will show you in a moment, is confined to a given compartment. In order, as you will see, to get the best therapeutic option and control of the tumor and the best functional outcome from the functional point of view. A big issue in contemporary oral cancer surgery is the concept of adequate surgical margin. Whatever your experience, whatever the book on which you have studied, these surgical margin, adequate surgical margin can be defined differently. Sometimes they are few millimeters, sometimes they are 1 centimeter, sometimes they are even more than that, 1.5 or 2 centimeter, according to your school, to your philosophy, and to your teacher. And unfortunately, according to your experience and to the local position of the tumor in the oral cavity. Obviously, sometimes you cannot have the luxury of having 1 centimeter of free margin all around the tumor. For example, when the tumor is close to the mandible, for example, and if you resect 1 centimeter of mandible in all direction, you probably will always finish with a segmental mandibulectomy. So the concept of adequate surgical margin is definitely too vague today. And especially if you consider that its real nature must be done on your brain, on your experience, on the tip of your finger. And if you fail to get an adequate surgical margin at your first resection, there are a bunch of papers that demonstrate that the second resection, even when getting an R0 condition, will not give you the same results of a first R0 resection. So this is the problem. We need adequate surgical margins, but so far we have no infallible way of finding with our fingers or with our eyes the adequate amount of adequate surgical margin in every clinical scenario, in every patient, in every subsite. And this is the big problem of this kind of surgery, especially when you consider not just the surface of the tongue, but its depth extension, especially at the level of the TNN tract. The TNN tract is defined as the fiber of fatty tissue, including nerves, vessels, and lymph nodes, which lies in between the genioglossus muscles and the mylohyoid muscle, roof of the level 1 and superior border of the submandibular gland. In that soft tissue lies the lymph vessels and lymph nodes sometimes that brings the metastatic cells from the T side in the tongue or floor of the mouth to the level 1A or 1B basin in the neck. And this is a piece of tissue which is frequently neglected in classic transoral resection, but that have a very important role, as demonstrated, for example, in this landmark paper from colleagues working in the European Institute of Oncology in Italy, in which they clearly stated that the involvement of the TNN tract by tumor spread statistically means a significant more frequent distal recurrence, triple risk of distant metastasis, and double risk of death. And obviously this TNN tract must be resected whenever you feel there is a different than zero probability of having involvement of these lymphatic vessels by metastatic spread, because if you leave tumors within that lymphatic network, you will have for sure a local or regional recurrence in a few months from the primary surgery. So whenever you deal with more than 10 millimeters depth of infiltration tumor, you, as I mentioned you before in the anatomical remarks, you are dealing with tumor that approximate the paramedian or lateral septum. This means that the tumor reaches those big avenues represented by lymphatic veins and artery, all together with nerves, glossopharyngeal, lingual, and hypoglossal nerves that stays within this secondary septa, within the inferior longitudinal muscle and genioglossus in the inferomedial portion of the tongue. So whenever you have a 10 millimeters depth of infiltration tumors, this means that the core of the tongue is involved and must be resected with your tumor. To control, it's in a three-dimensional way, it's spread of diffusion through not just the surface, which is clearly accessible through your naked eye, but most importantly, in the depth of the organ towards the hyoid, mandible, styloid process, and floor of the ventricle, floor of the mouth. In this direction, the tumor, when has reached the T2 border T3 condition, tends to spread in a very subtle and subclinical way, thus giving you the risk of leaving microscopic tumor spread within the organ without feeling it with your fingers, but just realizing it a few months when you will have a persistent or recurrent disease at the periphery of your surgical bed. So the real bundles is one of these possible routes of escape towards the styloid process. And the other one is the lateral lingual raphe through the lingual vessels and lymphatic route, as already mentioned before. These things are even more dramatically evident when you consider the floor of the mouth or the ventral portion of the tongue, where the distance for the tumor to reach the lateral or paramedian raphe of the tongue are even less and less than 10 millimeter. And you have already infiltration, you may have already infiltration of the sublingual gland, genioglossus muscle, or other intrinsic and extrinsic muscle of the body of the tongue for less than 10 millimeters DOI tumors. And in fact, as already everyone knows, the floor of mouth cancer may have a very early diffusion to the lymph nodes of the floor of the mouth through the sublingual gland and submandibular gland through the lingual nerve and hypoglossal nerve, both to the skull base and to the neck, with a very ominous prognosis and an unpredictable loco-regional patterns of diffusion. So when you consider all these things together, you will quickly realize that the easier from the technical point of view and safer from the oncological point of view way of removing a tumor that infiltrates the floor of mouth or oral tongue more than 10 millimeters is the removal of the entire compartment of the tongue, which goes from the hyoid bone to the mandible, to the midline raphe, to the base of tongue, or epiglottic vallecule if you need to remove it, because the tumor, for example, is at the level of the amygdaloglossus sulcus, and therefore you need to extend your resection to the base of tongue. Conceptually, the median raphe is to be considered, when not reached by the tumor, a safe barrier to the progression of the tumor to the contralateral half of the tongue. And this means that at this level, for example, the safe surgical margin can be less than 1 centimeter, because this is, as it can be less than 1 centimeter at the level of the mandible or hyoid bone, because those are, I would say, well-defined boundaries of this anatomic compartment that we can follow safely without any doubt of macroscopic involvement if frozen section have been demonstrated to be negative at this level. This means obviously a complete TN tract removal together with the compartment of the hemiglossopelvectomy and the neck dissection that obviously must be performed in a one-step unblock fashion. In so doing, you will perform for every T3 or up T4 tumors, and in some cases even for small T2 that approaches the T3 depth of infiltration. I would say 9 millimeters is still a T2, but in my opinion is worthwhile of a compartmental resection. In all these patients, you should perform a so-called type 3 glossectomy as defined by this beautiful paper appeared in Head and Neck in 2018 by Ansarin and Jatin Shah, that is aimed to classify the various types of glossectomies in a very schematic way. So we are talking about a 3B glossectomy, if you want to refer to this classification. Just to simplify this concept in a very schematic anatomical way, I will show you some cadaver dissection that and a brief video that will give you the necessary landmarks to repeat in your daily life this very easy and successful surgical technique. First of all, the surgical approach is more or less the same that for then you are used to apply for every advanced stage tongue cancer. I prefer a pull-through approach without transversing or opening the mandible. In my experience, this is needed in less than 5% of cases, just in failure after chemoradiation, second tumor, heavy trismus, or something like this. Usually, the classic hemiglossopelvectomy is performed through the neck in a pull-through fashion, as I will show you in a moment. The procedure starts with a 1 to 3 or 1 to 4 or 1 to 5 according to the neck situation, neck dissection, unilateral, bilateral, according to a number of variables that I don't want to mention here. But at the end of the neck dissection, if you want to do it separately, you will have this kind of approach and view. If you want to do it in one piece, unblock resection with the TNN tract and hemiglossopelvectomy, obviously you will have a different situation. For the purpose of the didactic aims of this lecture, I just removed everything from the neck of this cadaver just to show you the situation before starting the compartmental neck dissection. You can see here the facial artery. The facial vein has been already ligated. You see the ventral, the anterior body of the digastric muscle, the posterior belly of the digastric muscle, also the mylohyoid, the right mandibular body, and the skin flap reflected upwards. In my opinion, facial artery is one of the most usable donor vessel for free flap, so I usually ligate it as long as I can in order to reuse it for subsequent vascularization of my free flap, and the same is for the facial vein or thyrocervical branch of the jugular vein. At this point, I clearly see the 12th cranial nerve and the hyoid bone, where I can obviously isolate the lingual nerve, the Wharton ducts, and again the mylohyoid muscle. I isolate the lingual artery, just cutting the hyoid, the hyoglossus muscle just above the grid corners of the hyoid bone, and isolating therefore the lingual artery and ligating it flush from its origin from the external carotid artery, because this can be a second donor vessel for my free flap. And I separate completely the hyoglossus muscle from the hyoid bone. At this point, I usually cut the 12th cranial nerve, which is, and the lingual nerve, and then I approach the midline of the compartment by separating one gene. Well, I detach the anterior belly of the digastric muscle, and I cut the mylohyoid muscle from the mandibular line, and then I cut in the midline, separating one geniohyoid muscle from the contralateral one, and every genioglossus muscle from the contralateral one. In this way, you get a midline line through the midline raphe of the organ, and you reach the genius tubercle of the mandible. Here you detach the geniohyoid and the genioglossus in order to get the vast majority of the extrinsic muscles of the tongue pulled apart. In this way, in this moment, you have to pay attention not to transgress the midline in order not to damage, devascularize, and denervate the healthy side of the organ, because this obviously will heavily impact on your functional outcome. And then when you are finished to detach all the hyoid musculature and the midline musculature, as well as the mylohyoid musculature, you start your dissection from the oral cavity, separating the tongue along the midline raphe, from the tip of the organ to the dorsum, and you finish your resection pulling the affected hemitongue into the neck in a real pull-through maneuver, then cutting the posterior half of the posterior part of your surgical specimen, either at the level of the circumvallate papillae, if the tumor is confined to the oral tongue, or at the level of the palatoglossal pillar, or even at the level of the epiglottis, if you need to do that, if the tumor is partially extending to the base of tongue. At the end of the procedure, you will finish with having a large hole that pass through the mandible from the oral cavity and the oropharynx into the level 1B, 1A, and 2A of your neck, while the contralateral healthy hemitongue will be again fully functional, vascularized, and innervated. When you remove your surgical specimen, you can clearly assess it with your eyes, with your fingers, and especially with the fingers and eyes of your surgical pathologist, because these are very clear surgical specimen in which you have a tip of the tongue, a circumvallate papillae, a base of tongue, an artery, veins, lingual nerve, hypoglossal nerve, and all the extrinsic muscles resected from their bony insertion, the hyoid, the mandible, and the styloid process. So your pathologist is no more blinded on what you did, is clearly able to give you important information, for example, about the TNM tract involvement, about the extrinsic muscles involvement. This was something that in the last edition, TNM7 edition, was very important. This was an essential element to define the T4 category, but no pathologist at the time without this kind of surgery was able to define which was an extrinsic muscle or not, because they just received a piece of meat without any possible anatomical orientation. In this way, they are completely able to tell you not just that the extrinsic muscles are involved, but which extrinsic muscle is involved, geniohyoid, genioglossus, mylohyoid, or whatever. And this is something that is very important to decide the complementary adjuvant treatment. Just a small video that show you the 20 minutes surgery usually needed to do this kind of procedure. This is the midline raphe separation, okay, just to perform a right hemiglossopelvectomy. This is a separation of the anterior belly of the digastric from the mandible. This is the separation of the mylohyoid muscle. This is the separation of the posterior belly of the digastric. This is the intermediate tendon. Then the hyoid bone is skeletonized in order to separate the hyoglossus muscle and ligate the lingual artery and the 12 cranial nerve. This, as you can see, the greater cornus. This is the artery, the lingual artery. You can ligate it long or short according to your reconstructive needings. And after ligating it, you cut the hypoglossal nerve. And also this nerve can be ligated as long as you want from the T and then tract, potentially reaching the skull base if you need it. And then you proceed with your transoral approach. You just cut along the midline the tip of the tongue along the midline raphe. This time is quite quick and without blood because you have already ligated the lingual artery. So there is, it's a very speedy procedure. and then you demarcate your posterior resection on the mucosal side, and when you pull the right hemitongue through the mandible into the neck, you finish your posterior dissection, in this case preserving the base of tongue, because this was a mobile tongue tumor, but clearly through that window you can resect all the organ up to the vallecula, glossoepiglottic vallecula. And this is the T3 with the healthy free margin, and this is the defect at the end of your hemiglossopelvectomy. The oncologic outcome of this procedure had been already described by the Calabrese and co-workers in a landmark paper of 10 years ago on oral oncology, in which he compared the traditional standard surgery that he himself performed by the same surgical instrumentation and surgical equipe some years before, with the oncologic outcomes obtained with this technique that I already showed you, the compartmental approach, showing that the 5-year local control and 5-year overall survival had been greatly improved of 17 and 24% respectively, just applying this different philosophical and conceptual surgical approach. I published 2 years ago my experience on a more limited series of patients. These numbers have grown to more than 100, but remember that the most important concept is that this technique is very good when you apply it to the naive patients, never treated before, as I will show you in the group B of 10 patients already failed to chemoradiation or previous surgery with chemoradiation. Unfortunately, the outcomes are very dismal. My indication for this kind of for this kind of procedure is tumors of the oral tongue and or base of tongue or floor of mouth with a tumor depth radiologically defined as more than 10 millimeters. And with this indication, obviously in the 7th edition, all these tumors, for the reason I explained you, according to the Takamoto model, all these tumors were T4. Now, according to the 8th edition of TNM classification, these tumors should be classified as T3 if they do not involve the mandible, skin, or other adjacent organs. These, as I already told you, are the outcomes from the oncologic point of view when you apply this technique to naive tumors in terms of overall and disease-free survival, quite good outcomes. At 2 year, 80%, that maintains at 80% at 5 years in terms of overall survival. Disease-free survival is 90% at 2 years and goes down to 65% at 5 years, and local control, which is 100 at 2 years, maintains 100 at 5 years. It means that the failure of these patients is unfortunately more frequently than not regional and or distant, but you control completely the tumor at a local level. This is unfortunately not true in the already failed patient, which have a very dismal prognosis in spite of any aggressive compartmental surgical technique. Clearly, when you have removed the compartment, you have to reconstruct it with a free flap, for example, and the idea, however, is that if you leave completely untouched the contralateral hemitong, the morbidity of your compartmental resection will never be more than a traditional standard surgery in which you preserve some part of distal extrinsic or extrinsic fibers, because these are no more functional fibers. So the muscle that you cut will never function again. So the idea is to cut them and remove them completely in order to improve your oncologic outcome, maintaining the same functional results. Functional reconstruction in my hands is always performed by free flaps, radial forearm, or anterolateral thigh. In this case, in this situation, are my favorite techniques. The most important idea is to leave the contralateral healthy hemitong free of moving in the oral cavity in order to be able to articulate the speech and manipulate the bolus, the food, in order to reduce the limits in terms of swallowing and dysphagia that, especially after chemoradiation, this patient may have. Then the choice between anterolateral thigh and radial forearm depends essentially on the body habitus of your patient. Bulky and fat women are not ideal candidates for anterolateral thigh. In this case, I prefer the radial forearm, while for very thin muscular men, I prefer the anterolateral thigh because it's usually of the perfect thickness to reconstruct a full hemiglossopelvectomy. So in conclusion, from the oncological standpoint, compartmental approach provides excellent local control to at least naive patients with advanced T3, T4 oral cancer and oral and floor of mouth cancer. This approach does not significantly affect speech. Usually 2-3 months after surgery, these patients are able to talk at the telephone like before and to be understood perfectly. If you study in a serious way by, for example, swallowing barium test swallow, you will see some kind of subclinical food aspiration, especially for some kind of foods, but this does not usually impact on the daily quality of life and does not cause aspiration pneumonia. In my experience, the PEG dependency is less than, is around 6%, and therefore less than that classically described for every kind of major head and neck surgical procedure. However, the impact of specific reconstructive techniques and the choice between one option, for example, radial forearm, versus the others, for example, anterolateral thigh or latissimus dorsi, is still matter of debate and should be addressed by prospective multi-center clinical trials. Thank you for your attention.
Thank you very much, Professor. It was indeed a true oration. Thank you, really appreciate you delivering this oration today. Normally, following orations, there are no questions, but given that we are physically so apart, there is no coffee break, tea break to interact with you personally. So we have a few of our members who will raise few points and conduct a discussion. I request Dr. Rajiv Kumar, Dr. Shiv Kumar, and Dr. Mandeep Singh to make brief comments.
Yeah. Hello. Hello, sir.
Hello.
Hello. Very nice oration, Dr. Piazza. And indeed, we are following this compartmental tongue resection for last few years. I have few points to discuss with you and obviously with the other colleagues. That the one is when the tumor is very close to the midline raphe, but is not infiltrating. Do you take the deep margin from the opposite tongue also? Because if we go as per the anatomical barrier of avascular raphe, median raphe, the deep margin might come close in the final histopathology. So do you take an extra cuff of that deep margin from the opposite compartment? Because this is the point which I feel is difficult sometimes for me to understand, that if it is a compartment and the tumor is strong barrier, the midline raphe is strong barrier, should we stick to that barrier or should we take an extra margin?
Well, I fully agree with you. It's just a matter of philosophy. I usually do like you mentioned. I take a frozen section or also an extra surgical margin for definitive pathology through opposite to the midline raphe, but just for convincing my pathologist and radiation oncologist and medical oncologist colleagues that this was an healthy margin. I do more for them than for me or for the patient. Because when I see that the median raphe is healthy, for me is enough. But at the end of the story, after shrinkage of the surgical specimen and fixation of the specimen, that margin that in your eye was 2 millimeters and was enough, it will become 0.5 or 0.8 millimeters. And in the eyes of your medical oncologist and radiation oncologist will not be sufficient, will be an R0, sorry, an R1 or R close, and therefore they will force you to make a second procedure. Just to avoid this misunderstanding, I always make an extra margin, which is, if it's safe, demonstrate that it was not an R1 or R close margin. Then, obviously, sometimes the postoperative chemoradiation is dictated anyway by the multidisciplinary team, because it's, for example, a T3 or T4 and plus tumor, so you have to, anyway, to make the complementary treatment. But from the philosophical point of view, I honestly make this just for my colleagues than more than for me or for the patient.
Thank you.
Yeah. Hi, Dr. Piazza. This is Dr. Shivkumar here. Excellent presentation of concept, the philosophy, and the technique of compartmental resection. There are a couple of questions in the chat box. One question is from Dr. Moni Koryakos. Yeah, he has asked that you mentioned 10 millimeters was suggested the indication for tongue for a compartmental resection. So he's asked for a clarification as to whether the same holds true for floor of mouth and ventral tongue carcinomas. Would you like to take that?
Thanks, Moni, for the wonderful question. As usual, very well done. Well, it's something that we should I would say deepen a little bit more with anatomical and prospective study. My feeling is that 1 centimeter in the oral tongue is enough for switching to compartmental surgery for the reason that I explained you in terms of anatomic landmark. But for the floor of mouth, I think that the cutoff should be even less than that. In my opinion, sometimes already 5, 6, 7 millimeters of depth of infiltration are enough for a floor of mouth cancer to reach the paramedian septum or the lateral septum. So this is something that obviously must be balanced with other variables, which are the superficial extent of the tumor and, for example, the N situation in the neck. all these things together sometimes make the full picture much more understandable. But I agree with Moni. The floral mouth is a far worse beast than the oral tongue, and the depth of infiltration in this case to switch to a compartmental resection should be even less than 10 millimeters.
Right. There is there's some few other questions. Maybe we can just take a couple of them. We have 5 more minutes. So there was one question regarding was any correlation of the TN tract possible with MRI findings in your cohort of patients?
Well, unfortunately, the TNN tract is something that still is below the radar of our MRI and CT scan evaluation. Sometimes, very rarely, it happens that the radiologist signal as a lymph node or suspected lymph nodes at the level of the sublingual compartment or at the level of the mylohyoid surface. Usually, it's something that you have to have in mind as as an anatomical concept more than a radiological warning, because at least in my experience, the TN tract involvement is something that your pathologist tells you. Sometimes you have doubt about that, but you have no clues, no clear indication about that, and you will find it in the definitive histopathology if you ask to your pathologist to look at that, because otherwise they will consider the specimen altogether and they will never put attention to this very crucial element of the surgical pathology of the oral tongue. So you have to ask specifically, you have to work with your surgical pathologist, you have to explain him where is the mylohyoid, where is the TNN tract, why the TNN tract is so important for you, and why you want to have information about that. And usually imaging is not very useful in this direction.
Right. There's just one interesting question, and even I would like to put forth that question is, would you ever, when do you at all consider using any local flaps, if at all, for tongue defect? I do understand you predominantly use a free flap, but is there a situation where you would consider using a local flap? Or for that matter, a primary closure? When would you consider doing these two things?
Well, primary closure, in my view, is impossible, because you should have to close the midline of the tongue with the contralateral gum or gingiva or a cheek. So I think it's impossible, and this would finish in a completely suboptimal function of the residual oral tongue. Then the option of the local flap or regional flap is another issue. I know that there are countries in which the microvascular technique are not developed at all, or they are considered an exception more than a rule. So they raise a pectoralis major flap or submandibular pedicle flap or other things. But in my opinion, they are not a good indication, and I've never performed them, at least as a first line option. Then as a failure, sometimes, unfortunately, it happened to me to use the pectoralis, but it was the last choice. And honestly, in the last 10 years, when I failed the first free flap, I redo a second free flap. And just when I fail the second free flap and I'm really desperate, I do a pectoralis measure.
Right.
Because I really think that the residual function of the contralateral mid-tongue will be far better when you put a pliable, thin, and very well vascularized free flap instead of other surgical reconstructive option.
Absolutely.
We would really love that this discussion continues for at least a couple of hours, but unfortunately we have to stop. Mandeep, you have any comments to make?
Um, uh, Dr. Piazza, it was a very nice, elaborate. There's no words to explain the kind of presentation which you have done. Just I'll take one question from here. That is any indications of post-op radiation when you after you do a compartmental resection, does any indications for adjuvant radiation change, or you consider something different after doing a compartmental resection, or it remains the standard how we go about doing after
No,
normal?
I don't think there is something different. I mean, apart from the discussion about margins that I already addressed, I would say that the only new indication to postoperative chemoradiation is a TNN tract involvement. If TNN tract is involved by metastatic spread, perineural infiltration, and so on, this, in my view, is an indication, even in presence of clear margin and even in presence of N0, this is, in my view, an indication for postoperative radiation, at least, if not chemoradiation.
For TN tract identification, I think we have to work closely with our pathologists to, And one last question I just wanted to ask: when do you consider doing a marginal mandibulectomy with a when you're doing for advanced tongue cancers along with compartment?
This happens more frequently for the advanced floor of mouth cancer, in which you have clearly to get a good margin at the level of the genius tubercle, and so you have to perform a rim mandibulectomy at the level of the internal part of the mandible if you feel that the tumor is adherent to the periosteum. In that case, I fully agree, you need to reach an healthy bony margin, even if the CT scan or MRI does not show you any kind of cortical invasion. It happens less frequently for the real tongue cancer because if they are not associated to the floor of mouth cancer, and it happens at the level of the hyoid bone. Sometimes happen to me to resect the hyoid bone for infiltration of the, for example, genioglossus muscle or eoglossus muscle up to the hyoid bone. In that case, I prefer to remove the ipsilateral half or even the entire hyoid bone.
Sir, one last question can I ask, sir?
Sure.
Sir, do you ever perform bilateral compartment for some lesion who is involving the midline or crossing the midline? Bilateral compartment surgery?
Yeah, the total grossectomy obviously is still, unfortunately, a role. This is not something that I suggest for tumor crossing the midline, I would say for a few millimeters. In that case, I would enlarge my resection involving, for example, as like in the old days, 1 centimeter or 2 of the contralateral mid-tongue. But if the tumor involves the contralateral compartment for more than 1 centimeter, then in my view, there is still indication for a total grossectomy. There is indication for total grossectomy.
Okay.
Thank you, Professor Piazza, for a wonderful oration and patiently answering all the questions. I hope you can stay back for some time. The chat box is getting full with many questions, and we can discuss some of these issues in the chat box. I request Dr. Thakkar to come online to do the honors.
Thank you, Vikram. As much your privilege as mine. That Dr. Piazza, I'm glad to note that you have the oration medal with you. Of course. Yes, thank you so much. We would have liked it very much if you were here with us, but that's not to be on this occasion. Perhaps another occasion soon. Also, we would wish to induct you to the society as an honorary member.
Thank you very much.
Yes, and
it's a
Vikram,
pleasure. a real pleasure. I know most of you, and I really appreciate this honor greatly. Thank you a lot.
So,
Do we have the certificate? Zia,
yes.
the certificate? Yes.
So we undersigned hereby declare that Dr. Cesare Piazza is nominated an honorary life member of the Foundation for Head and Neck Oncology. As such, he shall enjoy the privileges and be subject to the obligation and membership of the foundation, whose objective is to promote the science and practice of head and neck oncology. Signed by President, Secretary, and Chairman, Governing Council. So welcome.
Thank you very much. It's a really honor for me. And I would like to be part of your meeting, hopefully next year in person. Thank you a lot.
Certainly. Thank you.
Like that. Thank you so much.
Thank you so much.
Of course, like you to stay on and hear further. And as everybody knows, you are going to be with us again tomorrow.
For sure. Thanks again.
Thank you.
Thank you very much.
Bye.
Dr. Cesar.
Bye.
Bye.
Professor Kudush is hosting next year's meeting, so perhaps Dr. Kudush can have Dr. Cesar.
Yeah,
next year.
keep that in mind. Dr. Cesar will keep that in mind.
Okay, over to Dr. Nebu.
Yeah, it is time for the next oration. It is the Professor R.M. Tiwari oration. I invite Professor Alok Thakur and Professor Anand Pathak to chair the session. Professor Alok Thakur is the President of the Federation of Head and Neck Oncology and head of head and neck surgery at AIIMS Hospital, New Delhi. And Professor Anand Pathak is a senior medical oncologist and director of the National Cancer Institute, Nagpur. Over to you, sir.
Thank you, Nebu. Dr. Pathak, sir.
Yeah. So nice seeing you in this meeting, and thank you for the invitation to chair this session. This is welcome to this oration in the memory of Dr. Ramohan Tiwari. I don't think he needs any introduction. Most of you know about his contribution, but I would like to take this opportunity to brief the participants about the significant contributions made by Dr. Tiwari. He was, as you know, the first president of the Fhno organization, and he did pioneering work in the field of head and neck oncology. He did his medical schooling in the year 1957 from Medical College Nagpur, and then went on to obtain Masters of Surgery in otorhinolaryngology from Bombay University in 1961. He further did DLO and FRCS from London and obtained his PhD in 1977. He also became a fellow of the American College of Surgeons. He then began his career as a head and neck surgeon, initially in Delhi, and then moved on to UK and Netherlands to practice as a head and neck surgeon. He returned to India and settled down in Bangalore in the year 1999 and established head and neck surgery at the Bangalore Institute of Oncology. He then gathered all the pioneering head and neck surgeons in the country to form the foundation of head and neck oncology in the year 2001. And he was instrumental to focus the organization on the academic and evidence-based practice in head and neck oncology. He has a number of publications in the international national journals, almost more than 100, and also wrote a textbook on excision and reconstruction of head and neck cancer, edited jointly with David Sauter and published in 1994. Some of the significant contributions that he made in the field of head and neck cancer include masseter cross overflap and primary closure of oral and oropharyngeal defects in 1987, temporal bone resections for carcinoma of middle ear and external ear, studies in the anatomy and pathology of orbit and its significance in the preservation of eye in carcinoma maxilla, surgical landmarks of infratemporal fossa published in 1998, and a transmandibular approach to total maxillectomy, published in year 2009. Dr. Tiwari left us in 2017. However, his legacy lives on with Fhno. So, thanks to the organizer to have this oration in memory and honor of Professor Dr. Ram Mohan Tiwari. Over to you, Alok.
Thank you, Dr. So, this oration in the name of Professor Tiwari is among the most prestigious of the orations for the meeting. And yes, we generally have a mix of science and basic science and craft in the oration. And this occasion, we have Professor Terence Jones. Professor Terence Jones is a professor of head and neck surgery and director of the Liverpool Head and Neck Cancer Center. He is also the director of research and innovation at the Liverpool University Hospital Foundation Trust. And he is affiliated to the Department of Molecular and Clinical Care at the University of Liverpool. So Professor Jones is actually well qualified in both aspects. He earned himself a BSc degree in microbiology and molecular biology in London, and then moved on to study medicine at the St. Bartholomew's Hospital. He subsequently undertook surgical training in otolaryngology and in head and neck surgery, of course, at Liverpool. All of us here, of course, know that Liverpool was and is in many ways the Mecca of head and neck surgery. This was a department set up by PM Stell, and no wonder that Terry Jones gravitated towards head and neck in his otolaryngology training. He was appointed an NHS consultant at the University Hospital Aintree in 2003. Fortuitously, as things have it, I was myself a fellow at the same department at that moment when Terry was appointed a consultant. It was quite obvious even then that he had deep interests in minimally invasive surgery, organ preservation, and of course, with regard to the basic principles and progression, the underlying questions with head and neck cancer. Pursuing his interest, he moved on to a research position by 2006. He was senior clinical lecturer, and very soon after he was professor. In 2018, when the Liverpool Head and Neck Cancer Center was launched, Dr. Jones was appointed as its inaugural director. And the Liverpool Head and Neck Center is today among the largest clinical research facilities for head and neck cancer in the world. It comprises of more than 200 clinicians and researchers, and they deliver research-led improvements in patient care. Also, at the national level in Britain, Dr. Jones is the national lead for the genomics for the England Head and Neck Clinical Interpretation Partnership. Drawing on his strengths, we have called him today, and with us today, he is going to be speaking to us on the genetic map of head and neck cancer, how it's evolving, and how it may impact cancer care. So Professor Jones, welcome. Thank you for being here. And we are honored, very much waiting to hear.
Thank you, Dr. Thakkar, and thank you to all of you for the honor of being able to speak to you today. It really is a huge honor, and I understand the gravity of the task I've been offered today. So thank you very much. It really is a true honor. So thanks to you and the organizing committee. So as you pointed out, I'll just share my screen, which is the first thing to do. So hopefully you'll be able to see those slides now. Yes, you can see the slides?
Yes.
Good. So as you pointed out, I've been asked to talk to you about the emerging insights on the genetic map of head and neck cancer and how that might impact on cancer care. I have no disclosures at this point in time. And one of the things I'd like to use to develop some of the arguments around how we might attempt to do this is to use this graph. We all know, particularly in the context of oropharynx cancer, but this applies to head and neck cancer in general, is that we've seen the emergence, particularly in the developed world, of HPV positive oropharynx cancer, but yet globally impactful. And the biggest global problem is also wrestling with HPV negative disease. And the important point of this graph is simply to display that the patients who suffer from HPV negative disease still, despite our efforts to improve things, still have relatively moderate overall survival outcomes in term, over their lifespan. And whilst we all appreciate that patients with HPV positive disease do far better from treatment, response to treatment, we must always be minded that there's a 10 or 15% of this population that still also do incredibly badly. And so we're in this interesting situation within HPV negative disease. We're still trying to strive for ways to improve survival, where functional outcomes might become less of a concern to address in survival. Whereas in the context of HPV positive disease, with patients presenting at a younger, earlier stage in their lives and much more fit, and surviving in greater numbers, then actually what we are increasingly having to address is the consequence of the treatment outcome to maintain or actually even improve survival outcomes, whilst mitigating the effects of treatment downside, treatment adverse events. The problem we've actually got is that it's actually really difficult to, in fact impossible at the moment, to identify the patients who are likely to do badly from treatment up front. And so we need to find ways of identifying those individuals as well. When we manage oropharynx cancer in particular, once many of us grew up doing these big operations, we probably no longer do them. And there's two reasons for that. One is that they were significantly mutilating, and whilst they worked in terms of survival outcomes, the quality of life that was left after them was left a lot to be desired. But actually, more importantly, concurrent with this was lots of high-level evidence, level 1 evidence, that was confirming that the use of concurrent chemoradiotherapy to treat oropharynx cancer conferred a significant survival advantage. And that these initial clinical trial data were backed up with really quite impressive meta-analysis data, which essentially has established that if you add chemotherapy in a concurrent setting to standard of care radiotherapy, then patients might enjoy a 6.5% enhanced survival at 5 years. And so when you take that into account, it's not surprising you see data like this, that from the late 1990s, you see a massive increase in the use of chemoradiotherapy to treat oropharynx cancer, and a concomitant decline in the use of surgery. As time progressed, the radiation oncologists were getting better at what they did. So they were using function-sparing techniques, particularly intensity modulated radiotherapy. And once again, there's level 1 evidence to suggest that if you treat patients in a function-sparing way, this is data from Chris Nutting's Passport study, then you will improve functional quality of patients who you're treating. But at the same time, there were, in many centers across the world, there were moves afoot to attempt to stop doing the large open surgery that I alluded to previously, but rather to develop transoral surgical techniques with the idea of, once again, maintaining survival, but mitigating the consequences of large open surgery. And whilst Wolfgang Steiner and Petra Ambrosch were developing transoral laser microsurgery from Europe, then latterly Greg Weinstein and Bert O'Malley were developing transoral robotic surgery for use in head and neck cancer, which has become widely adopted throughout the world. We also know that there are significant, quite large size retrospective data sets which confirm that treating patients transorally is possibly not a bad thing. I have most intimate knowledge of our own data, which is, I think, the largest single center data, which we reported on our first 264 patients that we treated with transoral laser surgery. And for reasons that I won't go into at the moment, but happy to address afterwards, the vast majority of these patients, despite features that might be considered adverse surgical prognostic features, were treated with postoperative radiotherapy alone. And we were able to confirm that despite this, treating patients with transdermal laser microsurgery and postoperative radiotherapy, it looked like the survival outcomes were as good and comparable with any other treatment that had actually been published to date. Not surprisingly, we saw a split off between HPV positive and HPV negative disease, with HPV positive disease doing far better. Of our 264 in the cohort, 2/3 of these were HPV positive. Our local regional control rates were extremely high at 91% at 5 years. And once again, as I say, patients with HPV positive disease do far better. So that proved nothing other than the fact that we were doing nothing that was dangerous or nothing that was unsafe, and confirmed that this was hypothesis generating, as that this treatment strategy may be a way of addressing some of the broader concepts that we're attempting to achieve whilst treating these patients. What we are aware of, though, is that that's not to say that surgery is without its consequence, but non-surgical treatment, particularly postoperative radiotherapy and concurrent chemoradiotherapy, is not without its adverse features. And if you look at these data, these are patients who, the green columns are patients who had open surgery and parallel opposed field radiotherapy. They're old studies. And you can see that significant numbers of patients managed in this way are dependent on feed-in tubes at 1 year after their treatment. In the purple columns, these are patients who had chemoradiotherapy, concurrent chemoradiotherapy, but that the radiotherapy was delivered by parallel opposed fields. And these patients also had significant need for feed-in tube at 1 year. The yellow column studies involve patients who had chemoradiotherapy but were treated with intensity modulated radiation, function sparing, and therefore you can see whilst there is an improvement in the necessity for feed-in tube at 1 year, then still in significant numbers of cases that feed-in tube is still required at 1 year. And then in comparison to our cohort, where the feed-in tube rate at 1 year was 2.3%. So this actually again fed into the narrative that maybe this is a reasonable way to start treating these patients. I make the point here that the off-target effects of chemoradiotherapy are obviously negated if you only treat patients with surgery and radiotherapy. If we look at other data, Kate Hutchison has been active in these data to suggest that if you manage patients with transoral robotic surgery, so transorally versus IMRT, their gastrostomy rates are better. That if you ask the patients how well they do after this treatment, they report outcomes using the MD Anderson dysphagia inventory that are favorable that are favorable for TORS treatment at all time points after treatment, despite being having similar swallowing functions pre-treatment. And then Joe Patterson and James O'Hara in Newcastle did this comprehensive study, which suggests that whether you ask the patient whether you measure how much water they can, how quickly they can swallow 100 mils of water, what their diet's like, at all time points, patient managed with transoral laser microsurgery and radiation compared with chemoradiotherapy, their functional outcomes were better at all time points. So taking all of that into account, it's probably not unreasonable. We see these data now is where, since the FDA approved transoral robotic surgery for head and neck cancer in 2008, we've seen a reverse of that previous trend that I showed you, where far more patients are being managed with surgery. But this doesn't help us when we're actually when we're trying to personalize treatment. Data from clinical trials is obviously something that many of us spend our lives trying to achieve, but ultimately they're not amazingly helpful when you've got a patient sitting in front of you and you're trying to make a very specific decision relating to that patient. So some central questions is how might we identify patients who will do badly? And that's badly in terms of survival and or toxicity outcomes. And actually, how might we identify patients who will do well? As I've already mentioned, clinical trial or cohort data are not particularly helpful in this quest. And then an acceptance that probably nothing is more personalized than either our germline genome and or our tumor genome. And so the question then is, the holy grail is, how might we individualize or personalize treatment based on this emerging genomic data? And that can be used in two ways. It could either be prognostic, so if a patient presents with a given tumor, with a given fitness status, you might be able to prognosticate how well they will do given the treatment that you'll provide them. But more subtle than that is that you may be able to predict which treatment might actually confer better and more advantageous outcomes, both in terms of survival and functional outcome, if we had those data and we were able to deal with that issue of personalization in a better way than we currently can. Well, I guess the background to all of this starts with the Human Genome Project, this fantastic project that started in the US by the Clinton administration, started in 1990 and completed in 2003. And that gives us a huge indicator of how things have moved on. We're now sequencing genomes in days and in some places in hours, depending on which way you want to do it. So it shows how much this technology has moved on. And in doing that, things have become far, far more cheaper, so that this is now becoming readily available to us in clinical practice. So the first meaningful publication for us in this group was from the Cancer Genome Atlas Network, and you'll all be aware of this. This contained 279 heterogeneous head and neck squamous carcinomas, and it was published in Nature. And the findings from this was to confirm what everybody suspected, was that HPV and non-HPV tumors are molecularly distinct. That in the context of HPV, you would have integration linked to increased somatic copy number variants. There was a finding of shortened or deleted TRAF3 dysfunctional immune responses, and then you get an amplification of the transcription factors downstream from the retinoblastoma protein. It was also noted that PIK3CA mutations were increased as well. In contrast, in the HPV negative disease, we saw high frequency of TP53 mutations, CDKN2A inactivation, and frequent copy number variations. But whilst that was really interesting in data that we've not seen before, this is also limited in providing us with an ability to personalize treatment, because there are a small n when you split down 279 into its constituent subcategories, and there will be inadequate linked outcome data to this. So this too didn't lead us to where we want to be. Now, at the same time, albeit later on, the government in the UK decided that it wanted to become one of the world leaders in personalized medicine in healthcare, and it provided a significant amount of funding from central government and formed a company called Genomics England. And the mission of Genomics England in December 2012, announced by the then Prime Minister David Cameron, was to sequence 100,000 genomes, hence the 100,000 Genome Project. And that would include about 75,000 people that they would hope to sequence by 2019. And the original focus was on rare disease, but latterly was extended to include cancer. And as I've already alluded to, the aims was to create a new genomic medicine service for the UK. They pinned all of their aspirations on including personalized medicine strategies into routine care, that they stuck to whole genome sequencing rather than targeted sequencing or exome sequencing, because that would maximize the research power. And therefore, it would also provide an impetus to develop the medical research capabilities and expertise of the UK. We in the UK have a very advantageous or very beneficial arrangement with our National Health Service, where we have access to unified national medical records. So there was a theoretical possibility of combining this genomic sequencing with medical records, and that could be the largest resource to develop this in the world. It would lead us to understand how best to deliver genomics in healthcare. And we could actually do all the things that you would expect to feed off that sort of factory type of process. And as I've already mentioned, the idea was to make the UK a world leader in the genomics industry. So very simply, what they actually did, again, as an advantage of working in the NHS, is that they set up an ethics process, which meant that of patients who were undergoing resective procedures or having blood for any other process, that there was a consent process that allowed anything that was in excess of that required for routine diagnosis could be then utilized, subject to the consent of the patients, for genomic sequencing. So this is what this looked in a stylized way. They created essentially a research embassy, and the sequencing data, which came from a massive investment in sequencing infrastructure, was ultimately linked to the health records of patients being treated within the NHS. This required massive data infrastructure, which was also funded. And then the idea was, by the time you ally the healthcare data to the sequencing data, you then have a firewall, because everybody is identified on this side of the firewall, which allows a research resource to be passed through the firewall, subject to the usual safety constraints, to clinicians and academics or industry even, to develop how you might use personalized medicine in this setting. So as part of this, they formed what were called genomic clinical interpretation partnerships, or GCIPs, around various tumor-defined groups, and one of them was head and neck, and I have the privilege to lead that on a national level. And we have developed several aims. Again, the aim would be to develop personalized therapy approach to inform treatment selection and prognostication, much as I've described, but very specifically to identify genomics-based novel therapeutic targets, to be able to facilitate drug repurposing, to also define clinically informative biomarkers, particularly of risk stratification and treatment outcomes. So to do exactly what I've tried to describe to you up to now. Now, for reasons I won't bore you with, we were late to the game. We weren't invited in. Head and neck was felt to be too small. So we were only started recruited to the 100,000 Genome Project for the last 18 months or 2 years of the project. We set up our own individual research domain, where we had a squamous cell domain, we had a sinonasal cancer, salivary gland, thyroid gland, pediatric head and neck cancer subdomain. And by the similar principles, the sequencing data would be allied to clinical data. We have an analytical team which would address questions of individuals who were co-opted into these various subdomains. And that's exactly what we've been developing over the last 3 years. So we managed to contribute in total 355 patients to this. The research embassy is not the most straightforward organizational structure, and we've struggled with that a little bit, but what we have got at the moment in preparation for publication is our first 106 cases, which happen to come from Liverpool and were allied to very rich data sets. And as you might imagine, that there's a complete heterogeneous group of tumors, very much like the TCGA data, across various stages and various sites, who have all undergone whole genome sequencing. And our initial data, which I'll give you the headlines of, is that we did an initial comparison with the TCGA data, and we were pleased to report that actually, as you can see from these plots here, that we were pretty similar in terms of gene frequency. And of particular relevance was this almost identical frequency of p53 mutations in both the Liverpool cohort and the TCGA cohort. Similar frequencies of gene mutations in other genes that had been identified in the original TCA data set. So if you look a little bit more detail at this TP53 mutation state, and the reasons for doing this is that it is likely that this would have, if we were able to assay the mutational status of P53, that this is likely to have really significant impacts on how we might manage patients. The problem with everything prior to sequencing is that it was almost impossible to measure P53 status. It doesn't lend itself to immunohistochemistry because of the regulatory cycle of its expression. It's only expressed at times of stress. And there was an inference that every time you saw immunohistochemical overexpression of P53, that this was synonymous with a mutational state. And frankly, that's not sensitive and specific enough, because that's untrue in a significant amount of cases. So it's only when you're able to sequence TP53 are you really able to make a genuine attempt at defining the mutational status. So now that we are able to do that, we were able to show, interestingly, that there were no P53 mutations in the very small numbers of HPV patients that we actually had included in our data set, and that all the P53 mutations were included in the HPV negative cohort. And what we're seeing, which is probably what we'd expect, is that patients with wild type P53 have a very similar survival outcome to patients who are HPV positive, i.e. that they're in this good outcome group. Whereas if you see patients with P53 mutation, they do less well. You can actually drill into this a little bit more, rather than just saying P53 mutations. The P53 is obviously one of the major tumor suppressor genes in the body, and it acts in a quaternary structure, in a tetrameric structure when for its biological activity, and that there are mutations that can be missense or truly truncating. And obviously truncating mutations are essentially mutations where there aren't any active P53 at all. And once again, we're seeing split out between wild type P53, which is very similar outcomes to HPV positive. We're seeing an intermediate outcome stage here with missense P53 mutations. So these are single point mutations where the P53 will still maintain some activity, but not all its maximal activity. And then the truncated versions of the patients with P53 with no definitive activity at all. Looking at that slightly more detail, you can divide these mutations, which is probably the more clinically helpful, into wild type, non-disruptive, so these would be missense mutations where some activity will be maintained, and then disruptive mutations, which will include the truncated mutations that I showed you before, and also mutations in the DNA binding site, which will nullify the effects of P53. And once again, we see exactly the same thing. So we see wild type patients with wild type tumors doing better, in keeping with HPV positive tumors. We have patients with non-disruptive tumors doing an intermediate risk category, with the poorest outcome of patients who have disruptive mutations. And so the way that we can actually, and we aspire to use this, we're working up an application for funding for a cohort study that will actually assay with sequence P53 in all patients undergoing treatment for head and neck cancer, in an attempt to establish this in a real-world pragmatic setting, so that then we can think of taking this to one level further to include P53 whole genome sequencing into an algorithm as to how we might manage patients with head and neck cancer. So just moving slightly aside, if we consider oropharynx cancer specifically at the moment, we've got, as I've pointed out before, this issue of identifying patients who will do badly, identifying patients will be doing well, which is the opposite side of that coin, and then also finding strategies which will actually improve outcomes, both in terms of survival, but particularly in function terms. So if we're going to address that, we've got a few outstanding problems before we convince people to do something differently. I'm biased in terms of transoral surgical approach, but we have no level 1 evidence comparing transoral surgery with non-surgical treatments, and the likelihood is we never will. There's an issue about margins, which we won't go into today, but we need to remember that surgical margins are simply surrogates of outcome, and if outcomes are good, then it's likely that margins are good. And then the central vex question is in the clinical setting is whether we can de-intensify adjuvant treatments, and particularly whether in pathologically high-risk HPV or oropharynx cases, postoperative chemoradiotherapy is actually essential, or whether postoperative radiotherapy is sufficient. And then there's the obvious question of should treatment be intensified for high-risk oropharynx cases. The reason for giving you all of that background is it leads me to this study, which is dear to my heart. It's a PATHOS clinical trial, which is led by myself and my colleague and friend, Professor Mererid Evans, who's a clinical oncologist in Cardiff. And this trial recruits patients with HPV positive oropharynx cancer, which would be managed with transoral surgery and a neck dissection. And following their surgery, they're then allocated to one of 3 risk groups. The low risk group are patients who require no adjuvant treatment. The patients in high risk group would be patients who either have a surgical margin which is less than 1 millimeter and or the presence of extranodal extension. And those high-risk features normally, or via the Cooper and Bernier data, should be managed with postoperative chemoradiotherapy, 60 gray and 30 fractions. So that randomization either treats with the either randomize patients to the control or to receiving 60 gray of radiation in 30 fractions alone. The intermediate group B risk group are patients who don't have those adverse features but still require radiotherapy. And the randomization is whether they require standard of care radiotherapy, 60 gray in 30 fractions, or whether that can be safely reduced to 50 gray in 25 fractions. The primary endpoint of this is a co-primary endpoint, which is overall survival and swallowing function as measured by the MDADI at 12 months post-treatment. And we're looking for a clinically meaningful 10-point difference in that. And then we've got the usual secondary endpoints that we're measuring. Funding, this trial's been ongoing from 2015, is now a phase 3. It's eye-watering numbers are required in this trial because the event rate is so low, and we're currently requiring 1,100 patients in this trial to answer those 2 questions. We're recruiting in 32 sites in the UK and have been now for some years. And really positively, we're open in 2 sites in the USA. We're opening 12 sites, about to be opening 12 sites in France. We are opening in Australia, 10 sites in Germany, hope to open in 2 sites in Switzerland, and working to open in Hong Kong. Truly international study so that we can get the numbers required to answer the questions that we do. This is what we're doing up to now. We've registered best part of 620 patients and randomized nearly 400. So COVID obviously intervened, and there's been a bit of a delay in opening non-UK centres, but we're roughly on track for what we think to be recruiting to the end of October 23 to answer these really important questions. But in the context of today's talk, whilst giving you the background of the trial, the most important thing as I say, for the context of today, is that we've also got a bioresource collection funded with this, which we call Pathos P. And that gives us the ability to collect up to 5 biopsies, geographically distinct biopsies from the primary site and from 2 involved lymph nodes, together with blood samples pre-treatment, 6 weeks, 6 months, 12 months, 18 months, 24 months post-treatment. And these samples are collected fresh, they're put in RNA preservative, and they will underpin, together with the data from the clinical trial, they will underpin a pretty ambitious program of translational research called Pathos Trans. And this will constitute the largest bioresource in the homogeneous HPV oropharynx group in the world to date. And our current plans are that we will molecularly profile these tumors by whole genome sequencing. We've already secured funding to sequence 300 patients with a germline sequence and 3 tumor samples associated with that whole genome sequencing. And I obviously haven't got those data for you today because that's to be done, but funding has been secured. But very interestingly is investigating the role of intratumor immunobiology as a mediator of outcome, because we're moving into an era where immuno-oncology is becoming an increasingly important way of managing patients with these diseases. And this is based on some fantastic work that is being carried out by an extremely good friend and colleague of mine, Professor Christian Ottensmeier, who we work very closely with Professor Vijay Anand in the La Jolla Institute in San Diego. And they've done some fantastic work over the years in defining the role of tumor-infiltrating lymphocytes in the outcome of head and neck cancer. This initial data has been done by Christian Ottensmeier and Gareth Thomas in Southampton. And what they've now demonstrated in an increasingly large cohort is that if you get the greater the density of tumor-infiltrating lymphocytes within the solid tumor, the better patients do. And that's across both HPV negative and HPV positive tumors. They've also done a significant amount of work on transcriptomic analysis. So this is sequencing all the RNA molecules that are related in these tumor samples that they've looked at. So just looking at this heat map, you've got 3 categorization of tumors, ones with low tumor-infiltrating lymphocytes, so these patients do less well, as we know, or the worst. We've got an intermediate moderate group who have an intermediate outcome, and then the high TIL tumors, which do best. And what you can actually see here is that there is a significant difference in gene expression between the low TIL tumors, the low TIL, the low TIL tumors and the high TIL tumors. And what's particularly important is, particularly with relating to immune genes being upregulated. And what's particularly noticeable is that these in the high density infiltrated tumors, there's big upregulation of PD-L1, PD-L2, and PD-1. And as we know, they're the checkpoint inhibitors that are currently being targeted by the anti-checkpoint inhibitor therapies that are now being increasingly used. So if we take those data, what we can actually do is make some predictions. And what you would actually suggest is that the patients in this blue group, so they're TIL low with decreased expression of immune regulated genes, that these patients will relapse early, they'll do worse, and they won't respond to PD-1 treatment. Essentially, they'd be immune cold tumors. And the corollary of that is that the patients in the red aspect of this heat map will relapse late or do better, and that they will respond to anti-PD-1 treatment. And that immediately gives us a segregation into patients, how we might actually use these sorts of data to determine how we manage patients with anti-PD-1 therapies as we progress into learning how we utilize these drugs in contemporary treatments. If we take this to a different level, what we all know is that the vast majority of immune cells in the body circulate through blood, primary, secondary lymphoid tissues, but there's a category of immune cells called tissue-resident memory cells, which do exactly what they say on the tin, is that they stay resident after being challenged with an antigen. They stay resident in the tissues. And these are increasingly understood as important parts of the innate immune system, particularly in epithelial cancer formation. So if you interrogate the tumor-infiltrating lymphocyte populations and look specifically for tissue-resident memory cells, what you actually find is that you find a group of these that express CD103 which are highly implicated, taking the analysis of this to a different level. And that if you look at CD103 high versus CD103 low tumors, that patients are discriminated in terms of their survival outcomes simply on the expression of that. So you can see that you're going from HPV positive negative through to TIL high to TIL low, through to tissue microarray, through to CD103 positive or 103 negative, and you're increasingly distilling down to smaller and smaller numbers and becoming much more sensitive about how you predict how patients might do and what therapies you might use in their future treatments. And you can go even further. You can actually do single cell analysis, which subdivides these tissue microarrays into clusters. And I want, for the purposes of today, is to concentrate particularly on this purple cluster, which is found differentially expressed in tumors relative to normal tissue. And what you find if you look at these is that that purple cluster is a differential expressions of cytotoxic genes. And so what you might expect is, so purple, these happen to be TIM3 positive cells, and they're highly expressive cytotoxic genes. And so what you might expect is that patients who are rich in TIM3 CD103 positive cells, the tumor infiltrating lymphocytes, are patients who would actually do very well from these treatments, both in terms of outcome and response to anti-PD-1s. And so you can see where this story is leading, is taking forever layers off the onion ring to understand these details, these data and these biological phenomena to be used in clinical treatments more and more. And it leads to some continued research questions. So again, how might we use these data to validate surrogate markers of good and poor outcome, immune hot, immune cold tumors? What molecular features predict poor outcome? Interesting, what's the role of viral gene expression in this context? Does it make any impact on what might be the host gene expression, tumor infiltration, lymphocyte density, and to look forward to further treatments, which I'll come to in a second, is what shared and unique antigens are expressed in particularly HPV positive head and neck squamous cell cancer, but it could actually be any squamous cell carcinoma. So if I start expanding that last context a little bit more, if you think about it, how do we exploit what a cancer cell makes to attempt to treat? And so if you look at tumor-associated antigens in head and neck cancer, you could get viral antigens, and we know that HPV is implicated in this, and Epstein-Barr virus in nasopharyngeal cancer. But also we could have non-viral antigens, and they could be broadly split into mutated tumor antigens. They become then tumor-specific antigens, and these are typically the cancer-driving mutations. And high on this list would be TP53 in the context of head and neck cancer, which I've already spoken to you about. You could actually get somatic mutations, which would lead you to neoantigens, and this would lead you into the highly exciting field of personalized vaccines, which I'm going to come back to in a second. Unmutated tumor antigens would be the antigens that are typically expressed on many cancers. Probably the best known example of this is the cancer testis antigens, but there are others. So how might we exploit this? So this is a really exciting protocol that we've just opened in Liverpool, led by Christian, who's now located. We had the pleasure of recruiting him to Liverpool in the last year from Southampton. And this is now a randomized phase 1 clinical trial of patients with newly advanced, newly diagnosed, regionally advanced HPV negative squamous cell carcinoma to develop a personalized vaccine. And it's in collaboration with Transgene. It's a phase 1 study, as I say. It's multi-center. We're leading in Liverpool. It's randomized, newly diagnosed, locally advanced head and neck cancer, and we're looking for 30 patients randomized on a 1-to-1 basis. And the usual inclusion criteria, as you would expect, patients have to be fit for this treatment, as you'd expect for the phase 1 trial. And patients will be eligible if they're destined to have curative treatment, that's surgery, plus or minus relevant adjuvant treatment. And they're available to have both blood and tumor samples taken. And the way this works is that at the time of surgery, tumor samples are taken together with blood, and they're actually sent off for sequencing. You sequence both the tumor and the germline. And then from that, you're able to compare and identify specific tumor-specific mutations, exactly as I showed you in that previous slide. And this then identifies the most abundant tumor-specific neoantigens for that tumor. You then use that data, that information to go away and form synthetic gene encoding most relevant neoepitopes, and you put this into a vaccinia antigen vaccine host. You put this into a vaccine host. And when these patients relapse, the idea is that they will have an already available personalized vaccine personalized to their tumor that they can be inoculated with at that particular point in time. So the design of the trial is exactly as I say. Patients would undergo surgery. They'd go through that process to have a unique vaccine based. The randomization here is that patients who after surgery would be inoculated at these time points until they recur, or not, as the case may be. In arm B, patients wouldn't be vaccinated until they recur. So we'll get a differential readout here as to effect of the vaccine in this period of the trial, and then we'll have another assay to see how much the vaccine would actually prevent recurrence as both of these two arms coalesce to having recurrent disease. So that's hugely exciting, as you might imagine. The primary outcome is obviously safety and tolerability of these injection regimes. Secondary outcomes would be failure to provide, or who's unable to provide the necessary requirements for the trial, plus survival, event-free survival. And then there's lots and lots of science, exploratory science, that we can do off the back end of that to understand this a little bit more. So if I pull all of that to a conclusion, I realize that we've covered a lot of space in that, but essentially the development of personalized approaches to treatment of head and neck cancer is an urgent research need. And whilst we have large-scale randomized controlled trials in generating level 1 evidence. They're really quite limited in developing personalized approaches. Genomic data, germline and tumor, in contrast, are highly personal and underpin numerous approaches to identify these really personalized approaches to treatment, individualized approaches to treatment. What's key is that high quality bioresources and linked clinical data are critical, and therefore so is the involvement of clinicians and particularly surgeons in a lot of these strategies. And accepting my bias, I think this is a really exciting area for future development, and that we need to watch this space. None of the stuff I've spoken to you about happens on its own, so I really want to thank the team back at Liverpool for allowing us to develop the transoral laser microsurgery approach. My work with the team around pathos has been one of the most fulfilling things in my career, particularly working with Mererid Evans, without whom none of this would actually happen. Working with the Genomics England team and some really bright individuals, particularly Tim Fenton and Ian Reddin, who are doing a lot of the analysis in some of these data, has been a truly fulfilling, really, really positive experience for somebody like me from a surgical background at this stage of my career. And then these two gentlemen are truly outstanding individuals and scientists. Christian Ottensmeyer is one of the world leaders in tumor immunobiology, particularly in the context of head and neck. And Vijay Pandurangan is a truly startling scientist who is so energizing and positive. And I want to thank both of those for engaging with us and our efforts in the Liverpool Head and Neck Centre. Thank you so much.
Thank you, Professor Jones. That's been, I'm out of words. It's been excellent. You have elucidated a topic which we find very difficult, and you have managed to convey to us the exciting developments that await us. As you said, watch this space. You did tell us that the Human Genomic Project was an exploration inwards, and that one exploration inwards is not yet 20 years since it was culminated, but the progress we see already, of course. We have a panel of colleagues who are involved a little bit with this, and we would very much like if we can have some discussion on this. So we have Binay Panda, and Dr. Panda is a professor at the Jawaharlal Nehru University of Cancer Genomics. He's a professor of cancer genomics and integrated data analysis here at New Delhi. Sudhir Nair is at the Tata Memorial Center at Mumbai, and he's very much a surgeon, but very much like you, a little bit of interest in research and further. And Sevanti is Director of Precision Oncology. She's a medical oncology by training, and she's again at Mumbai. So Sevanti, any thoughts, questions?
Wonderful, wonderful presentation, sir. Professor Jones, amazing, and truly a treat to hear about your work and the kind of exciting research that is happening. Few very quick questions. So one of my questions, and this is from my previous observations regarding the TCGA data. As a medical oncologist, I keep looking for longitudinal data on molecular testing in head and neck. And when I go back to the TCGA 200, 300 patients, most of the samples were surgical. Correct me if I'm wrong, but this is from way back. So do you think that the molecular signature, as we collect longitudinally in pre-treated patients for disease that has recurred or metastasized, would there be similarities, or is that still not very well known?
So thank you so much for the question. You've blown my cover already, because that's the obvious question in this, and actually where it plays probably can be answered in several ways. But so we got the TCGA data, and it's very much like the Genomics England data. It's highly limited. It's one snapshot, stuff that we actually didn't understand before. But actually, I'm still not sure of the applicability of it. I'm actually really not sure about how we utilize this data. For the two things I pointed out, one is that you've just assessed is it's snapshot in time, and what relevance is that? How might that vary? So the other bit that take into account, and this needs to be addressed to surgeons is a whole issue around intratumor heterogeneity, because if we're actually taking one biopsy sample, how representative it is. So how, if we're going to take some of these strategies, we need a handle on that true intratumor heterogeneity, which is another level of complexity. Where this becomes really important is in the last bit I spoke to you about, is the personalized vaccine. So we're investing a huge, or transgene is investing a huge amount of money into this. The bit that we really don't know is the relevance of those apparent tumor-associated antigens at that time point of surgery. And at recurrence time, is it still relevant? Is it still relevant in lymph nodes, which we know kill far more patients than primary site tumors? So I don't know the answer to, but neither does anybody else. So what we've attempted to do to try and address some of these issues, because they're highly complex, is that we're setting up a program in Liverpool where we're going to take on treatment biopsies, for example, to see what that variability is. So then we'll have primary site tumor lymphoid tissue on treatment biopsies, and then we've also got ethics and funding in some settings to take tissue at recurrence. And it's only by doing that we're then going to tease out some of those issues that you really correctly allude to.
Perfect. Thank you. That was a great answer. Dr. Thakur, if I'm allowed, I'll ask one more question because I know we are running late. So I'll just ask one more question, then pass it on. I've written many, so just the top two. One of the things that I realize when I'm looking at Indian patients, so I was in the US, now I'm in India, patients are different. Head and neck cancer in India is different. So do you anticipate difference in ethnicity contributing to the immune microenvironment? And is there any plan to study that in your center? Because in the US, we don't have as many Indian patients, but maybe in UK you do. And so is there any plan to study ethnicity as a differentiator for immune microenvironment?
Yeah, that's such a really important question as well. So the answer is yes, it's important. It's bound to be important. And the question about how we study this. So here's the plan. And as you'll be aware, Dr. Thakur and I know each other from an awful long time ago, and we have been having recent talks as to how we formalize the relationships between Liverpool and his own institution. We also have just appointed a head and neck pathologist who has extremely close ties with Papua New Guinea, and they have yet another ethnic variation of disease. Very interestingly, in endemic oral cavity cancer, that's P53 negative, for example, in a number of cases. So the idea would be then is how might we triangulate these research endeavors across three highly different or likely to be highly different populations to really tease out what are likely to be, I suspect, very different answers, very different strategies, depending on ethnicity, etiology, presentation, and all of those things that you correctly allude to.
Thank you.
Thank you, Sevanti. So yes, Dr. Binay Panda is professor in genetics here at Delhi. Dr. Panda, your reaction to an exciting development? Of course, it's a road which is very less traveled yet, I guess. But crystal gazing into the future. We don't hear you. Please unmute yourself, Dr. Panda.
Well, thank you very much, Dr. Thakur. Excellent talk, Dr. Jones. So I think you touched upon two very important points, which are, unsolved mysteries of use of genomics in head and neck cancer. I think head and neck oncology is probably one of the very few subspecialty in oncology where genomics and precision medicine is least touched. And it's not, I am saying, because we only have cetuximab, pembrolizumab or nivolumab, which is there as FDA approved. But you spoke about something which is extremely important. It's not because of the lack of the drugs, but the lack of the predictive markers. And the question that I have for you is, as you know that the initial euphoria about cetuximab has subsided, and it's not because cetuximab doesn't work, it's because we don't have a predictive marker for cetuximab. So I think it's about how we are stratifying the patients. And the question is that the recent analysis for the phase 3 data, which is published, I believe, in 2017 by the Yale group, they could find a single KRAS mutation, it's a germline mutation, in the 3' UTR. Now, the question is, don't you think when you are taking the coding reasons only, you are missing the germline mutations, which can potentially be predictive?
Sorry, is that was the end of the question? You just froze there. Could you repeat the last end of that question?
I was just asking, if you study, am I audible?
Yes, you are. Yeah, no, you are. Yeah.
If you are taking the coding sequences alone, are you not potentially missing those germline mutations in the non-coding reasons? For example, the 3' UTR that they found in KRAS. Of course, KRAS frequency is pretty low, as you know, in head and neck, but still, are you not concerned about that?
Yeah, and that's exactly the reason why we've been rigorous to not deviate away from whole genome sequencing at the minute. It's more expensive, it's more arduous, but the point being is that we know so little about this stuff at the moment, we'll miss stuff. And so if we dive in on the targets that are, it's going to be a blended approach, because we're going to end up doing whole genome sequencing for the discovery parts of this, but there will be things that emerge. I mean, I think we are in a position where P53 mutational status is probably primed if we prove the data in big enough numbers that we need to, that I think that could take us to a different level. So I think these things will be coming down the track in different ways. But in answer to your question, I think it answers your question, and you can use multiple examples of that, is that we need to continue doing whole genome sequencing on these patients for exactly that reason and many more. We could really miss the wood for the trees on a lot of this if we don't continue to do that.
Right, and the work that you showed about the P53 mutation is absolutely exciting. The worry that I will have by taking P53 mutation alone in HPV, and I think we all agree that we shouldn't really talk about head and neck tumors. We should talk about HPV positive or HPV negative. These are two completely different tumors as far as molecular classifications are concerned, as you mentioned that beautifully. Now, in HPV negative tumor, the P53 constitute nearly, depending on the cohort, about 80 to 85% of the patients. Now, when you take the mutation in P53 alone, what I'm afraid is that you are actually, probably putting a lot of patients who may respond to a therapy differently in one basket. Except that I liked the graph that you showed where P53 with the infiltrating, lymphocytes actually is an exceptionally good marker for good, prognosis, because obviously as we can anticipate more and more lymphocytes coming in with wild type P53 can work very good. So what I was going to, ask for your comment is, how do you feel like taking P53 alone when it constitutes nearly 80% of the HPV negative tumors?
So that's a really good point. And the answer is, it's still blunt. It's taken us a little bit further forward, but it's still blunt. A really central question to what you've just addressed now, which I think, why are some tumors high in lymphocytes and why are others not? And that has to be hypothesis, because I don't know the answer to this, but this has to be genomically driven at some point. So actually I would go further than that, is what's the genomic landscape that actually could be a driver of the lymphocytic landscape? I think we're in danger here of measuring lots of surrogates of outcome, because we're plotting them on survival curves. And actually what the true underlying aspects of this, very much the frailty of what you just described now, is picking on one might lead us further ahead, but it might not be the correct answer, and we might be missing things in the first place. So I think that's why we have to remain very, very open-minded about some of this stuff. And it's the usual complexity issue of what we do. Going back to your point about head and neck cancer, I think you're right. It's in its infancy as to how we do this. We're way behind personalized medicine strategies of breast and bigger tumors, for example, lung. But actually, it has one advantage. It's much, much easier to get hold of tissue because everybody's getting an upper airway endoscopy. That tissue can be easily got. So I think you raised some really, really important points that I don't disagree with at all. It's just methodically working through some of these stuff and not closing doors as we move forward.
Thank you. Dr. Thakur, if I may just have one quick question.
Let's have Sudhir ask a couple of questions.
Okay, thank you.
Yeah, I'm sure it's time for the inaugural function too. So Sudhir, the perspective of a clinician.
Yeah, thank you. Thanks, Dr. Thakur, sir.
Just started. Yes.
Yeah, I have two questions and quick questions continuing with the discussion on P53. I think, our patients are mostly tobacco chewers, and we see even in that tobacco chewers, our ICGC data shows that they have almost 70 to 80% having P53 mutations, and majority are HPV negative cancers. Now, we try to, it has a lot of excitations, but unfortunately P53 is difficult to target. And previously we tried gene therapy studies, but unfortunately lack of regulatory frameworks, we could not start in India. So your team has some publications regarding P53 affecting metabolism of cells. Do you have is there any hope in that direction for targeting P53 mutations?
Yeah, so that's a really, really interesting point. Is once you identify P53 mutation status as a biomarker of outcome, whichever way you're going to use it, it then leads us to the secondary question, which is totally appropriate to clinicians: is what are you going to do about it? And that's a whole issue about what you do about it. So I think there's two approaches. One is the data that you saw in that publication showed that if P53 mediates almost everything in the cell basically, and what we showed is that it was a metabolic mediator of glucose intake, that if you actually nullify the glucose intake by inhibiting one of the enzymatic pathway of glucose metabolism, that you'll enhance radiosensitivity. So I think that then starts addressing the secondary down points, is that if you detect some of these things, what are you actually going to do about them? And in that same thing, if you had a wild type P53, for example, could you use MDM2 inhibition to actually enhance P53 usage, to actually reduce external beam radiation, that you might actually want to do that. So I think many of those issues that you quite correctly are thinking through or addressing, I don't have the answers to. And it's the second part of this story, is actually, if you identify this, what actually are you going to do about it? In really simple terms, what you might want to do about it is that if you identify, for example, that, I don't know, and I'm just using a hypothetical example, I've got no data for this at all, but if you had a truncated mutation in B53 that was going to do particularly badly from combined chemoradiotherapy, for example, might you then actually choose to opt for surgery up front? And that would just be a very, very simple algorithmic flow diagram response. It may be actually the other way around. So I'm not saying that, I'm just using it as a truly hypothetical example as to how you might mitigate what you do here. But I think the novelty of new treatments coming down the track is the second stage.
One more question with permission of Dr. Thakur. And why we are not seeing any molecular based diagnostics in head and neck cancers? We still depend on histopathology, biopsy and histopathology. So can you have any?
Yeah, so I can only speak for the UK particularly, but I just don't think we've done the work yet. I think it's all there to be done. I think this becomes political in some ways, but we tried. I was a little bit unconvinced by the 100,000 Genome Project when it first was announced. I couldn't see what you were going to do with these data. And we asked, could we become involved, because we knew we could get the tissue, and we were politely refused entry to the 100,000 Genome Project because the assumption was that there would be lots of other much more numerous tissue types that would produce lots and lots of tissue. That actually proved not to be the case. So when we were halfway through, when the project was halfway through, and we asked to become a part again, they allowed us in, and we put 400 samples in within 18 months, compared to about 2,000 samples over 5 years for prostate cancer, for example. And suddenly, so we were punching well above our weight, and you suddenly realize that the stuff that we've then developed from that, even in this small little analysis, is actually leading us further down the track. But I think it comes back to all the answers to my previous questions, is that there are multiple layers to be continued taken off this. We just need to correct infrastructural approaches, collaborative approaches, because at the end of the day, we're still dealing with, apart from you guys, we're still dealing with relatively small numbers, which is why we need to collaborate with centers around the world, albeit that the etiology and the ethnicity issues might be very different. We just need to understand more.
Thank you.
Thank you, Professor Jones. Your passion shows through, as does that of the others. Unfortunately, we can't quite indulge on it for much longer. Vikram's here, and Dr. Pathak, maybe please join to have the medal. Terry, you have the medal on you?
I do.
You do? Please. Of course, it would be so much nicer if we had to. We could put it around you, but the situation being what it is, we are grateful. Thank you.
No, I'm extremely grateful.
Yes, absolutely. Wish we could have you with us. Of course, it will happen someday. And Vikram, would you wish to induct Professor Jones into our society? As you might have gathered, Terry, we do induct our honored speakers into the society as honorary members. And Dr. Kekatpure, our society secretary, would take us through that. So Vikram, could we have the certificate put up, please?
Thank you, Professor Jones, for a wonderful oration. So we, the undersigned, hereby declare that Dr. Terry M. Jones is nominated an honorary life member of Foundation for Head and Neck Oncology. As such, he shall enjoy the privileges and be subject to the obligation of membership of Foundation, whose objective is to promote the science and practice of head and neck oncology. Signed by Alok Thakkar, President, Vikram Kekatpure, Secretary, Subramaniam Iyer, Chairman, Governing Council. Welcome, Professor Jones, to our society.
Thank you so much. I'm so deeply humbled by this and honored. It means an awful lot to me. Thank you so much.
Thank you, Terry. And of course, we see you again tomorrow.
Absolutely.
Right.
Thanks so much. It was really good to talk to you. Speak tomorrow. Bye-bye.
Yes.
Thanks so much.
Thank you.
Dr. Anand, thank you.
Yeah,
Yes,
thank you. Thank you, sir. Yep.
Yes. We have a small inaugural function which is organized.
Yeah.
George is here, Dr.
Yeah. So we are starting the inaugural function. It is a very short inaugural function. We'll start with a silent prayer for about a minute. Thank you all. Welcome all the delegates to Fhno 2021. Can we have the inaugural video on now? We now move on to the welcome address by the organizing chairman. Can we have Dr. Bipin Thomas speech on?
Ladies and gentlemen, today is the culmination of 3 years of our preparation, and it is my pleasant duty to officially welcome one and all of you to the 21st Annual Conference of the Foundation of Head and Neck Oncology. The theme of Fhno 2021 is mitigating controversy and complication through technique and technology, and the outcomes of the proceedings will undoubtedly contribute to the advancement in the quality of life of cancer patients in our state and our nation. At the outset, I welcome our Honorable Minister for Health and Family Welfare, Srimati Fhno George, who has accepted our invitation to be the chief guest of the inaugural function that we are going to have now, and also to officially inaugurate the Fhno 2021. A warm welcome to you, Madam, to this function. Director of RCC, Professor Rekha A. Nair, has been our constant guiding force throughout the preparation of this meeting, and it is my pleasure to welcome her on behalf of the Joint Organizing Committee of the Regional Cancer Center, Trivandrum, and Fhno to this function. She will deliver a keynote address which will highlight the milestones of RCC, besides speaking a few words about our beloved founder director, Padma Shri Professor M. Krishnan Nair, who left us recently with his heavenly abode. The President of Fhno, Alok Thakkar, is part of us and the most consulted member of the current organizing team. I welcome you, sir, on behalf of the organizing team to our midst and look forward to your remarks. Dr. Shaji Thomas, Head of the Department of Surgical Services, RCC, has been our pillar of support all throughout the preparation of this event, and it is my pleasant task to welcome him to this meeting. I welcome Dr. Vikram Kekipure, Honorary Secretary of the Fhno, officially to this function, and look forward to hear his brief report as it is customary for all the annual Fhno meetings. I welcome all the delegates, faculty, both national and international, academic industrial partners, media professionals covering this function, staff members of RCC who are cooperating with us for the smooth conduct of the event to this function. Most importantly, now I welcome the organizing secretaries of the Fhno 2021, Dr. Elizabeth Matthew Ike and Dr. Nebu Abraham George, to our midst, and congratulate them for the exceptional organizational capability displayed by them. Last but not the least, I welcome all the members of the Joint Organizing Committee and applaud them for their wonderful effort in making this event a grand reality. I wish I could go on naming all of them individually, but for the limitation of time, I conclude my words with this. Thank you.
I would now like to invite the Director, Regional Cancer Center, Trivandrum, for her Director's address.
It's a great honor and pleasure to be able to address the 21st annual meeting of the Foundation for Head and Neck Oncology, which is being hosted by Regional Cancer Center, Trivandrum this year. Head and neck cancers being one of the commonest cancers in India, it's important to note that there is a declining trend in many parts of the country, largely due to the decline of oral cancers. The Division of Head and Neck Oncology in RCC was established in 2001 and offers comprehensive treatment for patients suffering from head and neck cancers, and we are also actively involved in cancer screening and prevention activities. In the field of head and neck oncology, RCC offers various academic programs like MCH head and neck surgery and 2-year fellowship programs in head and neck surgical oncology and head and neck clinical oncology. I take this opportunity to pay homage to our founder director, late Professor M. Krishnan Nair, who was a great visionary and a pathfinder in the field of oncology in India. He was instrumental in establishing RCC as one of the largest comprehensive cancer centers in India. He was well acclaimed nationally and internationally for his innovative ideas in oncology. He is credited with establishing the first community oncology department and pediatric oncology department in the country in RCC. He was a member of the expert group to form National Cancer Control Plan of India and was a WHO advisor for more than a decade as a member of the Expert Advisory Panel on Cancer. His contributions in oncology finds mention in IARC and WHO documents. His unequal contributions towards oncology earned him various laurels, including the prestigious Padma Shri Award in 2001. His demise on 28th of October 2021 will definitely leave an enormous vacuum amongst us. His contributions and foresight are a source of constant inspiration for all of us, and his life is an example to the world to aspire for great things even in limited resource settings. Let us uphold his legacy and work hard for betterment of cancer patients in the country. I wish all success to this great academic event. Thank you. Honorable Minister of State.
We'll observe a minute of silence in memory of our beloved director, ex-director, Professor Krishnan Nair. After that, we'll go for the inaugural address. I now welcome the Honorable Minister of Health and Family Welfare, Government of Kerala, to deliver her inaugural address. And as is a norm, the inaugural address is going to be in the regional language, Malayalam. Sorry.
Good morning, everyone. Bahmaniyaya Adhyaksha RCC Director, HOD, ഈ കോൺഫറൻസിൽ സംബന്ധിക്കുന്ന ഏറ്റവും ബഹുമാന്യരും പ്രിയപ്പെട്ടവരുമായ ഏവരുമേ, ഫൗണ്ടേഷൻ ഓഫ് ഹെഡ് ആൻഡ് നെക്ക് ഓങ്കോളജി സംഘടിപ്പിക്കുന്ന ഈ വെർച്വൽ കോൺഫറൻസിൽ പങ്കെടുക്കാൻ കഴിഞ്ഞതിൽ വളരെയധികം സന്തോഷമുണ്ട്. ഈ കാലഘട്ടത്തിൽ നിങ്ങൾ ഓരോരുത്തരും ഈ മേഖലയിൽ നടത്തുന്ന ഡെഡിക്കേറ്റഡ് ആയിട്ടുള്ള സേവനത്തിന് വേണ്ടി പ്രത്യേകമായ അഭിനന്ദനവും നന്ദിയും അറിയിക്കുകയാണ്. RCCയെ സംബന്ധിച്ചിടത്തോളം നമ്മുടെ ഹെഡ് ആൻഡ് നെക്ക് ഓങ്കോളജി വിഭാഗം വളരെ മികച്ച രീതിയിലുള്ള പ്രവർത്തനങ്ങളാണ് നടത്തുന്നത്. അത് ദേശീയ തലത്തിൽ തന്നെ അംഗീകരിക്കപ്പെട്ടതും ശ്രദ്ധ നേടിയിട്ടുള്ളതുമാണ്. പ്രത്യേകമായി ചികിത്സയ്ക്കൊപ്പം തന്നെ അക്കാഡമിക് ആക്ടിവിറ്റീസും വളരെ മികച്ച രീതിയിൽ മുന്നോട്ട് കൊണ്ടുപോകുന്നതിൽ ഡിപ്പാർട്ട്മെന്റ് വളരെയേറെ ശ്രദ്ധ പതിപ്പിക്കുന്നുണ്ട് എന്ന് മനസ്സിലാക്കുന്നതിൽ വളരെ സന്തോഷമുണ്ട്. അതുപോലെ തന്നെ അതിലും മികച്ചതായി മുന്നോട്ട് പോകട്ടെ, എല്ലാവിധ പിന്തുണയും ഈ അവസരത്തിൽ അറിയിക്കുകയാണ്. കേരളത്തിൽ ക്യാൻസർ ചികിത്സാ രംഗത്ത് ഈ 5 വർഷക്കാലം ശാസ്ത്രീയമായിട്ടുള്ള ഇടപെടലുകൾ നടത്തി മുന്നോട്ട് പോകണമെന്നുള്ളതാണ് സർക്കാർ ആലോചിക്കുന്നത്. അതിൽ സാമ്പത്തികമായി പിന്നോക്കം നിൽക്കുന്നവർക്ക് പരമാവധി സൗജന്യ ചികിത്സ നൽകിക്കൊണ്ട്, അതുപോലെ തന്നെ അതിന് ശേഷമുള്ള അവരുടെ മെഡിസിൻസ് ഉൾപ്പെടെയുള്ള കാര്യങ്ങളിലുമൊക്കെ ഏത് രീതിയിൽ ഒക്കെ നമുക്ക് ഇടപെടാൻ കഴിയും, അവരെ സഹായിക്കാൻ കഴിയും എന്നുള്ളത് പരിശോധിച്ചാണ് മുന്നോട്ട് പോകുന്നത്. അതോടൊപ്പം വളരെ പ്രധാനപ്പെട്ട ഒരു കാര്യം, കേരളത്തിൽ നമ്മളൊരു ക്യാൻസർ ഡേറ്റ രജിസ്ട്രി ഉണ്ടാക്കുകയാണ്. നമ്മുടെ RCC, അതുപോലെ CCC, അതുപോലെ MCC. അപ്പോൾ ഈ 3 റീജിയനുകളിലായിട്ട് നമ്മളുടെ ക്യാൻസർ സെന്ററുകൾ നമുക്കിപ്പോൾ പ്രവർത്തിക്കുന്നു. പ്രാദേശികമായി കാണപ്പെടുന്ന ക്യാൻസർ, ഏറ്റവും അധികം കാണപ്പെടുന്ന ക്യാൻസർ രോഗങ്ങൾക്ക് പ്രാദേശികമായിട്ടുള്ള വ്യത്യാസങ്ങളുണ്ട്. അപ്പോൾ അതിനനുസരിച്ചിട്ടുള്ള ഇടപെടലുകൾ, ഗവേഷണങ്ങൾ നമുക്ക് അനിവാര്യമായിട്ടുണ്ട്. അപ്പോൾ കേരളത്തെ സംബന്ധിച്ചിടത്തോളം അങ്ങനെയുള്ള ഒരു ക്യാൻസർ ഡേറ്റ രജിസ്ട്രി ഉണ്ടാക്കുന്നതിന് സർക്കാർ തീരുമാനിച്ചിട്ടുണ്ട്. അതിന്റെ നടപടികൾ ആരംഭിച്ചിട്ടുണ്ട്. ഈ ഒരു കാലഘട്ടത്തിൽ RCC, പ്രത്യേകിച്ച് റീജിയണൽ ക്യാൻസർ സെന്റർ തിരുവനന്തപുരം നൽകുന്ന നടത്തുന്ന എല്ലാവിധമായിട്ടുള്ള പ്രവർത്തനങ്ങൾക്കും ദീർഘവീക്ഷണത്തോടെ നടത്തുന്ന പ്രവർത്തനങ്ങൾക്കും എല്ലാവിധമായിട്ടുള്ള ആശംസകളും അർപ്പിച്ചുകൊണ്ട് ടീം RCCക്ക് എല്ലാ ആശംസകളും അറിയിച്ചുകൊണ്ട് ഔപചാരികമായി ഇന്ന് ഇവിടെ സംഘടിപ്പിക്കുന്ന ഫൗണ്ടേഷൻ ഫോർ ഹെഡ് ആൻഡ് നെക്ക് ഓങ്കോളജി സംഘടിപ്പിക്കുന്ന ഈ വെർച്വൽ കോൺഫറൻസ് ഔപചാരികമായി ഉദ്ഘാടനം ചെയ്യുന്നതായി അറിയിച്ചുകൊള്ളുന്നു. നന്ദി, നമസ്കാരം.
The Honorable Minister has just inaugurated the meeting, and she has highlighted the fact that Kerala is going to be the first state with a total cancer registry program in the government sector. All 3 cancer centers are together going to have a cancer registry program, and that was highlighted in the talk by the Honorable Minister. Now I invite Professor Alok Thakur for delivering the presidential address. Over to you, sir.
Thank you, everyone. So I don't quite have a recorded address here, but certainly my greetings and respects to the Honorable Minister, Srimati Fhno George, and Director of RCC. And congratulations to the entire team at Thiruvananthapuram, who's been working so hard to put this together. Congratulations also to Vikram Kekatpure, who's been equally hard at work to make this happen. We are well aware that head and neck cancers are unfortunately widely prevalent in our society. We are very much the epicenter. And perhaps the focus of the tobacco control program has been mainly on smoking, but hasn't addressed oral tobacco as it should. And this continues unabated. We continue with surrogate advertising, and certainly there are users who have migrated from smoking to oral tobacco. I just wish to emphasize that all of us here need to take some responsibility towards this, because some of us can influence policy. Certainly all of us can move forwards with advocacy. Perhaps we need to do a little bit more too on our side. As far as the Fhno goes, of course, it has thrived, it has moved forward. The advancement and sophistication in treatment on head and neck cancers has come home. We have knowledge and technology which is applied here in India, and certainly we know that we are at the cutting edge of head and neck practice. The Fhno in large measure can take credit for this, because we have been instrumental in disseminating practice improvements over the years. This meeting is another endeavor in the same and the prime reason we continue to be so relevant despite the disruption of moving to the virtual mode is, of course, because we have concentrated on science. Last year we had 800 odd independent registrations, and this year also is turning out quite similar. So congratulations really everybody. For my part, I am especially pleased that our trainees are so involved. The RCC had put up a journal club yesterday. It was great to see the enthusiasm of the trainees, the quality of their talks and their analysis. It was very heartening. And tomorrow again we have a session on the training which Elizabeth is mentoring, and I am particularly very much looking forward to it. So in my view, this is important. A scientific organization and a conference is not only about the stars and the thought leaders, it is about the delegates, it is about getting everybody involved, about discussing threadbare the issues of protection and of elevating practice standards for all. I think we are succeeding. So congratulations and thank you.
Thank you, sir. I would now welcome the Fhno Secretary for the Fhno Secretary's report. Over to you, Dr. Vikram.
Thank you.
Good evening all.
Congratulations.
Honorable Minister for Health and Family Welfare, Srimati Fhno George, respected Director of RCC, Dr. Rekha Nair, President of Fhno, Dr. Alok Thakur, Secretary Dr. Vikram, senior colleagues, organizing committee members, friends. The Department of Surgical Services of RCC is extremely delighted to host the 21st annual conference of Foundation of Head and Neck Oncology, as the department is about to complete its 40 years of service to the humanity. the Department of Surgical Services had a very humble beginning as part of RCC Trivandrum in one part of the Government Medical College Trivandrum, and evolved to be one of the finest departments of surgical oncology in the country. And there's training programs in all divisions of surgical oncology, namely head and neck surgery, surgical oncology and gynae oncology. And so many trainees and observers come to this center for training from all over the country and outside. These 3 days of training and academic sessions, orations, workshop will be of high standards and beneficial for the trainees and the practicing consultants. And I hope that this will give a new perspective and insight into the recent advances in the management of head and neck cancers. With these words, I wish all the best for the Fhno National Conference 2021. Thank you.
Sorry for that. There was a mess up of the order of the talks. That happens in a virtual conference, I guess. Over to Dr. Vikram for the Secretary's address.
Thank you. I would like to congratulate the local organizing team from Thiruvananthapuram. Indeed, this has been a challenging times, and I think we are having a great conference. So congratulations to the local team. So my job is to briefly mention the Secretary's report. The 20th annual meeting of Fhno was held on 12th and 13th December 2020. First virtual meeting, we were all new to it. We had more than 800 unique logins, and conference saw a partnership between AOMSI, Fhno, South Asian Symposium, and partnership with medical and radiation oncology. There were more than 150 abstracts, out of which best paper, best poster, and video was judged. There continues to be a great interest in our membership. In past 1 year, we have received more than 100 membership application, of which 78 have been already approved. They are from varied specialties like surgical oncology, ENT, maxillofacial surgery, pathology, and we are now 1,100 members strong organization, probably one of the largest in the world. We continue to promote education by supporting travel awards. Despite pandemic, we had 2 Shirin Gazdar 12 months award given, 3 6 months awards, and 7 candidates were awarded for 1 month travel award. This has been an important landmark year for our fellowship training program because there was exit exam conducted by following very stringent guidelines. Our journal continues to grow. It's a peer-reviewed, open access, biennial e-publication, Journal of Head and Neck Physician and Surgeon. We continue to have many online courses, both academic as well as a lot of allied topic on motivational topic talks which our faculty member delivered. Now most of our membership and application process has gone online, and I request all the members to use our website very well. So it's been a privilege. These 2 years have been challenging for everyone, and we at Fhno are happy that we could reinvent to carry out our activity despite the challenges brought by pandemic. So wishing everyone good health and all the very best for the conference. Thank you.
Thank you, Dr. Vikram. Now it is the last session. I invite the co-organizing secretary, Dr. Elizabeth, to deliver the vote of thanks.
Good evening, everyone. Respected senior members of the faculty and dear friends, I am here to present the vote of thanks for this function today. At the outset, I would like to thank the Honorable Minister of Health and Family Welfare of Kerala State, Mrs. Fhno George, for inaugurating this function, Fhno 2021. We are really honored to have listened to your precious words, Madam, and I extend my deep gratitude on behalf of Fhno and on behalf of RCC for keeping aside your part of your busy time to address us. I thank Professor Alok Thakkar, the President of Fhno, for gracing this occasion, and also, sir, for being a strong pillar of support for us for the last few months amid the uncertainties of the pandemic. I thank our respected director, Professor Rekha Madam, for her wonderful keynote address and also for helping and supporting us for hosting this meeting at RCC. I would like to thank the Honorable Secretary of Fhno, Dr. Vikram Kekatpure, for gracing this function and also for guiding us throughout our journey to organize this meeting. I thank our Head of Surgical Oncology, Dr. Shaji Thomas, for his leadership and contributions for organizing this meeting. I thank all my team members, Dr. Bipin, Balagopal, Nibu, Deepak, Rajneesh and Cecil for their hard work spent for making this event a successful conference. I thank all my colleagues in Surgical Oncology Department, Radiation Oncology, and also the Operation Theatre staff, the Engineering Division staff, the staff of the Information Technology of RCC for their help and guidance for this meeting. I would like to thank the eminent faculty for all the 4 workshops for making that academic program a grand success yesterday. I would like to thank all the eminent international faculties and national faculties for their contributions to this academic program as orators, keynote speakers, chairpersons, panelists, and speakers. I thank all the eminent delegates for their presence and contributions for our academic program. I would like to thank all the industry sponsors for supporting us for this meeting, Fhno 2021. Last but not the least, I would like to thank the event organizers, Meetings and More, for their great arrangement for making this event a grand success. Finally, I thank the Almighty for helping us and guiding us for organizing this meeting. Thank you. Good evening, everyone.
Thank you all. That was the end of the inaugural session. And I would like to ask Dr. Divya to now say a few words about the cultural program that we have in store for us.
Good evening to all. Now it's time to enjoy and relax after a day packed with knowledge and information. Sir, Madam, it's my pleasure to introduce before you Dr. Raji as Associate Professor Radiation Oncology from our own institution to perform Kathakali, the classical dance form of Kerala. He started Kathakali training at the age of 5 under Guru Kalanilayam Gopi and his father Kalanilayam Raghavan. He did his first performance at the age of 9. Today, he is going to present Geetopatesham, the main part of Mahabharatam, where he is playing the role of Arjuna and his guru, Kalanilayam Gopi, is playing the role of Krishna. Over to Dr. Raji to give a brief introduction about the Kathakali he is going to play. Thank you so much.
Dear friends, good evening. I know the time is too late to enjoy the art forms, but this is to relax. And as you know, the Kathakali is one of the complete art form and one of the great scientific art form, I must say. And there are so many reasons why I said that it is a scientific art form, but this is not the time to explain why it is a scientific art form. But you can see why it is a complete art form, because there is so many songs, there is percussions, there is acting, and it is a mixture of all these things. So earlier days, we used to see all these art forms only in temples of Kerala. And we invite you now for the great feast of cultural events that is happening in Kerala. So moving on to the play that we are going to show you today is regarding Bhagavad Gita, which is called in our language as Gita Upadesham. So I don't think there is no much explanation which is needed regarding what is Bhagavad Gita is, because each and every corner of the world know who is Lord Krishna and who is Arjuna. So anyway, what you are going to see for the next 20 or 25 minutes is a play in which Lord Krishna and Arjuna is going to come into the battlefield. You can see a character with a yellow dress, which is going to be Krishna, and a white dress is going to be Arjuna. So the great, almost all the stories of Kathakali is taken from great Hindu epics like Mahabharata and Ramayana. So this, as you know, from a small piece from Mahabharata. So they are going to come into the center of the battlefield, and Arjuna, as you know, is going to ask his charioteer Krishna to stop the chariot between the two great army field of Pandavas and Kauravas. And as we see a lot of genetic expressions like PDL1, EGFR and all these things, and we as oncologists don't know what to do exactly, and the surgeon might not don't want to resect a tumor with a skull base infiltration. So the same thing happens to Arjuna. He don't want to do a battle, and he don't know what to do exactly, and he is asking Krishna what to do. So that is a sort of scenario there, and Krishna exactly tells him and or reminding him what he as a human being to do his own right duties. So we have to stand up and be bold and to fight against cancer and fight against this molecular array. The same way, Krishna is asking Arjuna to fight against the evils. So that is what exactly happening, and but still Arjuna is not getting enough courage to do that, and finally Krishna decides to show the universal cosmic form, what we call as the avatar, Vishwarupa. So that by that way Arjuna realizes what is the real life and what is the meaning of death, and why what is the immortal Atma, and what is the body and all these feelings. And the Arjuna realizes he has to do his duty in the right way. So I think I have selected this play because we are all Arjunas, and we know what to do in the right way, in the right scenario to have a success as a career in oncology. And we are in the middle of a great difficult tumor and the poor patient. So this is the play that we are going to see, and please enjoy the show. Thank you.
അച്യുത നീരഥം നിർത്തേണം അച്യുത നീരഥം നിർത്തേണം അച്യുത നീരഥം നിർത്തേണം അച്യുത നീരദം തേണം അച്യുത നീരദം നിമിഷ നേരം ഇരുസേനകൾ നടുവിൽ 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 അടറിനു പോന്നു വന്നു ഇടയുമീ പടുമറു 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 പടതീകളേരന്നിടതീരിഞ്ഞറിയുവ പടതീകളേവരന്നിടതീരിഞ്ഞറിയുവ പടതീകൾ ഏവരൻ നിടതിരിഞ്ഞറിയുവ ഇവരെ വധിച്ചു രാജ്യഭരണം എന്തിനു കൃഷ്ണ വധിച്ചു രാജ്യഭരണം എന്തിനു കൃഷ്ണ ഇവരെ വധിച്ചു രാജ്യഭരണമെന്തിനു കൃഷ്ണ ഇവരെ വധിച്ചു രാജ്യഭരണമെന്തിനു കൃഷ്ണ വധിച്ചു രാജ്യഭരണമെന്തിനു കൃഷ്ണ ഇവരെ വധിച്ചു രാജ്യഭരണം എന്തിനു കൃഷ്ണ വധിച്ചു രാജ്യഭരണമെന്തിനു കൃഷ്ണ ഇവരെ വധിച്ചു രാജ്യഭരണം എന്തിനു കൃഷ്ണ തിരിക്കതേരി വീടന്നു നമുക്കു വേഗം തിരികത്തേരി വീടും ഗമിക്കാൻ നമുക്കു വേഗം തിരികത്തേരി വീടുന്നു ഗമിക്കാൻ നമുക്കു വേഗം തിരികത്തേരി വീടുന്നു ഗമിക്കാൻ നമുക്കു വേഗം തിരികത്തേരി വിടന്നു ഗമിക്കാൻ നമുക്കു വേഗം തിരികത്തേരി വീടുന്നു ഗമിക്കാൻ നമുക്കു വേഗം തിരി വിടന്നു ഗമിക്കാൻ വേഗം തളരുന്നു മമ ദേഹം ഇളകുന്നേല ഗാണ്ഡീവം തളരുന്നു മമ ദേഹം ഇളകുന്നേല ഗാണ്ഡീവം തളരുന്നു മമ ദേഹം ഇളകുന്നീല തളരുന്നു മമ ദേഹം ഇളകുന്നീല ഗാണ്ഡീവം 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 വളരുന്നു ഭയം 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 കനിഞ്ഞരുളേണം കരണീയം കനിഞ്ഞരുളേണം കരണീയം കനിഞ്ഞരുളേണം കരണീയം കനിഞ്ഞരുളേണം കരണീയം പാർത്ഥ പാർത്തുകിൽ അവമാനം ഇതു പാർത്ഥ പാർത്തുകിൽ അവമാനം ഇതു പാർത്ഥ പാർക്കുക അവമാനം ഇതു പാർത്ഥ അവമാനം ഇതു പാർത്ഥ പാർക്കുക അവമാനം ഇതു ഇതാർക്കു ചേർന്നതു വെടിയുക വിവശത ഇതാർക്കു ചേർന്നതു വെടിയുക വിവശത ഇതാർക്കു ചേർന്നതു വെടിയുക വിവശത ഇതാർക്കു ചേർന്നതു വെടിയുക ഇതാർക്കു ചേർന്നതു വെടിയുക കൊൽവനേവൻ യവനിക യവനിക கொல்வனேவன் எவனே எவனிக மிருதிபுவி எவனே எவனிக மிருதிபுவி சொல்க பரம சேதனா அவிநாசினி சொல்க பரம சேதனா அவிநாசினி சொல்க பரம சேதனா அவிநாசினி கருணா வருணாலய தருணாருண வதன வருணாலய தருணாருண வதன கருணா வருணாலய தருணாருண வதன வருணாலய கருணா வருணாலய தருணாருண வதன வருணாலய தருணாருண கருணா வருணாலய தருணாருண சரணம் தவ சரணம் சரணம் மம மாதவ சரணம் சரணம் தவ தரணம் மம மாதவ சரணம் சரணம் தவ சரணம் மம மாதவ சரணம் சரணம் தவ தரணம் மம மாதவ சரணம் சரணம் தவ சரணம் மம மாதவ விஜய ಎಂದಿನೂ ಕೃಷ್ಣ ಕೃಷ್ಣ ವಿಜಯ ಎಂದಿನೂ ಕೃಷ್ಣ ಕೃಷ್ಣ ವಿಜಯ ಎಂದಿನೂ ഹനനം ചെയ്തു വിജയമെന്തീനു കൃഷ്ണ സ്വജന ഹനനം ചെയ്തു വിജയം എന്തിനു കൃഷ്ണ സ്വജന ഹനനം ചെയ്തു വിജയമെന്തീനു കൃഷ്ണ സ്വജന ഹനനം ചെയ്തു നിജ നില അറിയാതി 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 ഈ വിജയനുൾ പതറും വിജയനുൾ പതറും ഈ വിജയനുൾ പതറും यदा यदा हि धर्मस्य ग्लानिर्भवति भारत अधर्मस्य तदात्मानम् सृजाम्यहम् परित्राणाय साधूनां विनाशाय च दुष्कृता धर्मसंस्थापनार्थाय संभव युगे युगे शेषयानं पिहकेशयानं धूतारिजातं धृतपारिजातं शेषालयेशं कमलालयेशं श्रीपद्मनाभं भजदञ्जनाभम्.
Okay. Yeah. That was a splendid performance by Dr. Rajiv. Hope you all enjoyed it. Let's listen now 3 songs sung by Mrs. Veena, who is a wife of our Brinda. It is Mrs. Brinda, who is a wife of our radiation oncologist, Dr. Rajneesh Kumar. The first is a Hindi song. The first song is a Hindi song. The first is a Hindi song from film O Kondi, Legja Gele, and this will be followed by 2 Malayalam songs. One is a Onam song and the other is a old Malayalam movie song. Let's enjoy. Gurmi, can you please play this Legja Gele? The other Hindi song. Can you please
Other Hindi song, okay. Please play the other Hindi song.
Yes, yes.
गले की भी हंसी रात हो न हो, शायद फिर से जन्म मुलाकात हो न हो, लग जा गले की भी हंसी मुलाकात हो न हो, लग जा गले। नसीब में ही बात हो न हो, शायद फिर इस जन्म में मुलाकात हो न हो, लग जा गले। बार बार സൈകത ഭൂമിയിൽ നിന്നു നീ പ്രണയപ്രവാഹമായി വന്നു. അതിഗൂഢ സുസ്മിതമുള്ളിലൊതുക്കുന്ന പ്രഥമോദ ബിന്ദുവായി തീർന്നു. ഹിമശൈല സൈകത ഭൂമിയിൽ നിന്നു നീ പ്രണയപ്രവാഹമായി വന്നു. അതിഗൂഢ സുസ്മിതമുള്ളിലൊതുക്കുന്ന പ്രഥമോദ ബിന്ദുവായി തീർന്നു. നിമിഷങ്ങൾ തൻ കൈക്കുടന്നയിൽ നീയൊരു നീലാഞ്ജന തീർത്ഥമായി. പുരുഷാന്തരങ്ങളെ കോൾമയിൽ കൊള്ളിക്കും പീയൂഷവാഹിനിയായി. പീയൂഷവാഹിനിയായി. എന്നെ എനിക്കു തിരിച്ചു കിട്ടാതെ ഞാൻ ഏതോ ദിവാസ്വപ്നമായി. ബോധമബോധമായി മാറും ലഹരിതൻ ശ്വേതപരാഗമായി മാറി. കാലം ഘനീഭൂതമായി നിൽക്കുമക്കര കാണാക്കയങ്ങളിലൂടെ. എങ്ങോട്ടു പോയി ഞാൻ എൻ്റെ സ്മൃതികളെ? നിങ്ങൾ വരില്ലയോ കൂടെ? നിങ്ങൾ വരില്ലയോ കൂടെ? ഹിമശൈല സൈകത ഭൂമിയിൽ നിന്നു നീ പ്രണയപ്രവാഹമായി വന്നു. അതിഗൂഢ സുസ്മിതമുള്ളിലൊതുക്കുന്ന പ്രഥമോദ ബിന്ദുവായി തീർന്നു. പ്രഥമോദ ബിന്ദുവായി തീർന്നു.
Hello, hello all. No. Yeah, Gurmeet.
Yes, ma'am.
Yeah, no, it's okay. Let's finish this. No need to play the other song.
Okay, ma'am.
Yeah.
Thank you to all those who have stayed back to listen to the culturals. I've been seeing a lot of people have taken interest and a lot of attendees and panelists in the participants list. A special thanks to all who stayed back to enjoy the culturals.
Thank you all. Hope you all enjoy our programs. And I think time is too late for us to continue this. So let's go back and take rest and see you all tomorrow morning for our continuation of academic program. Thank you and good night.
People who are around will be organizing can probably stay back for tomorrow's to discuss some of the strategies for tomorrow as it was yesterday.
Okay.
Bikram is there?